Mrs. Aarti, can we start?
Yes, sir. So, sir, it's 3, 2, 1. You are live now? Over to
Dear friends and colleagues, good morning to you all. First of all, let me thank each and one of you for being part of this conference. I'm very excited and honored to be hosting our very first National Conference of Indian Ophthalmic Anesthesiologists. As you all know, we wanted to host this as a face-to-face conference. However, due to the ongoing pandemic, our world has become virtual. I don't know how many of you know this, but this year is particularly special for us here as Giridhara Institute celebrates its 25th year of service. Before we get started, I would first like to invite our guiding force and our inspiration, Medical Director Dr. Giridhar, to kindly say a few words. Sir, you're mute. Unmute, sir.
Yeah, thank you, Sumana, for this opportunity. Actually, I'm very delighted to be here. And at the outset, I would like to congratulate the anesthetists who have dedicated their professional lives in ophthalmology. It's a very proud moment for all of you because you're organizing the first ever national conference of ophthalmic anesthesia. Actually, when Dr. Pushpa requested me to say a few words on this occasion, I was reminded of my early years in ophthalmology. Way back in 1983-84, when I was in Shankar Netralaya, Dr. Ayan Sundar Raj was a sole anesthetist, full-time anesthetist in Shankar Netralaya. So probably he is one of the first full-time anesthetists who dedicated his professional life to ophthalmology, at least in the quasi sector. And I'm sure for him, it's a very proud moment when 40 years later, you guys are having the first national congregation of ophthalmic anesthetists. It's indeed a proud moment. What I would like to say on this occasion is basically 3 important points I would like to highlight here, which I think you as ophthalmic anesthetists or anesthetists dedicated to ophthalmology should do in the years to come. One is to create awareness among your anesthesia fraternity about your contribution. B, the development of ophthalmology itself as a multidisciplinary specialty, and what role you as anesthetists have played in the growth of ophthalmology in the last 30 to 40 years. I was reminded of a surgical case that was operated in our institution just a couple of weeks ago, a blast injury, where the oculoplastic surgeon repaired the large lid tear, the corneal surgeon repaired the corneal injury, the vitreoretinal surgeon simultaneously looked into the posterior segment. So it was a multidisciplinary approach that went on for 4.5 hours. And that is what today is ophthalmology. And that is what is your contribution to development of ophthalmology and the importance of anesthesia in ophthalmology. Ophthalmic anesthesia has come a long way in these 4 decades, and probably your scientific deliberation will look into those aspects. But nonetheless, it's important for you all to document, because now you have formed the first national conference. You're trying to form an independent body of anesthetists who are contributing to ophthalmology. It becomes very important for you to trace the history of your specialty, because this becomes important for the future generations. 23 years from now, when your organization is going to celebrate its silver jubilee, documentation becomes very, very important. The reason why I'm saying this is I was very active in the Vitreous Retina Society for many years, and I'm also the past president of the Vitreous Retina Society, and had an opportunity to host the 25th Silver Jubilee Conference, wherein I tried to document the history of the specialty in India, and I found it very difficult because documentation was very poor. Finally, I thank this group for giving us this opportunity to host the first national conference in a very important year in the history of this institution as we are entering the 25th year. I sincerely appreciate the contribution that you people have made in the last many years. And I take this as a great opportunity for our institution to organize this meeting. And years ago, we organized probably one of the earliest OFISA-Con conference, which set the ball rolling. And probably that was the turning point, if I may say so, if you have to trace the history of ophthalmic anesthesia in India. Friends, with these few words, let me declare open this congregation, the first national conference of Indian ophthalmic anesthesiologists for scientific deliberation, fellowship, useful interaction, and a bright future. Thank you all.
Thank you, sir, for those warm words of welcome. Over to Sumana now to start the scientific session. I hope all the speakers have logged in for the morning.
So we will start off with a regional anesthesia, which is being chaired by Dr. Marian Pauly. She is the senior consultant and head of oculoplasty, orbit, ocular oncology, and ocular prosthesis in Giridhar Eye Institute. So first, we'll start with Dr. Tanvi Samra, who will be presenting preoperative systemic evaluation for cataract surgery from PGI Chandigarh.
So good morning, everybody. I hope I'm audible. So first of all, I would like to congratulate the organizing committee of the first national conference of the Association of Indian Ophthalmic Anesthesiologists. And I would thank you for giving me the opportunity to be the speaker for the first talk, which is the preoperative systemic evaluation for the cataract surgery. Now, the importance of the topic can be estimated by knowing that 51% of blindness in India is preventable and is due to the cataract. So keeping this in mind, the WHO, along with the International Society for Prevention of Disease, Blindness in 1999, came up with the concept of the Vision 2020. It is the Right to Sight initiative, and with the main aim to intensify and accelerate various measures to eliminate this avoidable cause of blindness by 2020. You can estimate the burden which we have by knowing that at present there are 6,000 cataract operations per million people per year, and we still have to upscale to up till 8,000 to 8,700 so that we can eliminate blindness and achieve the goal of Vision 2020. So coming to my talk, first, when it's very important to address cataract in the two different age groups. The first age group that we come in pace with when we talk of cataract is the pediatric age group, and the second age group is the geriatric age group. Going through the scientific program, you will know that we are dealing with the pediatric age group in the afternoon sessions. We have a talk by Dr. Renu, who's going to be talking about the management of the syndromic child. And we're going to be having a talk by Dr. Geeta, who's going to be talking about the retinopathy of prematurity. Thus, my today's talk will be focusing on the cataract for the geriatric patient. Now, as soon as we get a geriatric patient for pre-operative evaluation, we know that we are dealing with a subgroup in which 57% of them will be having any pre-existing medical problem. But the most common mistake which our residents do is that they think that they don't have to, be very vigilant, because at the back of the mind, they have it that is going to be performed under the regional block. So the main emphasis of my slide over here is that although they are going to be done under local anesthesia, they're going to be done under regional blocks. The most important reason why they come to us for a pre-operative evaluation is for us to identify the difficult cases and to identify the high risk cases. So as we go through the slides, I will be telling you how to identify the difficult and the high risk cases which need perioperative optimization. So whenever we do a pre-operative evaluation, we have certain objectives in mind. The objectives are the identification of the problem, then the estimation or assessment of the risk, perioperative risk which the patient has, and the most important goal is to optimize the patient as much as is possible pre-operatively. The history taking, the physical examination, a review of all the investigations that the patient has undergone helps us to come to a definitive decision making, and then after taking patient consent, to chalk out our anesthetic plan. So coming to the first, that is the history taking. Now, whenever we do history taking for an elderly, we have to specifically ask about each systemic illness, whether it is a cardiovascular, whether it is the respiratory, whether it is endocrine, or any other neurological complaint which the patient can have. Before starting the history taking, you have to keep 3 or 4 pointers in your mind. The first thing is that you are dealing with a geriatric patient. Now, a geriatric patient may not be very communicative. They have some amount of, memory loss. They are slow in their reflexes. So whenever you take a history of a geriatric patient, it is very important for us to be very patient. You have to give time for the patient. They generally are having a systemic illness for many, many years. And sometimes during the history taking, they do not give value to certain aspects which may be of relevance for the anesthesiologist. Second, it is important after the history taking to go through all the other medical cards, medical reports, or any other reviews which they have undergone, any other medical testing which they have undergone, because they might have missed certain very important points. The third is that it is very important to have a primary caregiver who knows very well about the patient along with the elderly. So these are the important points when you are asking in the history. Now, as we know, the most common systemic illness which the elderly have is pertaining to the cardiovascular system. Hypertension is very common in the elderly. Any systolic BP which is more than 180 or a diastolic more than 100 is unacceptable for any kind of surgery. Once reading has to be repeated in the PSC clinic twice and thrice with the patient in a little relaxed, because first reading which you take of the blood pressure could be generally because of the stress the patient is having, the anxiety the patient is having. But hypertension has to be looked for. The second is a history of ischemic heart disease. So any history of coronary angiography which the patient has undergone, any history of angina attack which the patient has, any history of revascularization procedure the patient has undergone should be taken very meticulously. All signs and symptoms suggestive of cardiac failure like orthopnea, any chest pain should be asked for. History of arrhythmias, any history of insertion of a pacemaker or any other valvular problem has to be looked for. As I have already told you that these are very important, because sometimes the patient has undergone a revascularization procedure many, many years back. So it could be very much possible that the patient might have developed a thrombosis again, and the patient might be at risk of perioperative MI following the surgery. and surgery and anesthesia itself are very stressful situations. So the patient might land up in ischemic ECG changes on the table, and then we might land up in a problem. The most important thing that we need to know is that cataract surgeries are elective surgeries. So any patient who has undergone a revascularization procedure or has had a history of myocardial infarction in the previous 3 months is a complete no for surgery or anesthesia. So for cataract, minimum period you have to wait is for 3 months after the MI, and preferably it has to be 1 year or later. The other important aspect from the valvular diseases which we need to know is that because a cataract surgery is a very low risk surgery, so no antibiotic prophylaxis is required if the patient even has any valvular problem. Generally, elderlies, if they do not have any history, when they just do an echo, routine echo, it is very common to find aortic stenosis. So, and you know that when the patient has aortic stenosis, there generally are not any symptoms in the initial stages. So you don't have to worry for that, right? And no antibiotic prophylaxis is required with patients with known valvular pathologies also. The second important system which we have to look for is the respiratory system. COPD, bronchial asthma, any history of orthopnea needs to be asked for. Nowadays, in the present scenario with the COVID pandemic, we also want to know whether the patient has had any past history of COVID. Because what we have seen is that patients with post-COVID generally land up in some kind of a respiratory complication if they need to be intubated. So a history of whether a patient has had COVID in the past is to be taken up in the present scenario. Now, sleep apnea is one very important systemic illness which should be looked for a patient with coming for cataract surgeries. Now, we are fortunate enough that if you look into the scientific program, we have a separate topic on the what we should do for a patient with obstructive sleep apnea. So I will not be going into the details of it, as it is going to be dealt in the coming lectures, because a patient with obstructive sleep apnea sometimes has a problem in even lying on the OT table, and even if you have to give a little bit of sedation, you land up in an airway collapse. Then the other things which you really need to look for is a history of diabetes. Patients with diabetes are at a risk of intraoperative hypoglycemia, as they generally come NPO in the morning, and then they might land up having a fainting attack. Any history of epilepsy, any history of tremors is to be asked for and looked. Now, tremors are a big problem for a cataract surgeon, because the requirement for cataract is the patient should be lying flat on the OT table. Now, people in the elderly age group, they have a history, if they have a history of Parkinson's, they have some tremors, it becomes very difficult for the surgeon to operate, and this becomes one more indication for giving general anesthesia. Medication history is very, very important. Sometimes the patients are not able to tell us which drugs they are having. So it is always a good idea to tell your patient to bring whatever drugs the patient is having and show you when you're doing a pre-anesthetic evaluation. The important drugs which we really are concerned about are the antiplatelet agents and the warfarins. Because if the patient is on any antiplatelet drug and warfarin, your surgeon might not like to give any deep block because of the risk of bleeding. In that condition, again, there is more dependence on the anesthesiologist to give sedation to the patient, or probably GA if the need be. We have to advise the patient about the drugs, which drug to continue, which drug not to continue. Generally, for a cataract surgery, we do not stop any kind of medication. Whether to stop warfarin or any other antiplatelet drug, the decision of this has to be a combined decision, which has to be taken by the anesthesiologist, by your eye surgeon and by the cardiologist, keeping in mind the risk-benefit ratio. A history of allergy is never to be missed, and specifically the allergy to the local anesthetics is one which we are looking for over here, because it may preclude the block which the surgeon is going to be administrating for the ophthalmic surgery. So it is always preferable for the residents to have a pre-filled checklist. We generally follow different performers at different centers, and you should have a proper checklist, especially for the geriatric patient, because each and every system has to be asked for, and each and every system has to be evaluated, so that we do not miss out anything when we are going for the pre-anesthetic evaluation of the geriatric patient. Now, out of all the systemic diseases which we have done, it is always the cardiac patient who, when operated for a non-cardiac surgery, is a dilemma for the anesthesiologist, especially for the residents. Whenever we are doing a pre-operative evaluation for a cardiac patient, the diagnostic modalities and the various further evaluative echo or the angio or whatever we ask for, there is a big range of them. But whenever you are doing risk stratification, the foremost thing when you are doing for a cataract surgery to be kept in mind is that it is a very low risk surgery. So that is one thing which always has to be kept in mind, that we are already dealing with a patient who is at a lower risk. So instead of going for very detailed investigations like echocardiography or a stress testing, it is very easy if the resident takes into consideration the functional capacity of the patient. One more very important thing which has to be kept in mind when we are talking about the functional capacity in geriatric age group is that geriatric patients, they are a very diverse group of patients. One, the chronological age generally does not match with the physiological age. There are some elderlies who are chronologically very elder, like they might be 80 years or 70 years. And if you see them physiologically, they either match their age or physiologically they may be better than their age. On the other hand, we can have people who with a chronological age of 60 years, but physiologically they may be as a person who is maybe in the 70s, the person maybe who is in the 80s. So the functional capacity is the only thing which helps us to tell whether our elderly, his chronological age matches his physiological age, or is he worse than that, or is he better than that. Now for an elderly, if you just take a history of whether the patient can, just climb one flight of stairs, or whether he can just walk around in his house and he can do his activities of daily living, it is enough for the anesthesiologist. So a lot of importance should be given to the functional capacity of the patient. Now this picture which I'm showing is not new to anybody. This is the most important chart which we always refer to when we have to do the evaluation of the cardiac patient for a non-cardiac surgery. As I have already told you in my previous slide, we are dealing with only the elective groups over here when it comes to the cataract. We do not have any emergency. So there is no hurry for us to take any unoptimized patient. The second important thing which has to be kept in mind is we are dealing with a low risk surgery. As I told you, it is a cataract surgery, it is a low risk. So we will not go for any fancy testings or any estimations of the stress test or the echocardiographic finding or the LV function or the RV function of the heart. So we don't have to burden the patient with extensive investigations, right? And if the third important point which needs to be noted is any patient who has a good functional capacity is a good patient to give anesthesia, and no further testing is required in that patient. So the three important things which you always have to keep in mind is that a cataract surgery is an elective surgery. It is already a low risk surgery. And if the functional capacity of your patient is very good, then you don't have to go for any extensive testing. When do you go for an extensive testing of the cardiac patient? Is when the patient has features of heart failure. He has got features of worsening dyspnea over time, right? If the patient has an unknown functional capacity, you have a patient for cataract who doesn't walk much, who's generally bedridden, right? Then is the only condition where you would like to go for a detailed cardiovascular evaluation. Otherwise, a basic evaluation is enough for the cataract surgery. Now, till now, we have discussed about the systemic illness in the preoperative evaluation. We have gone through each of the systems, but there are other important logistic issues, other ergonomics which have to be kept in mind when we're doing the PSE. First, the patient's ability to lie in the appropriate position for the operation. Although the duration of surgery is very, very small, but even for that time, the patient has to lie still. So any patient with Parkinson's tremor, any patient who has got a history of cough. Now, history of cough is very common in the elderly who have gastroesophageal reflux disease. You might, when you do the geriatric PSEs, you will come across patients who will tell you that in the night, whenever they lie down, they have dry cough, they have chronic cough. Although these elderlies are on some, antacid or, these receptor blockers, they are on histamine receptor blockers, but still the cough which they develop is a problem for the cataract surgeon. Second important point is deafness. Generally, the elderlies, they have some amount of sensory neural deafness, but in some patients, it is very, very severe. In that case, you may not be able to communicate with the patient, and the patient might not be able to tell you whether he's experiencing pain, he's experiencing any other kind of discomfort during the surgery. Some patients who have dementia, who have some amount of delirium, they may not be able to comply with your preoperative instructions and will also not comply with you on the operating table. So such patients are also problematic patients. Some patients are not suitable for daycare, like a patient who is on oxygen, supplemental oxygen therapy, a patient whose sugars are uncontrolled, a patient who has to be watched for perioperative MI. So you should know whether a patient is suitable for daycare or not, and then you need to tell him in the PSE itself to get admitted one day prior to surgery. Again, I'm emphasizing, because the entire cataract surgery is based on giving local anesthetics. It is very important to elicit in the history itself any previous adverse reaction or any problem which the patient might have had when in the past the patient might have been given any kind of regional anesthesia. So this we were doing was the systemic evaluation and the patient evaluation. After doing this, it is very important for us to assess the surgeon's requirement for the cataract surgery. So there is a term which is called as a high-risk eye. Generally, all surgeons want to give either topical anesthesia or a regional technique for the cataract surgeries. A full general anesthesia or a monitored anesthesia care or sedation with the help of dexmedetomidine, fentanyl, etc. is not the first choice. But there are certain conditions of the eye which preclude the ophthalmologist from giving a regional block. For example, is an eye which has got a high intraocular pressure. It is known that all regional anesthesia techniques have the capability of raising the intraocular pressure because you are giving some amount of volume into the eye. So a surgeon might not want to prefer a regional technique and may ask you to do a PSE and give anesthesia in patients which have got high intraocular pressures. Sometimes a patient has already lost one eye in the past, and this might be the only eye, or it might be the only visually effective eye which the patient has. In such case, again, the patient and the surgeon again might not want to give a local anesthetic into the eye, and they might want a either MAC, or they might want some amount of short GA. There are some operations in which the eye needs to be open. There are some eyes which have a staphyloma. It is nothing but it's a, it's an outpouching from the globe, which is a staphyloma. In that cases also, they would like to avoid giving regional anesthesia. And patient with raised INR. Now, giving any kind of block with a needle has the risk of causing bleeding, especially in patients in which there is some amount of coagulopathy, in which the INR is raised. And in such patients, there can be conditions where you might not want to stop the antiplatelet drugs or the anticoagulants also prior to the surgery. So in such cases, again, a general anesthesia is preferred rather than giving a regional block. So for the anesthesiologist, it is very important to identify these kind of high risk eyes, so as to know that whether the surgeon will prefer a GA or prefer a regional anesthesia technique for the particular patient. So after all the history taking, a detailed systemic examination is a must. I will not go into the details, but you have to look for the cardiorespiratory, neurological, respiratory, and general physical examination. So after the systemic examination, airway has to be, evaluated in detail. Most of the time, what the residents generally do is they presume that because we are not giving general anesthesia, they just do a very casual look at the airway. And then sometimes on the table, when the patient is uncooperative, or when the block fails, or when the surgeon expresses his desire not to put a block and you need to intubate the patient, you land up realizing that there is some amount of cervical spondylosis and the patient has a flexion deformity of the neck, the patient is not able to lie flat on the OT table, or has a small mouth opening, or has a very poor Malampatti grade. So it is my advice for all residents that whenever, even if you are asked for a patient for a PSC, for probably a MAC, it must be a habit of yours that you have to go for a detailed airway assessment. And again, we all know that from the mnemonic lemon, how we will quickly evaluate, and how we will do a detailed Malampatti scoring, in which we can always find out the class 1, class 2, class 3, class 4. And as you all know, whenever you are asking the patient to open his mouth, the patient should be in the sitting position. Do not ask the patient to lie down and then just do an airway assessment in the lying position, right? You have to see for the neck mobility. You have to assess, especially in obese patients, the neck circumference, and you should be prepared for the difficult airway. Now, after we have done the history taken and we have done the physical examination, the most...
Sorry to interrupt, Dr. Tanvi.
Yeah.
How much more do we have of this?
3 slides. 3
Okay.
slides.
Okay.
Yeah.
Okay. Thank you.
Then we have to decide about the perioperative medication. It is advisable that all beta blockers to be continued. Continuation of the ACE inhibitors and the angiotensin receptor blockers. And as I had discussed previously, the management of the antiplatelet therapy has to be a consensus of the surgeon, the anesthesiologist, the cardiologist, and this. Now, those cases which definitely have to be cancelled and are not fit for cataract because it is an elective are those who have had a recent exacerbation of COPD with poorly controlled angina, prior history of MI in the 3 months, hypertension, as I told you, systolic BP more than 180, diastolic more than 100, inappropriately low blood pressures with uncontrolled atrial fibrillation, a bradycardia probably because of excessive beta blocker therapy, or an undiagnosed complete heart block. Patient with decompensated cardiac failure, pacemaker failure, inappropriately high INR, poorly controlled diabetes, epilepsy, or sepsis. We will cancel all the case and wait for optimization. So after giving approval for the anesthesia, the plan for giving either GA or regional has to be made. In the next talk, Dr. Diwan is going to tell you how to choose the needle versus the cannula versus the topical. Any questions which you have, we can have it now or at the end of the session. Thank you so much.
Oh, thank you so much, Dr. Tanvi. I just have 3 small announcements to make. One is please post your questions on the chat box, and the chairperson will announce them at the end of the session, not after every talk. The second thing is these sessions are recorded, so just keep that in mind. And the third thing is kindly stick on to your timing, your allotted timing, which is under 15 minutes. Thank you so much. Now we can have Dr. Rasesh Diwan, who's going to speak on needle versus cannula versus topical anesthesia. Thank you, sir.
Is my screen shared? Hello?
Yes, yes, yes. Yes, it's done.
Am I visible too?
Yes, yes.
Thank you so much. And it's a great pleasure. First of all, thanks to Dr. Giridhar for inviting all of us and organizing this first National Ophthalmic Conference. And President Sir, Dr. Parak Sir, and all the office bearers, it's a great pleasure to be participating in this symposium today. In fact, it's a very critical situation many times, which Dr. Tanvir mentioned, to assess the patient and select the right patient. Similarly, sometimes in some difficult situations is to select the right technique for the regional anesthesia also. It becomes a dilemma. So what I intend to talk into how to choose needle versus cannula versus topical, as the topic has been given to me by Dr. Jayachandran. Thank you, Jayachandran. It's a topic which I love the most. Basically, we have this armamentarium of ophthalmic regional anesthesia. The needle blocks, of which retrobulbar anesthesia, peribulbar anesthesia, or extracorneal, or recently, which has been added, is the medial canthal block. Among the cannula, we have subtenons, which been in practice for many, many decades. And last one, which is topical anesthesia, which came up in last 20-25 years. So this is what the armamentarium we have. And we have to know the factors which will help us how to select the right technique for the right patient and for the right surgery. So my objective is to talk about the features of each technique. I'm not going to teach you the technique, but the salient features of each technique, the advantages and disadvantages, the factors we need to consider for selection of the right technique, which depends on the type of surgery, and patient-related factors, which all factors Dr. Tanvir narrated very well, elaborately in her first lecture. Now we have, as I said, this armamentarium with the different different techniques of regional anesthesia, of which the needle blocks, which are being existing for almost, I would say, 80-90 years. It started long back in early 90s. And in which the retrobulbar technique, which has come as a first regional anesthesia technique in ophthalmology and served the decades for 60, 70, 80 years, and even today some people practice it. This was taken over by peribulbar technique or extracorneal block in almost in last 1980s or 88 or 89. It became popular everywhere in the world. And the last one, which was added recently in last 5-6 years, was the medial canthal block. But all are needle blocks that you must understand. The advantage of needle blocks are the excellent analgesia, good echinacea, adequate duration of anesthesia, which is many times necessary in long vitreoretinal surgeries. But the disadvantages are they are painful and scary. You just imagine I am standing on your head like this, with about to poke the needle in your around your eye. There are local and ocular complications, which you're going to cover today by 2 lectures by Ravichandra and Lakshmi. We're going to cover these complications. But the dreaded thing is it's a needle. In both, you are poking a needle, which is carry the risk of blind sharp needle insertion in the orbit and the structures which you are not showing can cause a lot of either local or systemic complications. And that is the only problem of these needle blocks, over and above the pain and scare, which can be taken care by counseling and proper sedation preoperatively. And particularly intracorneal block may need an additional lead echinacea, where we used to practice to give a facial nerve block in every patient. Subtenos block is a much safer, done with the blunt tip. There is no sharp needle, and it's a curved cannula. I'm not going to talk about the technique, but the advantages are there is a minimal pain because it is being done under topical anesthesia technique with placing the speculum. It gives excellent analgesia, no sharp needle complication, very safe for particularly myopic eyeballs. As Dr. Tanvil mentioned, we need to have the good preoperative assessment of the eye before we take up the job of giving regional anesthesia. High myopic eyeballs may have staphyloderma, particularly when the axial length is more than 27, 28. It can be repeated even during surgery. Some complicated repeat surgeries of vitreoretinal cases, we cannot give general anesthesia. We can repeat this during surgery also. But the disadvantage is, particularly for anesthetists, is it requires a little surgical skill. It's not suitable for repeat VR surgeries. We have a talk by Dr. Frederick on the buccal case has been done, and you want to give the subtenons, but I'll be scared to put a cannula when there is a buckling done in such cases. So you have to be very skeptical. There is a variable echinacea. It's no surety of giving good echinacea. So in a very uncooperative patient, sometimes the eyeball is moving. Systemic and local complications are similar to the intracorneal or extracorneal blocks, but they are of the less magnitude and less in incidence. The topical anesthetic technique, which picked up very well in late last century, by 1988, 1999, this was very popular among, particularly for the cataract surgeons. Practically, it's a very non-invasive procedure. The advantages are no needles, no apprehension, no fear, very quick onset, can be supplemented during surgery also if by chance it lasts a little longer, and no orbital or systemic complications. But the disadvantages are not suitable for all surgeries. Not all surgeons are compatible. There is no echinacea, so we are dependent on the patient's understanding, patient's cooperation, and patient's education done well with counseling preoperatively. Some patients do complain of visual perception and they are disturbed about that. So best is we have to do a very good preoperative counseling and sedation with monitored anesthesia care. Dr. Shalini is going to talk about that, so I'm not going in detail of those things. In my practice, in our place, our 85-90% cases are topical anesthesia. I mean, say 95+% we do on the topical anesthesia with good monitored anesthesia care and excellent counseling done preoperatively. So most of the cataract surgeons in the world have started preferring topical anesthetic technique because it gives a very good eye field postoperatively. Like in some tenors, sometimes there's a subconjunctival hemorrhage, there's a scar, there's a dry eye syndrome, sometimes postoperatively for lasting for some time. And patients see a little hemorrhage and they keep on complaining about that. So now I go in the detail, which type of surgery and your selection of technique. Say cataract surgery. Most of the surgeons prefer topical anesthetic these days, and they supplement the little bit of inadequate anesthesia by intracameral lignocaine. It's the most popular technique today, very well accepted by the patients. Even training doctors also adopt this very well, but you need very good counseling and sedation to complete the lacunae of the technique. However, some cases, some factors related to the surgery or related to the patient, if you are not able to do with the cataract surgery, where your prudence comes and you can go for the either subtenons or needle blocks. The caution is complicated cataract. Suppose there is iritis, a lot of synechiae, very small pupil. There are combined procedures. Sometimes some people want to do additional vitrectomy along with there, or some scleral fixations is necessary, or there's an unstable dislocated lens. All these are not the cases for topical anesthetic. If there is a language barrier, Dr. Tanvir also mentioned this, hard of hearing, she also mentioned this, and uncooperative, hyper-anxious patients with dementia. All this you know with your good preoperative assessment. I would not jump for topical anesthetic. I would go for subtenon's block and needle blocks. These are much safer because our aim is not to be egoistic and do on the topical, but your aim is to give a visual outcome nearly 100% without any per-operative eye complications. Glaucoma surgeries. Nowadays, it is safely done with the subtenon's block if it is not very complicated. But if you are not versed with that, you can select the needle blocks. But I know few surgeons doing glaucoma surgeries, and in my institution also, they do with topical anesthesia by rotating the eyeball down with an 8090 nylon, pressing on the limbus and rotating the eyeball, fixing it in one position. So, and with little of sedation and analgesic intravenously. But glaucoma surgeries, if it is there, if the surgeon is not comfortable with topical, I would rather recommend subtenons or a needle block. Many of the patients where there's an implant placement or revision glaucoma surgeries, and there are open globe techniques where it are not feasible for topical, as well as sometimes giving needle blocks also raises the intraocular pressure is little difficult. So these are the cases, probably subtenons in revision surgery is a good choice. However, simple surgeries can be performed in a good cooperative patient with the topical instillation. Vitreoretinal surgeries, of course, topical is out of question. There are long duration surgeries, echinacea is must, profound analgesia is must. So we prefer needle blocks. Combined with intra or extracorneal blocks is another safe technique where you get the quick onset of the block, very good echinacea, and very good lasting block also. Some people I've seen doing simple vitrectomies with subtenon's block. But if you're going to pull the muscles and rotate the eyeball too much, probably this doesn't block the oculocardiac reflex. We have a lecture on the reflexes today, but this is where probably safely done needle blocks are preferred. Squint, of course, we do only in adults. The establishment surgery is under regional anesthesia. We need profound anesthesia, we need echinacea, we need prevention of oculocardiac reflex, and post-operative analgesia also. So these are better preferred with the needle blocks, and we do regional anesthesia in patients who are adults, and are in adolescents who are very cooperative with some sedation, who are above 14-15 years of age. So the choice of regional anesthesia technique would depend on the magnitude and the problem of the surgery. It could be complex cataract surgery, or it could be vitreoretinal, anything. The complexity of the eye, a simple cataract surgery can be done with topical, but complexity of the eye with iritis or adhesions or a lot of synecdoche are to be preferred under regional blocks other than topical anesthesia. Now, most important is the comfort of the surgeon and the comfort of the patient and compliance of the patient. Now, if surgeon is not comfortable with topical, we do give needle blocks in our institution. Or a trainee doctor who is a beginner for the capsulorhexis, we prefer to give the topic instead of topical, we give them needle blocks. So these are the factors which are responsible where we have to consider for selecting the right choice of regional anesthesia. If I tell 3 blocks, the needle blocks, we need profound anesthesia, it gives good echinacea and adequate duration, suitable for all surgeries, but carries the risk of serious complications of putting a needle blindly in orbit, which carries risk of either local serious complications or systemic complications. Subtenons is as it gives substantial analgesia, but little echinacea. Sufficient duration you can provide with this. However, suitable for cataract and glaucoma surgery and lesser complications, which is a technique which anesthetists must learn, though it involves a little bit of surgical technique. The topical anesthesia gives moderate analgesia, no echinacea, patient cooperation is must, which you can extract more by counseling and sedation, and is being widely used by cataract surgeons today because it has the least complications. So what your choice should be, depending upon the type of surgery, the type of complexity of the eye, surgeon's comfort, and compliance with the patient, and very good pre-anesthetic assessment, counseling, and sedation, which will help you to change from subtenuous to topical, or sometimes, depending on the factors you are recognized in your preoperative, from topical to needle blocks. So this is how every patient needs a very good pre-anesthetic assessment, understand the modality of the surgeries, understand the surgeons, and select your choice. So that is what my summary was. Thank you so much. And I request all anesthetists, please register for ISACON 2021. I am the organizing chairperson for this meeting, which is happening on 25th to 28th November 2021. We also have an ophthalmic forum where all of us, many of us are in as a faculty. Dr. Jayachandran has already given the program, has been approved by the scientific committee. Please register for this conference. It is a hybrid conference, and we are going to have a lot of virtual registrations. In short time, the program will be on the website. Thank you so much.
Thank you, Dr. Ashish.
Thank you, sir.
Yeah.
Next, we would like to call Shalini Subramaniam to talk on sedation and monitoring of cataract surgery.
Good morning. Can you all hear me? Hello.
Hello.
Good morning. Yes, we can hear you.
Good morning.
Yes.
Oh,
Yeah.
hello. Good morning. Greetings from the Garden City of Bangalore. And my topic for today is sedation and monitoring in cataract surgery. Starting off with a few words from history, when more than half a century before, sedation for ophthalmic surgery, including that for cataract surgery, was in the form of twilight sleep, where a cocktail of drugs like chlorpromazine, promethazine, pethidine were given. They provided excellent sedation and immobility, but the patient continued to remain sleeping for 6 to 10 hours postoperatively, did not void urine for 20 to 24 hours, and a few of them even developed respiratory complications in the immediate post-op period. And moving from there to the current era of monitored anesthesia care, which is a deliberate choice of anesthetic technique in 10 to 30% of cataract surgical patients, where they are given the benefit of perioperative care by the anesthesiologist, starting from pre-procedural assessment and optimization of pertinent medical conditions, intra-procedural care, and post-procedure management until discharge from the hospital. So sedation and monitoring just provide one portion of this entire bundle of services about which we will be talking about in the next few slides. So the goals of sedation in any patient requiring it as part of monitored anesthesia care is safe sedation, anxiety control, and pain control. But particularly in the cataract surgical patient, our goals will be to have a comfortable and cooperative patient who has no undesirable or sudden movement of the patient, especially of the head, and to ensure patient and surgeon satisfaction. Cataract surgery as such is a low risk surgery with very less pain. Nevertheless,
Madam, I'm sorry to interrupt you. We can't see the slides.
Oh, one moment. Haven't I shared screen? One moment. I thought I have shared screen. Is it seen now, ma'am?
No. Sorry.
No,
Okay.
madam.
I have shared the screen.
Dr. Shalini, you have to share your screen.
Yeah, I have shared the screen.
Okay,
sir.
now
Okay,
it's coming.
now it is coming. Okay.
Okay. Yes. Is it good to go?
Yes, yes.
Yes, yes.
Okay, so the cataract surgery, though it is of low risk and causes minimal pain, it would be good to identify the cataract surgical patient who requires monitored anesthesia care. And this screening is best done at the ophthalmologist clinic or his OPD. He could take the help of his counselor, nurse, or optometrist, or any kind of a checklist to identify those patients who would benefit by an anesthesiologist consultation and monitored anesthesia care during the surgery. There are certain patient factors which would help identify these patients. This includes those with multiple comorbidities, poorly controlled systemic illness, ASA 3 or higher grade, the old frail patient, the morbidly obese ones, the ones with obstructive sleep apnea, and of course, the anxious and fearful patient. It has been shown that anxiety and fear exist in more than 1/3 of cataract surgical patients. Most often, it is the fear of blindness, and around 20 to 25% it is the fear of pain or the expectation of painlessness, and in around 9 to 10% it is the fear of death. And if any patient expresses such fears, it would certainly help them to have a reassurance and anxiolysis prior to the procedure. It is important at this stage also to identify patients who cannot lie down immobile or lie supine or who have claustrophobia. There are also a few surgical factors which would probably help the surgeon identify a patient who would benefit by monitored anesthesia care. If he is expecting a little more than the usual uncomplicated cataract surgery, say with poor dilatation of the pupil, a hard cataract, or a patient with a single seeing eye, or patients who had a stormy postoperative period after the first eye surgery, or if they did experience any frightening visual sensations during the first eye surgery, which they did mention, then such patients would also benefit with monitored anesthesia care. So the ASA has defined these the continuum of levels of sedation, from minimal sedation or anxiolysis, where we have an awake, calm and tranquil patient, and this is the state that we would want most of our cataract surgical patients to be in. The next level is moderate sedation or conscious sedation, where we have an asleep patient who still responds, however, to calling his name or to a simple tactile stimulation or touch. But however, these levels of sedation are all in continuum with each other, and they could easily drift from one stage to the other. And that is why there is the need for the constant presence of an anesthesiologist when administering such sedation. Well, before we actually go to the techniques of sedation in the cataract surgical patient, I cannot but impress on the importance and usefulness of several of these non-pharmacological maneuvers. The average age of the cataract surgical patient in our country would be around 65 to 68 years, and they would all benefit with a patient listener. It would be good for our center to have a robust counseling team that would give them a lot of reassurance in the preoperative period, including telling them about what to expect on the day of surgery, and a few educational videos can also be made. It's also good to optimize waiting time so that it is neither too less that they feel hurried on the day of surgery, nor so long that they become nervous and scared. Playing soft music in the background, ergonomically positioning them during the surgery with blankets or a pillow under the knee would also help. Keeping the hearing aid on certainly helps, as it helps them have control over what is going on in the surrounding by virtue of the auditory input that it provides. It also greatly helps to speak the vernacular, if possible, to reassure the patient. But even if that is not possible with several international patients or patients coming from other parts of the country to our city for cataract surgery, the patient always understands the universal language of love. And I mean, the technique of hand holding, it actually has to be done and experienced to understand the benefit it actually provides to the anxious cataract patient. Maintaining intermittent verbal contact is not only reassuring to the patient, but also helps in monitoring the depth of sedation if any sedative agent has been administered during the procedure. Well, going on to the various pharmacological methods and techniques that are available with us, I would dwell on the more practical points with regards to the techniques. The usual routes available that are used are the oral and intravenous, though intranasal and sublingual routes of administration or sedation for anxiolysis are also available. Going on to oral sedation, the usual or the most commonly used drug are benzodiazepines, either oral alprazolam or oral midazolam on the morning of surgery. Other drugs like gabapentinoids, alpha-2 agonists, and melatonin have also been used. The advantage of oral sedation is its low cost, ease of administration, very good patient acceptability, and it has also been found to be non-inferior to intravenous sedation if the end point is anxiolysis as assessed by a patient satisfaction score on the first postoperative day. The demerits of oral sedation are that it has unpredictable bioavailability and onset of effect, and we do lack precise control over the level of sedation that it provides. Moving on to the drugs and doses of the various intravenous drugs available, the first class is benzodiazepines, and the most preferred benzodiazepine is intravenous midazolam. The dose ranges from 0.01 to 0.1 milligram per kg, depending upon whether it is used as part of the balance technique or a sole agent to provide anxiolysis. The advantage of midazolam is that it provides excellent antegrade amnesia. So that in fact several patients when interviewed on the first post-op day and asked about what was the most painful part of the entire cataract surgical procedure actually replied under intravenous midazolam sedation to replied saying that it was placement of the intravenous line. But one needs to remember that it can worsen cognitive dysfunction in the already confused patient, and in a few of them there could be a paradoxical reaction due to loss of inhibition. Propofol, the intravenous anesthetic agent propofol can be administered either as intermittent boluses of 10 to 20 milligrams or an initial bolus followed by an infusion at 2 to 6 milligram per kg per hour, depending on what level of sedation we want, which is my minimal sedation in our case. Also, people have used patient controlled sedation with patient controlled boluses of propofol or set up a target control infusion. This drug is most effective in reducing recall, but one needs to remember that propofol has no analgesic effect, and there could be sudden unexpected patient movement while administering a needle block under propofol sedation. And so this has to be remembered as well. If only a single bolus has been administered, then once they wake up from propofol sedation, which may be any time between 3 and 10 minutes after the first bolus, they could have a sudden jerky patient movement, and that could happen intraoperatively and could prove counterproductive. The other offset of propofol sedation, which is unique to ophthalmic anesthesia, is the sneezing reflex. This has been described with propofol sedation used mostly in oculoplastic procedures where patients have drifted into a deep level of sedation and during eyelid infiltration have had a sneezing reflex continuing for any time between 1 to 5 minutes, though this could also happen under peribulbar block, and that is why several authors now actually use propofol along with another drug like either phentermine, dexmedetomidine, antihistamine, or midazolam to offset this sneeze reflex. Opioids, short-acting opioids like remifentanil, fentanyl, or alfentanil have all been used with excellent patient satisfaction by virtue of their analgesic property. The use of opioids is best given just before administration of the block, because once a good acting regional anesthetic takes over, there is really no requirement of a potent analgesic like opioids. The other advantage of opioids to provide analgesia is that it could help in patients who have aches and pains in other areas of the body like low back pain or osteoarthritis, shoulder or neck pain. We do need to remember that opioids do not reduce the risk of recall or cause amnesia. Nevertheless, patients have said that they have felt comfortable during the needle block after administration of either remifentanil or fentanyl. Opioids come with natural property that the patient could easily drift into deeper states of sedation, respiratory depression, and desaturation. The next drug that I would talk about is dexmedetomidine, which is one of our favorite agents for sedation, anxiolysis, moderate sedation, conscious sedation in the operating room as well as outside operating room procedures. Its role in the cataract surgical patients, I really would not go beyond examining this systematic review that appeared in 2020 by Joan et al., where they have described 15 studies where they have used dexmedetomidine in the adult cataract surgical patient, either as a bolus or bolus plus infusion, or along with other drugs. They have reported that use of dexmedetomidine has provided superior analgesia and good operating conditions in terms of reduced intraocular pressure, a soft eye, and higher patient satisfaction. But it has been frequently associated with a fall, with a reduction in mean arterial pressure and heart rate, especially when administered as a bolus, though none of the patients actually required any intervention. The other thing is that uniformly it has delayed PACU discharge and discharge from the recovery room. So the use of dexmedetomidine, if decided, has to be decided on a patient-to-patient basis. Low dose ketamine with its sedative, analgesic, and catatonic property of allowing the patient to lie immobile should actually have been one of the favorites for the cataract surgical patient, but has not proven to be so because of the unpleasant hallucinations that it could cause in the daycare patient, even at low doses, and other effects on the eye itself, like increase in intraocular pressure and nystagmus, make it not so suitable. Well, a few more words on the sedation technique, whether to use a single agent versus balanced technique. That depends on the expectation and needs of the patient, whether they require analgesia, anxiolysis, or sedation. And a balanced technique is usually preferred, where most authors as well as anesthesiologists use midazolam or midazolam plus fentanyl. For a short surgical procedure like cataract, which lasts anywhere between 5 to 40 minutes, depending upon the upon who is operating, an expert, senior, or junior, usually intermittent boluses are adequate. And there is no evidence to actually prove in cataract patients that continuous infusions provide extraordinary advantage over intermittent boluses. Same is the case with patient control analgesia as well as target control infusion, though a couple of studies have showed improved patient satisfaction in patient control analgesia with propofol and remifentanil, only because they have been given the control button to self-titrate how awake they will be during the procedure. Any sedative drug, if it is used, needs to be monitored continually, and these are all the various scales that are available to monitor the sedation level. We could use any of them, but it is best to familiarize ourselves with any one scale and use it regularly on a daily basis in our operating room. The equivalent levels of sedation in the ASA continuum of sedation scale, the modified observer's assessment of alertness and sedation scale, and the modified Ramsay sedation scale are highlighted here. If using a depth of sedation monitor, yes, a couple of authors have used process EEG or the bispectral index, where they have kept it in the above 85 or in the range of 70 to 80 in the cataract surgical patient. But the BIS electrode being so close to the surgical area, and plus the cost of the BIS electrode, make this quite prohibitive and not recommended out of the study setting, at least as of now. Well, prerequisites for monitored anesthesia care is careful patient selection, as we already talked about, not only for sedation, also to exclude those in whom sedation may not help, and they might actually be candidates for general anesthesia, like those with severe head tremors due to Parkinson's, titubation of the head, and such patients. And careful planning of the drug to use, the dose to give, monitoring, as well as what to do if in the event of over sedation. So the OT should be equipped with resuscitative equipment for oxygenation, airway access, as well as suction. Fasting is not routinely required unless moderate sedation is planned. And with regards to intravenous access, it is of course essential in patients needing intravenous drug administration or IV sedation, but it's recommended in all high-risk patients.
Dr. Shalini, I'm sorry to interrupt. How many more slides do you have?
4 more slides, ma'am.
Okay, thank you.
So the main complication that we are looking at is excessive sedation or cardiorespiratory instability. Moving on to monitoring in cataract surgery, I will restrict to monitoring in a MAC patient or a patient posted for cataract surgery under monitored anesthesia care. Well, if he has been deemed to require monitored anesthesia care, the continuous presence of anesthesiologists inside the operating room is a must. Constant intermittent verbal communication with the patient, careful clinical observation, including watching for over sedation is important. One measure of oxygenation, which is the pulse oximetry, and ventilation. We could use either visual inspection of chest rise or a nasal cannula EtCO2, which is a dual cannula, one to administer oxygen and the other to measure EtCO2. Or if ECG could be connected to monitor the respiratory incidence and show the respiratory rate. Authors have also used transcutaneous carbon dioxide monitoring, as well as tracheal sound signal analysis, which is acoustic monitoring by placing a microphone over the suprasternal notch to hear tracheal sounds to identify early respiratory depression. Circulation, ECG, and non-invasive blood pressure monitoring needs to be used in every case where circulatory disturbances are expected, or in high-risk patients, especially those with cardiac illnesses. Some monitors also do display an integrated pulmonary index monitoring, which is an algorithmic integration of heart rate, respiratory rate, pulse ox plethysmographic reading, and the EtCO2. Well, these are just areas for future development where we need to identify guidelines and policies for monitored anesthesia care in ophthalmologic procedures, particularly specific to our country setting, because much of the literature that is currently available comes from UK or the North Americas. The take-home message from this talk is that intravenous sedation should be administered after careful patient selection, and non-pharmacological measures have failed to achieve patient comfort and cooperation. Continual monitoring of depth of sedation and verbal contact is necessary. And for any further reading, I would certainly recommend you to these articles, especially the first one, which is not only narrative and descriptive, but also extremely practical and pragmatic. Thank you.
Thank you, madam. Before we move on to the next slide, I want to say 2 things. One is our Hall B will be having the free paper presentation between 10 and 11. And also kindly try to stick to your allotted time of less than 15 minutes. Now let us have Dr. Ravi Chandar, who's going to speak about systemic complications following regional anesthesia.
So he has to unshare the screen. The previous speaker is still on the, yeah.
Okay.
Is it okay now? Yeah. Good morning, and I am Dr. Ravi Chandar, a consultant anesthesiologist at Aravind Eye Care System. For almost 20 years, I am being there. I am going to talk about the systemic complications following regional anesthesia. I and I. I means how I am going to tackle the complications which is happening around the eye. So what I am saying needs handled with care in terms of both life as well as the patient vision. It looks like a monotonous job, but we have to be very cautious in doing our procedure. In general, the ophthalmology means LA. That is a common terminology used by any anesthesiologist, which I'm crossing with my friends, except the extremes. There is no precise and safe ophthalmic blocks per se. Most of the blocks are blind techniques, even though a lot of developments in the other blocks like ultrasound guided or so many things are there. There is no safe blocks. So the morbidity and the mortality, especially in ophthalmology, is not at all acceptable. And most of the times when the complication happens, it is not my process that messed up. This is a common scene that what we have seen in any complication issue problem. This is what the glance, what I am practicing, that Aravind Eye Care system. We have crossed nearly 68,000 cases in a year of 2019 pre-corona period, where the GA is 3,546 and the local cases are predominantly 64,000, that is 94%. In that, if you closely look into that individual, the topical drops is 30% and predominantly the subtenons is the major contribution, and the retro and peribulbar has gone down now. But when I started my career in that hospital, I could see only the retrobulbar block. Now slowly it is going down into the 0.%. See, some of the events which come across in this 1 year where the patient has been shifted to the ICU, because these are all the common complications I have faced, that is pulmonary edema, anaphylaxis, myocardial infarction, vasovagal attack. There are totally 16 out of 64,000. We face this type of adverse reaction, which necessarily I have to intervene and attend. And all the cases when find, sir, there is no fatality. This is what everybody expects. There should not be any complication in an ophthalmologic setup. So coming to the evolution, the anesthesia, it was started like this: no anesthesia couching, then retrobulbar, peribulbar, then subtenons. Now everybody is preferred to go with the topical anesthesia. See, before I go to the complications, I would like to highlight some of the anesthetic drugs which have been commonly used in many practices. That is the lignocaine, which is a commonly used drug. It has a fast onset of action, lasts for almost an hour. And the bupivacaine, it's a slow onset of action, but it lasts for 3 to 4 hours. Some of the common additives, that is adrenaline is the one which is already mixed with the xylocaine, that is 1 in 200,000 dilution, which has been mixed with the solution, and it reduces the incidence of hemorrhage and the intraoperative vitreous bulging. And next is the hyaluronidase, which improves the spread of the drug. This is a standard dose which we are using for the local anesthetic agents, but it is very unlikely in an ophthalmology center, ophthalmic block, to reach the maximum tolerable dose of this, because the bupivacaine is 2 milligram per kilogram, the xylocaine is 5 milligram per kilogram, even with the plain block, which is very unlikely to reach 10 ml or 15 ml to give any block. So we are quite safe in terms of the toxicity unless there is some misuse. See here, this looks like why I'm saying how these drugs have been changed our profile. See, this is the lignocaine, what we routinely used for block. And then this is the another drug which was available because there was a shortage of this drug when I started looking into it. Both are lignocaine with the 2%, but very interestingly, the adrenaline mixing is 1 in 200,000, which is the acceptable one. But what I am seeing now is the 1 is to 80,000 units, which has been used mainly by the dental surgeon. In fact, there is a pre-mixed loading of the syringe with the lignocaine with the adrenaline, which was available. So always look into the drug before taking the drug and injecting to any patients. These are some of the problems which we will face. But thinking that everything looks fine, lignocaine 2%, 2% with the adrenaline, that's all. We started loading and we started giving. But once the problem comes, when we look into the action, we notice that there were high dose of adrenaline in another drug which is available. See, anesthetic drops, which is very unlikely to produce any reactions of the toxicity. The preservatives, usually the preservatives is the common issues, many complications. This because of the toxicity or anaphylaxis, so many things. The paraben and EDTA, metabicel, these are all the preservatives which have been stabilized the local anesthetic drugs in solution. Why these preservatives are being used? To inhibit the growth of the fungus and yeast. It is used for the multi-dose vials. We can prick in the 10 times. As compared to the single dose vials, all parabens have been removed. But what we are doing, the preservative-free drug, sometimes we started using for a multiple pricks. This is quite dangerous because this has been designed for the cardiac purposes. This drug has been injected through some cardiac arrhythmias. So along with that, these preservatives also your neurotoxic drugs. So coming to the topic, I highlighted, these are all the 6 complications that can happen. That is hypersensitivity or allergy, overdose, toxicity, oculocardiac reflex, brainstem anesthesia, and the vestibular attack. Most of the previous slides have been given as an overview. Now I'm going to talk individually. The allergy, the true allergy is very rare, mostly confined to the ester-linked drugs. Because of the breakdown product of the esters, the para-benzoic acid triggers allergy. The reaction with the preservatives is methylparaffin. As I said, the multi-dose vial, they have used this for the preservatives. So what we have to do is, we have to take some history and a test dose before injecting a LA. The symptoms are usually started with the mild rashes and slowly going to the fall of BP and then respiratory difficulty and then finally the laryngeal edema, angioneurotic edema and loss of consciousness and arrest. So we have to treat in any allergy patient if they started telling that some allergic reaction like itching or some numbness or some other scratches you can see, we have to take immediately and give hydrocortisone first, then antihistaminics. And finally, if it is not settled with any of these our controlled measures, we can always have the drug of choice. That adrenaline we can give either IM or IV, depending on the situation, to manage the patient. So, if the patient is allergic to local anesthetic agents, is the general anesthesia is the only alternate? There are something that I wanted to highlight this. There is always a mistake or mislead which happen in the test dose level. It could be either intravascular, it could be the reaction, actually strictly speaking, it should be 1.5 centimeters around the test dose level. But there is itching like reaction, there is erythema like reaction, the patient started feeling some numbness in the tongue. These are some of the confusion which happens. So depending on the indications, we have to get the consent. If you are uncertain that the patient is going for some allergic reaction, we have to plan for the GA, but there is no definite test dose for any GA drugs. That we have to keep it in our mind. We don't have any test dose for the propofol. We don't have any test dose for the fentanyl or so many drugs. So all the things contribute us. We have to develop a safe protocol when we have chosen a patient for the GA in a allergic to a local anesthetic agents. So proper consent has to be obtained from the patient. Most of the times, the allergy, if you go in detail, this would have been the drug preservatives or some technique-induced problems. So we have to be very careful in identifying the patient whether they are going for really a allergic situation. This is one of the interesting terminology I noticed, the last. We don't want to be lost the patient. That is local anesthetic systemic toxicity induced. We don't want to lose the patients. The concentration of the local anesthetic in the circulation increases too rapidly within a short period of time. That is, if you are injecting a drug very high volume with the rapid force, we can get this type of systemic toxicity. Sometimes it can happen even when you give the drug intravenously. The toxicity effect primarily directed towards the central nervous system or the cardiovascular system where the excitable membrane is there. Although the neurological presentation is the most common, as everybody accept that, immediately they ask, if have you checked the blood has come or not. The patient shows fits or something like reaction. But there were indication in a 1 in 1/5 of the patient have isolated cardiovascular system, like asystole can also happen. So when a patient is going for asystole also the seizure-like disorder, we always look for the systemic toxicity of the drug also. In that, we have now developed the other drugs, levobubivacaine, ropivacaine, which have a slower systemic absorption than a bupivacaine, which has some vasodilating effect. So we have the time for that to react according to the situation. And also the bupivacaine is the one drug which stays in the myocardium and produces the severe reaction, and it is sustained for 3 to 4 hours. So it is very difficult to resuscitate and revive the patient rather than a levobubivacaine or ropivacaine or some other lidocaine. So some hospitals prefers even now avoid bupivacaine for a cardiac patient or already a compromised cardiac patients. These are all some of the things which is even now we are practicing. So what is the toxicity? How we can expect this type of toxicity if you are giving a peribulbar or some other drugs which has been entered into the bloodstream or high volume? The patient started saying lightheadedness, numbness, or tingling in the circumaural area. They initially started showing some anxiousness, tried to get up and tried to show some movements, then become drowsy and thrown fits, and then the CNS excitation following the CNS depression, eventually a cardiac arrest will happen. So what we have to do? See, minimum dosage. That means I don't think we are using the high dose in ophthalmology center like any other peripheral nerve block. And most importantly, aspiration before injection. This is very common practice, but even then we have to be very careful, and the injection rate should be very slow. And most interestingly, I believe that we have to talk to the patient verbally when you give any injection, not looking at the others or looking at the eye alone and doing the procedure. So we can get some important information from the patients. See, this is the oculocardiac reflex. Because of the previously we have the retrobulbar block and massage to the eye, and the patient develop bradycardia and ectopic and asystole. But now this is very unlikely in a retrobulbar or peribulbar because we reduce the number of retrobulbar. But even then, whenever we give a block, we should have a pulse oximeter and see the patient response, whether the patient is going for the oculocardiac reflex. So as I said, that is a pressure on the eye, manipulation of the globe, which is quite common in the intraoperative period. So what we have to do, any injection, even the subtenons or whatever it is, if you notice that even subtenons 3 to 4 ml, if you give it in a closed space, it can compress and it can produce the oculocardiac reflex-like reaction. Since the patient is lying down, the drug is easily dispersible. The chances of continuity of the oculocardiac reflex is very minimal, unlike in a general anesthesia patients. So what we have to do in a general anesthesia, the hypoxia and CO2 retention is the one which precipitates the oculocardiac reflex. What we have to do immediately, the atropine and glycopyrrolate is the next immediate choice. Even if it is not responding, and epinephrine is also another choice, but more 99.9% we never had a oculocardiac reflex going for refractory, going for CPR, because we are the gadgets we are having able to identify the issues very early and do the procedure and resuscitation very easily. This is the brainstem anesthesia, one another, very rare, very rare. I haven't seen in my 20 years, very rarely that needle has gone into the submeningeal pathway, the drug has dispersed and is entered into the brain and produces these brainstem anesthesia. The symptoms started with the 2 minutes and maximum reached by 10 to 20 minutes and resolves for 2 to 3 hours. So the most important thing is we have to be very careful in monitoring this patient. When the patient is going for a complete and apneic and not responding, not moving, and going for not any movement, we have to do this all supports in the form of respiration, cardiovascular, and monitor the patient for 2 to 3 hours, because we know we only give the drugs and we started the procedure. We know how the patient previously and we know how the patient now. So wait for the drugs to disperse and then the patient will become normal. The problem is keeping the patient in an ophthalmological center for some hours is always query from everybody. So close monitor the patient and ventilator or oxygen support, IV fluids. There are, depends on the hemodynamics. We have to use the other drugs to control this. See, this is the thing that I noticed, that the drugs has to be in the neutral gauge injection and less than 37 millimeter long needle, and withdraw the syringe whenever you have the resistance or anything, you relocate and do the procedure. This is vasovagal syncope. This is now very different scenario, because mainly because of the pain as well as anxiety, emotion. Patient will be in a very different anxious movements for the eye surgery, because especially when the needle or somebody is getting close to the eye, they started showing this type of movements. So the symptoms will be the sweating, and the patient started pallor and nausea and vomiting. But usually when the patient, keeping the patient in a lying down position and the positioning the airway and the good oxygenation observation, that will help the patient immediately. But I have seen this type of vasovagal attack at the end of the procedure. Whenever the local anesthetic effect is gone off, at the end the surgeon will give some drugs for the antibiotic or subconjunctivally. They started screaming and suddenly started showing and drenching sweats and other problem, then immediately recover. These are all the problems. So we have to be very balanced, the anesthetic depth and anesthetic duration, and you can even supplement even the anesthetic, local anesthetic drops or some other form of anesthetic agents before doing the closing the procedure, or we can add some other anesthetic agent in between, benefit of the patient. This is very unlikely, the facial nerve complications like Horner syndrome or swallowing or difficulty in this patient. This one time that I have faced one patient after the DCR started showing some abnormal movement because of the local anesthetic agent. They had gone into the oropharynx, the nasopharynx, and they started showing they cannot breathe, they cannot swallow. So restless movement, immediately we think of cardiac arrest or respiratory or pulmonary, so many things we monitor. And finally, once the drug effect is gone, patient is very comfortable. So depends on the situation, we have to rate. See, coming to this LA in ophthalmology, first thing is nowadays it is better a proper history making or preoperative checklist for the ophthalmology. And then I still believe that if the history is very good, the patient had already a local anesthetic experience, we can go ahead. If not, better to do a proper dose. And the IV access is one, always be a query in many places, because we don't operate any ASA 3 or ASA 4 patients, the ASA 1 and 2, but considering the life of the patient and the cost of the IV line, now it is mandatory, and it is almost, yes. And the starvation point of view, it is, I believe that there is no mandatory or obscure, because why I'm saying this, cataract surgery can be postponed and planned for the GA electively, or if already planned, you can maintain the starvation. So starvation is almost equivocal response. So our responsibility, anesthetist versus surgeon distribution, is very different. Where I am working and where I am seeing the dynamicity of the procedure also, anesthetist is not very interesting, because they have the closed area, there is no blood loss, there is no BP drop, something like that. But we have to ensure the safety and impart the knowledge of safety to the ophthalmologist. That is very, very interesting, very important, because they also scream when the patient screams. So most of the hospitals have unispecialty without a 24-hour physician or anesthetist backup. Depends on the resident and the nearby hospital. ICUs are basically a basic nature. And so what we have to do, we have to talk about the complications. And most of the times we have to ensure the emergency trial, all the atropine or glycopyrrolate, whatever the basic drug, have to be preloaded. That is always not a very cost effective, very easy. So take home message is no LA technique is entirely safe from free systemic adverse effect, and the gentle aspiration after insertion of the needle should be mandatory. Correct selection of the needle will be helpful. All ocular surgery with the LA should be treated as GA, thereby to avoid complications. I think I stick on with my time. I thank you for everybody.
Thank you so much, Dr. Ravichander. So the free paper presentation will be starting shortly in Hall B. Next, I would like to call upon Dr. Lakshmi J. of Giridhara Institute to talk about ophthalmic complications following regional anesthesia.
Dr. Ravichandra, can you just
Yeah.
stop share screen?
Okay.
Yes.
Yes. Am I audible? Can everybody see the screen also?
Yes, Dr. Lakshmi.
Good morning, everybody. It's been very informative from the beginning. The talks are going on really nice. Thank you, everybody, all the members of the AIOA, Dr. Girdhar sir, Sai sir, Pushpa ma'am, for giving me this wonderful opportunity to present in this platform. My topic is ophthalmic complications following regional anesthesia. All the systemic complications have been dealt with Dr. Ravichandra in a detailed manner. Actually, my duty is becoming very simple. Yeah, the complications may be local or it may manifest as a systemic complication, which has been discussed in detail. Okay, it may be immediate or it may be delayed. It may be related to the method of administration, that is the technique of administration. It may be related to local anesthetic agents or the adjuvants. The complications can be really trivial to very devastating, which may threaten sight or even life. I'll broadly divide the complications as complications of agents and complications of the techniques. So topical local anesthetic agents frequently sting. Temporarily, it can cause clouding of the cornea, and the corneal anesthesia necessitates protection of the eye by ensuring that it is closed and protected by a pad. The systemic complications, all these have been dealt with in detail. That is overdose of drug, which is very rare, as what Dr. Ravichandra has told. Intravascular injection, allergic vasovagal reactions, injection into the CSF, allergic reaction to hyaluronidase. Hyalase allergy, it manifests as periorbital edema, conjunctival injection, chemosis, pruritus, pain, and restriction of extraocular muscle motility. Mostly it is self-limiting, but it can be dealt with by giving steroid injections or antihistamines. Now, coming to the complications of techniques. The most common being subconjunctival hemorrhage or bruising, which is also called ecchymosis. The incidence being 4% of the patients, which is really disfiguring. Injection should be made through the conjunctiva rather than the skin, as it is less painful and the chance of skin bruising and disfiguring is reduced. Another one complication, local complication, is subconjunctival edema or chemosis. This occurs due to large volume peribulbar injections. It usually resolves with the use of pressure reducing devices and does not cause intraoperative or postoperative complications to the patients. Another really devastating complication is the retrobulbar hemorrhage, which I have to deal with in detail. Okay, the incidence being from 0.1 to 1.7%. The incidence of RBH, that it's how it is called, RBH, in peribulbar injection is usually around 0.4%, but in retrobulbar injection, it is obviously more, that is 0.7%. The predisposing factors include elderly patients, patients with vascular or hematological diseases, patients on steroids, aspirin, NSAIDs, anticoagulants are all can all develop retrobulbar complication. The manifestations include increasing proptosis with tight eyelids, subconjunctival and periorbital hemorrhage, dramatic increase in the intraorbital pressure, which causes retinal artery compression because of the mechanical tamponade, or increased intraocular pressure. The risk of developing retrobulbar hemorrhage is greater when a long, that is more than 38 millimeter needle is used. And when a large diameter needle is also used, the risk of developing retrobulbar hemorrhage is greater because it can cause tear in the blood vessel. The retrobulbar hemorrhage can be of two types, that is venous hemorrhage or an arterial hemorrhage. Venous hemorrhage is quite okay because it is slower in onset of action. It perforates the vein and presents as a markedly blood-stained chemosis and raised intraocular pressure. What we have to do is give intermittent digital pressure with a gauze pad over the closed lids. Usually it resolves and we can continue with the surgery, but arterial hemorrhage is not like that. It occurs due to perforation of artery, which is very quick and more difficult to control. Urgent measures must be taken to stop the hemorrhage and reduce the elevated intraocular pressure. We should also monitor the CRA pulsation. Management of arterial RBH is by giving digital firm pressure. Usually it stops the bleeding in venous, but not in arterial. You can also give intravenous acetazolamide 500 milligram or intravenous mannitol 20% IV in the dose of 1.5 to 2 grams per kilograms over 30 minutes. The initial flow should be really fast. You can also do decompressive procedures like anterior chamber paracentesis, lateral canthotomy, cantholysis, or urgent decompressive orbital surgeries can also be performed. The main aim is to save the eye. It is usually prudent to postpone the surgery, but occasionally the application of pressure-reducing devices may be successful in reducing intraocular pressure and surgery may be allowed to proceed. Next dreaded complication is globe damage. Globe damage can occur both in peribulbar and the retrobulbar blocks, the incidence being around 0.1%. Hamilton RC et al., they have described some risk factors for the development of globe damage following orbital anesthesia. One is the presence of long eye, as in myopes. The anteroposterior diameter more than 26 millimeters, you have to be really careful. Presence of staphyloma in ophthalmos, repeated injections, an uncooperative patient who moves his head or eye during the blocks, previous scleral buckling or corneal refractive procedures you have to deal with carefully. The bevel of the needle should be which is turned away from the globe so that the tip of the needle just pricks the globe, and which cause globe damage. It has to be looked into. The lack of knowledge of the orbital anatomy or technique is another risk factor for development of globe damage. The globe damage can be a globe perforation, which is a double puncture wound. The wound of entry and exit is there. It can also be a globe penetration, which has only an entry of wound. The globe rupture is injection of local anesthetic into the globe, which is very devastating. The symptoms include pain at the time of the block with sudden loss of vision. There may be hypotony because the globe has been punctured. Poor red reflex or vitreous hemorrhage can also be seen. A word about ocular explosion or the rupture of the globe. It is due to inadvertent injection of local anesthetic into the globe. Very low dose, like less than 2 ml, even if it is injected into the globe, will result in rupture of the globe because the globe space is very less. How to avoid globe rupture? A knowledge of the orbital anatomy is a must. The length of a globe, that is more than 26 millimeters, you have to be careful. The initial tangential needle insertion not going up and in until the needle tip is clearly past the globe equator has to be looked into. Minimizing the number of injections because every injection has a risk factor of developing a globe damage. Use of blunt needle. Noting negative aspiration before injection is very important. Inspection of aspirate for blood or vitreous fluid should always be looked into. Wiggle the syringe before injecting, which is quite controversial. Some say that you should do that. Discontinue the block if corneal edema or resistance to injection occurs. And inspect the globe for corneal edema or hypertony before shifting the patient after the block. Another complication is optic nerve atrophy. Optic atrophy and retinal vascular occlusion may be caused by direct damage to the optic nerve and central retinal artery with injection of to the optic nerve sheath or hemorrhage within the nerve sheath, or it may be due to pressure necrosis from the local anesthetic agent within or around the optic nerve. The risk factors for direct optic nerve injury include patients with small orbits where the space is very less, placement of long needle deep into the apex,
patient looking up and in at the time of block where the optic nerve comes in contact with the needle. Another complication which is dealt in detail with Dr. Ravichandar is penetration of the optic nerve sheath. Optic nerve has a complete dural cuff all the way up to the sclera, and injection into this cuff leads to subarachnoid spread of the agent directly into the CNS, causing brainstem anesthesia. So all the injections should be made with the globe in the primary position. That should be a must. The incidence of CNS complication with retrobulbar block is around 0.2 to 0.3%, whereas in true peribulbar blocks it is very less, that is 0.15%. The symptoms usually appear within about 8 to 15 minutes. If there is rapid onset of the symptoms, the injection has gone into the ophthalmic artery or the orbital artery. There can be a delayed symptom also, that is spread from the posterior orbit in the fat outside the dural sheath into the dural sheath. The symptoms and signs, as has been described, is drowsiness, vomiting, contralateral blindness, convulsions, respiratory depression, arrest, neurological deficits depending on where it has gone, where the local anesthetic agent has gone into, and cardiac arrest. How to avoid this is by use of short needles. Needles longer than 3 centimeters should never be used, and needle need not be inserted more than 2.5 centimeters into the globe, into the orbit. Sorry. Patient should be observed very carefully and monitored after the introduction of local anesthetic and also during surgery. Resuscitation equipment and personnel trained to use it effectively must be available in all OTs. Oculocardiac reflex has also been discussed. Bradycardia and hypotension in response to mechanical stimulation of the globe, which is very rare in after peribulbar block. Arrhythmias, asystole, all can occur. It may be due to the institution of the block itself or rapid distension of the tissues by large volume or speed of injection, or hemorrhage that might provoke the oculocardiac reflex. Next complication is myotoxicity. Usually, strabismus, ptosis, and entropion are the symptoms of myotoxicity. Most frequently affected muscle is the inferior rectus muscle. The toxicity occurs with high concentration of local anesthetic injected or direct injection into the muscles or direct injury to the muscle. They usually recur, and occasionally corrective strabismus surgery is required in some patients. Complications of facial nerve block has also been described by Dr. Ravichandar. The facial nerve block is painful, and it is also associated with bruising. The blocking of the main trunk can lead to full hemifacial palsy. Local anesthetic may spread to the vagus, glossopharyngeal, or the spinal axillary nerves, leading to dysphagia, respiratory difficulty, which has to be dealt with. Coming to subtenance block, which is said to be the very recent and the very safe block. The complications include mainly the pain on injection, which occurs in 15 to 33% of the patients, chemosis and subconjunctival hemorrhage in most of the patients, and all other complications in peribulbar and the retrobulbar block can also occur in subtenance block, but the rate of complications is very less. So this is in a nutshell what I've told, what I've spoken to. Okay, the most common complications being chemosis, subconjunctival hemorrhage, pain, ecchymosis. The rarer complications, ophthalmic complications, include the retrobulbar hemorrhage, the globe injury, optic nerve atrophy, muscular palsy, or myotoxicity, and the brain anesthesia. In conclusion, serious complications can occur from all techniques of eye blocks. Before attempting to perform any regional orbital block, it is essential to learn the anatomy of the orbital structures and the safe block techniques before doing them. Pre-operative assessment and preparation of the patient should be done. Establishing rapport with the patient, which reduces anxiety. Pardon me. Some of the noise is coming. Okay. The pre-operative assessment and preparation should be done with care. Establishing rapport with the patient, which reduces anxiety and stress, thereby lowering arterial pressure. A confident prick, a watchful eye, presence of mind, and prudent revival techniques will save our day. Thank you.
Thank you, Dr. Lakshmi. I would like to call, before I call upon the next speaker, I would just like to tell you we are behind by half an hour. So kindly keep up within the time. Now I'd like to call Dr. Oya Yalcin Kok of Baskent University, Turkey, to talk about managing obstructive sleep apnea syndrome patients posted for cataract surgery.
Intraoperative difficulties include clear view.
Thank you very much. There is a sound coming behind. I'm not sure if you are hearing, but
Yeah.
gentleman is speaking now. I'll share my screen. Okay. I'm Dr. Oya Yalçınçok from Turkey. It's a great privilege for me to be with you today. I will talk about managing obstructive sleep apnea syndrome patients, posted for cataract surgery. I will define obstructive sleep apnea, ophthalmic patients with obstructive sleep apnea, whom to suspect, what to evaluate, and how to manage them. So speaking of obstructive sleep apnea, in definition OSA, it's the pause of breathing due to obstruction of the upper airway during sleep, but it must be at least for 10 seconds or 5 apnea or hypopnea periods per hour. And the prevalence is not actually small, 5 in adult population, but more than 80% of these patients go underdiagnosed before surgery and is strongly associated with obesity. So what are the possible consequences? The possible consequences are actually physiological outcomes of obstructive sleep apnea, as expected, hypoxia, hypercarbia, and in response to all of these, all the systems are affected and the activation of sympathetic nervous system can be seen. Daytime drowsiness is a real feature of an obstructive sleep apnea patient. Hypertension, diabetes, cardiovascular disease, and stroke may follow. And unfortunately, death or near death can be seen in this group of patients. So these patients require a preoperative screening to suspect and identify OSA, and intraoperative tailoring is essential, and postoperative care should be very attentive to avoid possibly catastrophic events. So whom to suspect? Because we have got a huge group of ophthalmic surgery population, and some are obese, some are male, some have daytime drowsiness, headaches, and attention deficiency. Then there's an exclamation mark, because these patients are the patients who have to be suspected for OSA. Even if they are plus they are smoking, they have got alcohol and opioid analgesic use. If they have got hypertension, diabetes, or metabolic syndrome, these are the typical adult OSA patients, and they have always a history of snoring loudly during sleep, and they have often witnessed apnea periods by relatives or people around them. So what do we have to evaluate these patients? How can we do a preoperative OSA screening in a practical manner? We have got available OSA screening tools for the preoperative course, and these are ASA checklist, Berlin questionnaire, STOP questionnaire, and the advanced one, STOP bank questionnaire. Among these, STOP bank questionnaire is very practical, and it has a higher sensitivity, and it evaluates data on both patients' history and his or her physical characteristics. And it has been shown that the highest scores with STOP bank questionnaire is highly associated with moderate to severe OSA. and it predicts intraoperative and early postoperative adverse events. Let's have a look to this stop bank questionnaire. It can be adapted to preoperative clinic very easily. There are 4 questions about the history of the patients. We can ask the patient if they snore loudly, if they feel tired, fatigued, sleepy during the daytime, if there was any witness observing their breaths stopping or choking. These are the questions that we can easily ask at the clinic. And then if they have got high blood pressure and if their body mass index is more than 35 kilograms per square meter and the age was older or is older than 50 years old, neck size is large, and if gender is male, these are all predictive questions. So if there are 2 positive answers to the questions, the patient has a low risk for having OSA. If it is more than this, a moderate risk can be seen. And if 5 or 8 questions are positively answered, or if there are more than 2 stop questions plus gender, BMI, or neck size risk is there, we will highly suspect that this patient may have OSA, and we will prepare everything accordingly. So what can we do more? Because of these patients can have obesity along with their problems. A modified Mallampati score or body type data improves specificity and validation of stop bank questionnaire. But there's no OSA screening tool validation in ophthalmic surgery patients, and no OSA study in ophthalmic surgery population specifically done with this group of patients. So what are the concerns about anesthetic management? How will we manage these patients in ophthalmic surgery setting? These patients are more prone to perioperative complications. This is the very important point that we should not forget in every patient with OSA, because they are prone to hypoxemia, hypercapnia, preoperative myocardial ischemia. They may have postoperative delirium, and reintubation or non-invasive ventilation support need is another possible risk group. So why this happens? Because that we induce sedation, that we induce general anesthesia, actually they mimic the effect of physiological sleep and depress the activity of airway opening muscles, increase the tendency to airway collapse. So we have to tailor intraoperative management for cataract surgery in patients with OSA. What is recommended is to use regional or topical ophthalmic anesthesia without sedation. These patients may be assured by hand holding. You can say that we are here. We can support them vocally during the surgery. And semi-upright position may help them, especially in obese OSA patients. They can comfortably sit on the operating bed or the side. So what is the problem with the sedation in these groups? Any sedative and at any dose may start an unexpectedly deep sedation in OSA patients, which is leading to exaggerated relaxation in the upper airway, blunted central nervous system reactivity, and deteriorated airway integrity. And these may start a big problem for the surgical side, also for anesthetic side, with unintentional movements, hypertensive response, and increased intraocular pressure. So what will we do for sedation? There are some general considerations that we can follow in this group of patients. We can titrate sedatives. We can use short-acting and reversible agents. We can continuously monitor carbon dioxide along with standard monitorization, and we can use patients' own equipment for OSA. And the best strategy for avoiding problems is timely conversion to general anesthesia. What does this mean? It means that if you are not happy with the safe airway management or prevention of snoring, unintentional movements, or if there is a big problem with the IOP rise, then you will start with general anesthesia rather than using sedation or trying sedation in these OSA patients. There are some recommendations, we cannot say recommendations, but there are some papers claiming that some agents are better than the others, like alpha-2 adrenergic agents. But I must admit that there isn't a big group of paper showing us good evidence, but they say that these are suitable agents for cataract surgery and in this group of patients, and it is a little bit superior than midazolam. And there has been some other papers showing that continuous propofol and rifampicin infusion can be done if it is really required. Talking about general anesthesia, then we have to have some considerations. We have to have identifying alarm bands on patients. We have to prepare for a difficult airway management. Invasive monitoring can be used, and extubation while monitoring residual muscle relaxation and consciousness is also essential. So what the question should be, what shall we use then? Total intravenous anesthesia and inhalation anesthesia has been compared in this group of patients. The authors said that neither of them worsened the incidence of post-operative problems. However, none of them was also superior to the other one. And what about the opioids? Opioids are totally no and no. These patients should not receive opioids to avoid problems intraoperatively and postoperatively. And luckily, in cataract surgery, the patients feel less pain during and after the surgery, that we can skip opioids or swap them with less potent analgesics like paracetamol and the others. So there's another paper that we can just find out a little bit piece of information about OSA. This is a paper looking for anesthesia recovery after ophthalmologic surgery at an ambulatory surgical center. And they found out that, just taking out little piece of information, this is not a specific paper for obstructive sleep apnea patients. They said that after general anesthesia, if the patient had obstructive sleep apnea, they had significantly prolonged recovery. In this paper, there was no difference regarding recovery when you use sedation or topical anesthesia. For post-operative care, you should always closely monitor the patients for 3 hours. And if possible, you should use capnography as well as pulse oximetry in these patients. And if the patient needs supplemental oxygen, it should be less than 2 liters per minute to prevent suppression of central hypoxia response. And overnight hospital admittance should be considered if the patient has got respiratory problems persisting. And you should always remember that in OSA patients, the apneic episodes are more prominent after second night because of painful or sleepless surgery nights, the rapid eye movement sleep change, and attentive care should be employed until patient returns daily routine. And we have to know that PAP devices, as early as the patient is delivered to the recovery area, they will use their own appropriately pre-adjusted airway pressure equipments to assure and avoid the other complications. This is a paper about the cataract surgery patient with severe obstructive sleep apnea who was not psychologically fit for a regional technique, and they used sedation using his nasal CPAP equipment throughout the procedure. So for pediatric patients, we have to know that they have got OSA2, and it's also tenfold higher in obese children, but they are not like adult patients presenting at the preoperative clinic. They have rarely daytime drowsiness, and they have nocturnal sweating. And the most common etiology, fortunately, is a benign one, adenotonsillar hypertrophy, and they are screened with "I'm sleepy" questionnaire. So there are some other ophthalmic disorders associated with obstructive sleep apnea, which can be problematic after the surgery. This is the OSA. It causes the ocular motility dysfunction, and after these operations, the patients with OSA have more vertiginous symptoms. They may say they have got dizziness, nausea, post-operatively after ophthalmic surgery. So what to take home, the nuggets? Obstructive sleep apnea is a prevalent disease with a pause of breathing, and we can use stop-bang questionnaire for screening these patients. And unexpectedly deep sedation may happen. We should not use opioids, and we should observe our patients for 3 hours post-operatively. So as conclusion, I want to say that with attentive anesthetic care, we will be on the safety side without preoperative complications. If you would like to have some further reading on this subject, I can give this paper that we shared with Professor Kumar, Edwin Street, and Professor Joshi. Thank you very much.
Thank you, madam. Now I'd like to call upon Dr. Frederick Lersch from Bern Hospital, University Hospital, to talk about what is the best loco-regional anesthesia in previously encircled eyes. Sir? Dr. Frederick?
Sumana, they have to play that video.
Okay.
Okay.
Good morning, it's a pleasure to be with you, and I'd like to talk to you about the role subtenance blocks can play generally in encircling eyes and especially in previously encircled eyes. So this picture summarizes the different qualities of locoregional anesthesia that you can choose in ophthalmic anesthesia generally. And the preprint, the cited preprint, tells you that even in high numbers, we're seeing more and more, especially from Indian clinics, how a change to the safer blocks like subtenance block can really change practice. We want to really rub in how a never event really should be a never event. So avoiding sclera perforations, avoiding bleedings in the orbit or into the vitreous is very, very important. And using the subtenance block to this end seems to be advantageous. If you just throw this a quick glance, this is just a footnote on where to put a subtenance block in an eye about to be encircled. So in our experience, and we've done quite a lot of encircling bands or buckles in locoregional anesthesia, it is advantageous to put the nick for the subtenance close to the limbus, contrary to the usual practice where you rather remove the incision for the subtenance block to the periphery, further away from the limbus, because the surgeon can initiate his peritomy, so where the conjunctiva is open 360 degrees to make the muscles accessible for the encircling band from the nick where the subtenons block was placed. This gives the advantage that all the painful steps of the surgery, like isolating the muscles, are under the anti-nociceptive protection of the block, and the block at the same time severs the reflex arch of the trigeminocardiac reflex or the ocular cardiac reflex. So as we all had to do during the pandemic, we tried to find better ways to do local anesthesia, especially with the aim of producing less aerosols of COVID-19. And obviously we come across a lot of old frail patients that are endangered to be delirious or suffer hemodynamic complications where general anesthesia is not always the best option. So being aware of the problems that sharp needle blocks pose and the altered anatomy that you can see in these pictures, we were, on the one hand, undertaking a case series because we knew that we could place subtenons behind the encircling band. We had done this before, and we knew anecdotally that other colleagues like Keith Allman or Shashi Vora did the same. We found out that the surgeon under the microscope was free to use the buccal as a landmark, and we wanted to know what other colleagues did, and some of you participated in this international survey. We sent out 119 invitations, received 85 responses from all countries imaginable, and of these 85 responses, 20 ophthalmologists and 64 anesthetists replied. So when the anesthetists were cued about their choice in ophthalmic surgery for young healthy patients, either in previously encircled eyes, phaco, cyclophotocoagulation, or retinal surgery, you see that while many opt for the peribulbar block, a lot are quite freely choosing general anesthesia, and some use the subtenons block. Others proposed, for example, using a caruncular block or abstaining from general anesthesia using deep sedation without mechanical ventilation, but it was not further specified whether they would combine it with a block, as, for example, we would do. So when the patient in question was old and frail, this changes dramatically. The anesthetists are not so sure that subjecting these old, frail patients to general anesthesia is a good idea, and rightly so. And the choice is split up mostly on the local regional procedures, with the peribulbar block being the most chosen amongst these blocks. So the ophthalmologists, for example, here in cataract surgery, would use, especially for the cataract, mostly topical intracameral. And once they come across an old frail patient, there's a slightly bigger inclination to opt for subtenons block. When it comes to vitreoretinal surgery, this trend abstaining from general anesthesia is also visible when going from young to old patients. And when given the preponderance of most of our colleagues to use a sharp needle block, the peribulbar block, in this situation, we asked also in our survey whether they would be using the ultrasound to either plan or use the ultrasound to online perform their block, and we were surprised that very few people actually opted for this possibility. Most of those who opted yes are French anesthesiologists, given their likelihood to do all kinds of local regional anesthesia with good ultrasound planning. And I think they are right, because the buckled eye is an eye that is inherently myopic, and the buckling, as you've seen in the schematic pictures at the outset of this presentation, has a high likelihood of being staphylomatic. You can see in this publication by Howard Palt and Stephen Geyer, where they actually looked where the encircling band was, and this is a radiology study that shows the staphyloma in this myopic and encircled eye. So I think using the ultrasound to plan is a good option. So at the same time, during the pandemic, the outset of the pandemic, we wanted to test with our surgeons how feasible in bigger numbers, and these are still very small numbers to many of the numbers that you, for example, in India can produce. We wanted to test the null hypothesis that subtenance block in previously encircled eyes should not be done. And together with Dr. Ebneter and Professor Thickenagel, we performed 30 subtenance blocks in 26 previously encircled patients. And 6 of these 30 were done in combination with general anesthesia, like we do also in a not encircled eyes. We do a lot of combined anesthesias, which gives us the possibility to apply multimodal anesthesia and sparing the patients a whole load of opioids. These were 15 males, 11 females. The mean age was 59 years. We had a very high rate of patient satisfaction and a high rate of subtenance success. There was one patient with a lot of scar tissue encountered, and only one patient who produced a high rate of chemosis. We tried to analyze the buccal age and watched out for excessive sedation in those patients who were not under general anesthesia. 4 of these 13 blocks were inadvertently performed by the anesthesiologist, as it was not noted on the sheet that an encircling band was in place. 2 of these 4 were not successful, but were successful when taken up by the surgeon after that.
And the encircling band is localized. Held in place by a forceps or a cotton bud, the conjunctiva is incised just behind the posterior edge of the band, and subtenance capsule is spread slightly with the Westcott scissors. Fibrous scar tissue around the encircling band is visualized under the scissors tips. A white scleral reflection in a fold of the conjunctival tenons fascia double layer delineates the desired opening where the blunt subtenance cannula can safely be inserted.
So, as for the results of our case series, we treated one patient who was mentally handicapped, and this patient was underwent 2 surgeries in combined anesthesia. We had one patient who already came in alcohol deprivation delirium, and he underwent combined general anesthesia. One patient had excessive scarring, and on this patient the subtenance was not successful by the surgeon, and the surgeon opted to perform a peribulbar block. There was one patient with a successful subtenance block who suffered extensive pain during cryotherapy. There was one very, very old buckle, but on this patient, the subtenance block could be performed without problem. Basically, what we found is that the scarring and the chemosis in the subtenance block undertaken were negligible. So to conclude, we think that subtenance block may be a good add-on to the toolbox of either surgeons or anesthesiologists. In previously encircled eyes, we had a high rate of patient satisfaction and surgeons' satisfaction. Of course, with these low numbers, we're not going to make any pronouncement on the safety compared to peribulbar block. But we are convinced that the inherent safety of the subcutaneous block compared to sharp needle should be panning out into high numbers, as has been shown in the ARAVIN trial that is up for publication. But open question remain. So does the encircling band maybe lend itself to produce more patchy blocks where breakthrough pain might occur during cryotherapy? We've seen this in non-encircled eyes before, but that is an open question. Another important question is whether the intraocular pressure or the perfusion pressure are significantly influenced in previously buckled eyes. And does that mean for the anesthesiologist that he should more aggressively raise the systemic blood pressure to provide good perfusion pressure? We personally think, and we're in line with our French colleagues here, that ultrasound for sharp needle blocks should be recommended in eyes that have sometimes such drastically changed anatomy. And with this, I thank you for your attention.
Thank you, Dr. Frederick. Now we would like to call Dr. Mrityunjay Kumar to talk about various ocular reflexes. He's from AIIMS, New Delhi. Dr. Mrityunjay, can you please unmute your...
Yeah, I think I've unmuted now. Okay.
Yeah, okay,
am I audible now, ma'am?
Yes, thank you.
So good morning, everyone. I bring greetings from National Capital and AIIMS Delhi. And I thank the organizer for giving me this opportunity. I'm going to talk about various ocular reflexes that you encountered in both anesthesia practice and the clinical practices. So, so coming to reflexes, what do we mean by reflexes? So we have learned it from right from the MBBS days, the various reflexes that we elicit in patients for getting different clinical findings. So elicited like these reflexes are the involuntary responses that are usually associated with protective or regulatory functions. So while most of the reflexes are protective, there can be some reflexes which can be which can go otherwise. So right from our high school days, we know the pathways of any reflex. There's a receptor, there's an afferent neuron, which is mostly a sensory neuron. It senses, it goes to the interneuron, then it goes to the central nervous system, either in the brain or in the spine. And then from there, the motor neuron takes over, which acts to the afferent nerves and goes to the effector muscles, or the response where it is sympathetic and parasympathetic responses that happens. So as we have discussed, while most of the reflexes are protective, there are some reflexes which can be harmful, which got to be prevented. And we all know from the ophthalmic practices, there are few reflexes like OCR, oculoemetic and oculorespiratory reflexes that causes stress to the patient, and of course the anesthesiologist also. So these are the reflexes that we are going to talk about today. We have oculocardiac reflex, oculorespiratory reflex, and the other reflexes, oculoemetic reflex, and other ocular reflexes are oculovestibular, pupillary light and dark reflexes, ciliospinal reflex, corneal reflex that we elicit, and Bell's phenomena, lacrymetry reflex, and optokinetic reflex. So the main reflex that we always talk about is the oculocardiac reflex, and it is also known as Asner-Dagnini reflex, named after the persons who described it independently, Bernard Asner and Giuseppe Dagnini in 1908. So later on, Asner worked further on OCR, and he also demonstrated the afferent pathways of the oculocardiac reflex. And people kept on observing and doing more studies on that. And Sorensen and Gilmore, he highlighted about the importance of OCR because he observed the kind of clinical manifestation this OCR was causing. And it was also noted that incidence of OCR is higher in children, which goes on decreasing with the age, and it becomes very high in infant and neonatal age group. So incidence is roughly around 14 to 90%. It varies widely, and the reason for the higher incidence of oculocardiac reflex in pediatric populations are they have got increased vagal tone, and their heart, its cardiac output is more dependent on the heart rate rather than the blood pressure. And higher, they have got, obviously they are the candidate who go for the general anesthesia more often than regional anesthesia. So by definition, positive OCR is like any change in the rhythm or bradycardia of 10% or more below relative baseline heart rate, which can result from not only from the extra traction of the extraocular muscle. There are many other things that can precipitate oculocardiac reflex. It has got two phases. Adrenergic, first phase is adrenergic phase, and then that is followed by the reflex cholinergic phase. So definition of OCR is has been an thing of controversy. It has, people have not yet come on the consensus, but for timing we can use this definition as a dysrhythmia or bradycardia of 10% or more. So some people say any ECG change during manipulation will be coming to the definition of OCR. There are other researchers who state that heart rate below 60 beats per minute and any bradycardia with ectopic arrhythmias. And this is the Alaska OCR study who has got a percentage, who is using percent change in heart rate as the criteria for the OCR. It's comparing the definition in that case is 10 or 20% heart rate drop, and they'll try to calculate the incidence of OCR with both the percentage. And they have defined this profound OCR with either with more than 33% fall in the heart rate or more than 50% fall in the heart rate. Snail's OCR criteria is less than 20% of pre-induction heart rate, and this is one definition which all of us should be aware of. This by Rahimi et al. This has come up recently. Mild OCR, mild, moderate, severe, depending on the percentage drop in the heart rate that they have pointed out. So OCR can most commonly we see the OCR in the squint surgery that we do in ophthalmic practice, and it can also be seen in, during retinal detachment repair when the tagging of the extraocular muscles are done, when the enucleation is performed, when the people are performing retrobubble and peribubble blocks, and any digital pressure over the eye is put, or even during measuring the doing tonometry or applying the bandage in the postoperative period. It has also been observed in an like anophthalmic eye, and it is during repair of the nasal fracture under general anesthesia and stimulation of eyelids. In non-operative setup, it is seen in the wearer of contact lens during contact lens wearing and orbital trauma, especially with the orbital trapdoor or orbital floor fracture. It has also been seen in maxillofacial trauma. Predisposing factors, all of us know that patients who develop hypoxia, hypercarbia, respiratory or metabolic acidosis, they've got higher incidence. If they go for general anesthesia, they've got higher incidence. Any light plane of anesthesia, will precipitate OCR more often. And they have observed vitamin is bit protective compared to the propofol, as it counters the vagal stimulation in first phase of the OCR by increasing the sympathetic tone by the nature of the chemical. And it is more with the most with the halothane and least with the sevoflurane. So use of opioids, beta blockers, calcium channel blockers, these are obvious factors which will be having lower heart, predispose them for lower heart rate, and they are also susceptible for OCR. And traction of the medial lectures, they say that it has got a longer course, has got highest incidence along with the inferior oblique, and with the lateral and lateral lectures and inferior lectures it is less. So there is a phenomenon called vagal escape, as we see in many other autonomic phenomena. This is a fatigability of OCR due to repetitive stimulus, which can be tried in some patients who are very much susceptible to the, like they are very much prone to develop OCR. So this is the pathway we all know. There's a stretch receptors that stretch receptors over here, and then from there, both from the extraocular muscles and ocular area, from the facial also, it will go travel to the long and short ciliary nerve, and from the feedback from ciliary ganglion, it goes to the trigeminal ganglion. From there, it goes to the main sensory nucleus of trigeminal nerve. Then it synapses with the motor nucleus of vagus nerve, and through cranial nerve 10, it goes follow the which is a vagus nerve. It follows the efferent pathway and acts on the SA node. So that results in many rhythm disturbance, starting from the sinus bradycardia. Then we have junctional rhythm. Then 2:1, 1:1 complete heart block. Then and even asystole has been reported. Some cases, rare cases, they have reported incidence of pulmonary edema also. So what is being observed is that children who has developed positive OCR, they are 2.6 times more likely to vomit than those without the reflex. So we'll talk about oculometric reflex coming up next. And the modes of prevention of OCR, sir, we have to maintain the adequate depth of anesthesia, of course, normocarb normoxia, controlled ventilation with because the spontaneous ventilation has got higher incidence of it. We can ask surgeon to do gentle stimulation and manipulation. What studies have found that perivalvular and retrobulbar blocks has got protective role for prevention of OCR, and subtenon block can neither protect against OCR nor against the PONV. That's the study they've found. And treatment of IV atropine and glycopyrrolate, which attenuates the afferent pathway, the effect that can also be used for the prevention of OCR. Topical local anesthetic lignocaine, proparacaine, which are used in clinical practice, that they are also protective against OCR. And this is an interesting thing that has come up. Infratracheal nerve block has been found to reduce oculocardial reflex. For that, it is injection is given in the supromedial aspect of the orbit here. And treatment, we know that we have to remove the stimulus, and we have to notify the surgeon to stop whatever the surgeon is doing, and then release the applied pressure at traction on the eyeball. And atropine we can use at the dose of 10 to 20 microgram per kg, or glycopyrrolate at the dose of 5 to 10 microgram per kg IV. We have to increase the depth of anesthesia, and even LA infiltration, topical infiltration will provide some amount of relief from the OCR. And of course, we have to avoid those precipitating factors that we have talked about. So what's new in OCR? We have, of course, whenever we talk about any anesthetic management, we talk about dexmedetomidine. So dexmedetomidine effect on OCR, they have found that although it reduces emergency agitation, this is a meta-analysis done on the, it includes 11 randomized controlled trials. And what the conclusion is, it is found to be reduced emergent agitation without increasing the OCR in children. And So it can be one thing, area of research that can be there. And this is an agent which is developed by China actually. This is penny hyclidine, which they found it to be protective against PONV and OCR. It acts on it's an anticholinergic agent which blocks M1 and M3 receptor, but not M2 receptors. Talking about the Alaska Oclo cardioreflex study, which is on the way, which was started in quite early, late in 90s, and it's going on. It's an observational study which monitors vitals and anesthetic variables, particularly heart rate during and it is during manipulation. The uniform tension, which is 200 grams for 10 seconds, and on the extraocular muscles during establishment surgery. And it is going to enroll 4,000 participants, and results are expected in 2035. And these are the two cohorts they are going to include. Those on who will receive anticholinergic medication before that, and those who will not receive. And they're going to monitor this ECG and with that. An outcome they are going to see is heart rate and anesthetic intervention that will be or surgical technique that is going to act on that. So we'll wait for the results till that the prelim result shows that the incidence is around 50% of the OCR. When we talk about oculomimetic reflex, it is a increased nausea and vomiting due to extensive manipulation of extraocular muscle that happens during establishment surgery. And this is the pathway for that. Through the long and short ciliary nerve, it goes to ophthalmic division of the trigeminal nerve. From there, it goes to gastric ganglion and main sensory nucleus of the trigeminal nerve, which goes to vomiting center in the medulla. And there is increased vagal output, which leads to the increased incidence of nausea, vomiting. Retrobulbar or peribulbar blocks have been found to be protective in this reflex. Oculorespiratory reflex, it is a response to the stretching of the extraocular muscles or pressure on the orbit, which is more common with the spontaneous respiration, which is very we cannot, of course we cannot observe with the controlled ventilation with the muscle paralysis. It is a shallow breathing and slow respiratory rate, which is falling the respiratory rate more than 20%, and it is more. It has been observed more with the medial rectus than lateral rectus muscles. Pathway is again through the long and short ciliary nerves. It goes to the ophthalmic division, trigeminal, gastric ganglion, medullary. Goes to the medullary respiratory area, and from there the efferent is phrenic and other respiratory nerves that comes back and act on that. And atropine has got no effective protective effect on the reflex. Corneal reflexes we have been using in our medicine clinical practice in critical care also. It is the blinking of the eye, both eyes in response to the tactile stimulus of the cornea with the cotton wisp. And this is the pathway. It goes to the spinal trigeminal nucleus, reticular formation, and facial nerve, which and if afferent is free nerve endings of the cornea. Abnormal response in the corneal reflex can be seen in obtunded or semi-commotate spaces, posterior fossa lesion, multiple sclerosis, and these brain stem strokes. Pupillary light reflex, this is also very commonly used in the emergency practice. It is an autonomic reflex which is acts to the parasympathetic receptors. It has got a protective role and afferents of pupillary fibers, which goes to the optic nerve tract. And from there, the efferent will be coming from the parasympathetic preganglionic fibers through oculomotor nerves, and then it goes to the iris sphincter smooth muscle via M3 muscarinic receptors. And of course, since Edinger-Westphal has got bilateral this thing, and it is crossing on both the sides, we get a direct and consensual pupillary response at the same time. So this is a normal response that we get. Normally, both people will constrict. If we have got cranial nerve, that oculomotor nerve lesion, we have loss of consensual pupillary light reflex. If it is ophthalmic lesion, then loss of direct pupillary light reflex will be happening. So it is absence in brainstem lesion, which becomes sluggish in CNS depressant drugs. Similarly, pupillary dark reflexes, contrary to the constriction in the light, dilatation of the pupil in the response to dark or generalized sympathetic response. So normal pupils return to their usually returns to their widest size in 12 to 15 seconds after going to the dark. But there is a dilatation lag that will happen if the pupillary dark reflex is affected, which is seen in the Horner syndrome. This is the pathway of the pupillary dark reflex. Ciliospinal reflex, we have talked about the ciliospinal reflex in Horner syndrome. It is a pupillary dilatation in response to noxious stimuli, such as pinching through the face, neck, or upper trunk. Afferent here is trigeminal nerve and cervical pain fibers, and efferent is sympathetic fibers from the upper thoracic and lower cervical spinal cord. It is very easily elicitable in barbiturate-induced coma, and absence in Horner syndrome because of loss of sympathetic input to the pupil. We have this Westphal-Pils reflex, which is a common physiological reflex, which is a pupillary constriction in the darkness or as part of closing eyelids when going to sleep. When we go to sleep, this happens to all of us. It is due to central disinhibition of the oculomotor nerve. Then we have this very important reflex, which is vestibulo-ocular reflex, which is the which allows for the eye movements in the opposite direction of head movement to maintain steady gaze and prevent retinal image slip, so that we are able to make the image properly. It's a protective reflex, and it can also be elicited with the cold and warm water. We have read about it in our clinical practice again. This is cold water, which usually goes to the same side, and warm water, it will go to the opposite side. This is normal response. And again, this is all we know about doll's eye reflex, which is like in the direction of the rotation, it will go against the direction of the rotation, which is a normal response. So when the brainstem is affected, so then we have to it becomes a reverse thing, and when the bilateral middle fasciculus is affected, this is what it happens. It will go to the cold water side, but one whichever side is affected, so we will not be getting response in that one. And in brainstem death, we observe no response with the cold calorie test. So this is a Bell's phenomena, which is seen in mostly in the facial with paralysis and lag ophthalmos. Actually, it is a normal phenomena, which is an upward and lateral deviation of the eyes during eyelid closure against resistance, which is present in 90% of the population, but it becomes very evident in lower motor neuron facial paralysis. So as they cannot use this ipsilateral side for forcefully closing the eyelid, we can see the lateral and upward deviation of the pupil here, the cornea here. It is absent in idiopathic epilepsy, Sturge-Weber syndrome, and tuberous sclerosis. Then lacrimetric reflex, all of us cry. So it is a tear response, secretion in response to physical and chemical stimuli, and bright light, emotional upset, or vomiting, coughing, and yawning. Afferent here is ophthalmic branch of the trigeminal nerve here, and plus it also goes from gustatory afferents. It has also got gustatory afferents here. From here, sorry, it's here. Efferent is parasympathetic postganglionic fibers traveling with the lacrimal nerve, and abnormalities can lead to hypolacrimation or hyperlacrimation or inappropriate. Yes, and one of the kind of defect of this lacrimetry reflex is a gastrolacrimal reflex, which is also called crocodile tears, which is a unilateral lacrimation when a person eats or drinks. It follows the Bell's palsy or traumatic facial palsy. It is due to misdirection of after regeneration starts happening. This is the misdirection of regenerative gustatory fibers from either the facial or glossopharyngeal nerves, which carries the taste sensation. This last reflex that we are going to talk about is optokinetic reflex or optokinetic nystagmus. It is served to stabilize images on the retina. It has got two components: a slow component and fast component. Afferent is from the retina, which goes to the visual pathway and reaches a pontine horizontal gaze center. From there, it comes back to the abducens and oculomotor nuclei and reflexively induce either slowing or rapid saccades movements of the eyes. It is used to assess visual acuity in infants and children. Thank you so much for your kind attention.
Thank you, sir. Now I would like our chairperson, Dr. Mariam Pauly, to answer a few questions and hand it over to her for the discussion part.
Thank you, Dr. Sumana. It was wonderful listening to all the talks. There are a few questions. Due to paucity of time, we are confining our discussion to 1 or 2 questions. The one question was like, how will you manage a patient on warfarin before cataract surgery? Regarding the role of INR, any other precautions to be taken? Any of the panelists, like Dr. Ashish?
Thank you so much. I thought person who does the pre-op will answer this, but what we do, I'll tell you. The patient on warfarin, we always check the INR, and we consult the cardiologist or the treating physician, and we find out what is the recommended range of INR, and we keep the patient in that range. And most of the cases we do on the topical, we carry out even with slightly higher INR also. We do not discontinue it. But if the INR is higher, then we may continue for a day or 2, depending on the INR, which is much beyond the range. The second point is when we want to do the vitreal retinal surgery, which we are, in fact, in our hospital, we do very little. So probably other people who are doing most vitreal surgeries can answer this question. But we very rarely we have transferred them to low molecular heparin, admitting in their physicians or nursing home. And we bring the patient in the morning for the surgery, send them back, and then put again them on the warfarin. And so we do a bridging, but that is a very rare occasion. Certainly with high INR, we do not do needle blocks. Anybody can opine on this?
Yeah, absolutely, sir. Dr. Tanveer, you're absolutely right. Actually, the reason for doing a patient who's on high warfarin is very rare. We generally postpone if the patient has had an acute episode of stroke or an acute episode of, cardiac event for which the warfarin is. But some patients who have had a valve and are on warfarin because of their prosthetic valves, they are safely done with under local with topical and subtenon. Yes, with subtenon you have some amount of conjunctival bleeding, but that is all right if the patient has been informed. And it has been very rare for the other types of surgeries that we have started bridging. But as sir has definitely said, we follow up the INR and we do it in consultation with the cardiologist, the surgeon, and the patient.
Dr. Rashish, a question for you. Are you continuing the echosporin on the day of surgeries also, or you are stopping?
Dr. Raja, thank you so much for asking this question. We have been not stopping. I would say we are not stopping clopidogrel or aspirin both for almost last 22, 23 years. And we are continuing even the needle blocks also with this.
Okay. So you are not even stopping clopidogrel also?
Yes.
You're continuing. Okay.
And unfortunately, we haven't faced any problem, but we do. We are very careful in the blocks we give.
We are also not stopping the echoaspirin, totally no, and clopidogrel also. We are rarely stopping. And for the warfarin, Tanveer, I think that you should divide continuation of warfarin or stoppage of warfarin between anterior segment surgery and posterior segment surgery. For both, the things are different. So for posterior segment surgery, if you say that subtenon block can be given safely with mild hemorrhage, but for the surgery per se, for vitreoretinal surgery, there are high chances of vitreous hemorrhage. So for anterior segment surgery, yes, but for glaucoma surgery, for oculoplasty surgery, and for vitreoretinal surgery, there is a very gray area. So it should be.
I was limiting to the cataract. For the cataract, we
cataract surgery, yes, warfarin, if INR is not too high, it can be continued, or it can be stopped for 2-3 days if you say, and no need for bridging. But because bridging also has some are the problems, because in the eye centers, which are standalone eye center, giving heparin infusion is also not very easy, and monitoring the coagulation profile. So many a times, yeah, Dr. Ashish.
No, you continue, finish your, then I'll make a comment on it.
Many times it is shifted to Clexane, not the low molecular weight heparin, but it depends. It should be always with the consultation of cardiologist before deciding. So ophthalmologist, anesthetist, and cardiologist, all three should agree about the stoppage, not stoppage, starting heparin or giving Clexane for the particular surgery.
The question I want to put is, these days, many of our patients are on the Rivaroxaban or other kind of newer anticoagulants, where we do not have any, in our country, we do not have any clue how to monitor that. It's a big issue. So sometimes physicians will tell you, stop it previous night and carry on surgery. Nothing has happened up till now, but nowadays we are getting more patients on these drugs rather than warfarin and comedine.
It is walking on a thin line.
Yes.
Whenever you will fall for quite longer time.
Yeah, but for cataract, we are doing mainly 90%. We are not bothered about that.
For cataract surgery, even the topical Subtenon and peribulbar in some cases, we are going with the thing.
Yeah.
But for antiplatelet, for warfarin, it is the different scenario.
Yes. Something
I think what is the indication of warfarin is very important. And if it is a decision of cardiologist, what he feels, whether it can be stopped or not. Ultimately, we can stop it in the most of the situation. If there are certain very situations where stopping them can be inviting for the problem, in that situation, bridging with heparin is very helpful. And we have to bridge few patients in a year for this kind of indication.
Yes, particularly.
And regarding newer drugs, it is really true. Those newer drugs are coming, and we can't test. We don't have any test to objectivize how much levels are there and that. So it is, it is all right to stop them prior to some 24 hours or 24 hours prior to surgery, and go ahead for. This is only for posterior chamber. Otherwise, for anterior chamber cataracts and all that, it is really very good these days if people can do it under topical to continue with those drugs, because this cardiac issue gets scared off. You are not bothered about it otherwise. Thank you.
Yeah, thank you all. One more question, like pacemakers and cautery, like clear corneal cataract doesn't matter, but when you do SICS, vitreoretinal surgery, oculoplastic surgery, and when the patient is on pacemaker, can we use bipolar, unipolar? Like, what's the take of twin? What is the take on from the panelists? Like, what is the dictum? What should we do?
Who wants to answer?
Regarding pacemaker, okay, if most of the surgeries where you are not doing any cautery, or even if you are using cautery in anterior chamber surgery, you don't adjust the pacemaker. Okay, you get a pacemaker assessed by the cardiologist regarding its functioning and all that. Right? You don't put in on an asynchronous mode. Only surgeries, vitreoretinal surgeries, where they are going to use the cautery actively, there you can think of, putting the patient on asynchronous mode, which invites a lot of trouble. Actually, you have to call the technician in the morning. We'll put the patient on asynchronous mode, then go away, then patient goes to the recovery, and then people keep on waiting for him to come to put him again on the patient. So we, in our clinical practice, putting patient on asynchronous mode is not very common. Is it okay?
I mean, can we use bipolar or unipolar?
Can I add something?
Bipolar is always advisable.
Hello.
Yeah, Dr. Sharma, cardiac anesthetist can opine on that.
Yeah, Dr.
No. There will be a difference between the simple pacemaker and AICD.
Yeah.
AICD is more troublesome, and bipolar can be used with caution, but unipolar, of course, not. Unipolar is not advised at all. Only bipolar can be used, but it is best thing is to call a technician in the morning. Second thing is, it depends upon which side you have put the pad. Pad should be on the ipsilateral side. It should not, your current should not cross side. Suppose you put the pad of the Suppose the pacemaker is on the right side and you put cautery pad on left side, you are going to be in trouble. So, no, put on opposite side is okay, but if you put on same side, you'll probably have a problem. So bipolar is, your question was bipolar and unipolar. Bipolar is more safer than unipolar. Unipolar is not advised at all.
Okay, thank you.
And if it is AICD, there's a difference between AICD and the simple pacemaker. AICD will give, moment the cautery is on, it might just give a defibrillation.
Okay.
Pacemaker will not give. And then the other things are there, you use a magnet to stop the pacemaker and all. But that all those things has to be done by a technician, not by. And of course, ECG monitoring.
Now nobody use the magnet there.
Magnet is not used at all.
People and see the things, and he is in high risk cases. He is always there till the surgery ends because they have a lifelong contract with the.
Yeah, they have live. They have to come, so you can call.
So they come, but the timings are so variable because it depends that in the cath lab whether they are busy or not.
Sometimes the patient doesn't have the card that which pacemaker he has put.
Yeah.
Or they don't remember which company they had. That also is a
high surgery, they don't have anything. You have to ask.
sometimes because they don't give that much importance to.
And sir, thanks to WhatsApp, we can call their home and they can click the pictures and we can get things down.
But unipolar is certainly no.
Okay. Yeah. Thank you, sir. Thank you all for your comments, valuable comments. I think we will move to the next session. Dr. Sumana, please take it.
So let's move on to quality and safety. I would like to invite Dr. Dilip Shinde. He's Professor RP Eye Center at AIIMS, New Delhi, to chair this session. Thank you.
Good afternoon, everybody, speakers, delegate, and everybody around there. We go to next session, which is very important regarding quality and safety. As we are progressing and becoming a developed world, quality becomes more important, and patients' expectations are reaching very high. So this is a very important session. I will invite first speaker, Dr. Indu Sen, Professor Anesthesia, PGIM Chandigarh, and she will going to speak about perioperative ONSD, optic nerve sheath diameter, which has become very important tool, especially in critical care area. So Dr. Indu Sen, please.
Very good morning to all of you. I'll start sharing my screen. I think somebody else is sharing. Okay, my topic is perioperative optic nerve sheath diameter estimation, a tool for the anesthesiologist. And I bring greetings from City Beautiful, that is Chandigarh. And this is the institute where I'm working. This is the outline of my talk. We'll talk a little bit about the anatomy, sonoanatomy, then how to estimate the ONSD, and then literature review, and a little bit of personal experience I have in this measurements. Well, the portable ultrasound has been referred to as the stethoscope of the 21st century. And the other thing is that we are able to connect it to our mobile phone to get the pictures. So we can not only listen, but we can visualize what is happening inside the body. And regarding my topic, when I did a PubMed search, I could retrieve some 667 articles. So the interest in this field is increasing. There are various applications of ultrasound in the perioperative scenario. And we can do the hemodynamic monitoring, the volume status management, identification of various cardiopulmonary pathologies, then airway management, fate, fast. But besides this, remember this ocular ultrasonography. It is a non-invasive, convenient, repeatable surrogate of intracranial pressure, and we can diagnose various conditions. Then in the end, I will talk about future perspectives in the aviation industry. And this is a study which has been recently conducted, where it was found that the handheld ultrasound was like equally valid and reliable in the estimation of ONST. So this is the anatomy, and as we see here, the central retinal artery and vein are present close to the optic nerve, inside the optic nerve, and it is surrounded by the three layers: pyometer, subarachnoid, and the dura mater. And this is the image we get on the ultrasound. It's important that we know our equipment, follow good ergonomics, like the ultrasound machine should be facing us, and use a high frequency linear ocular probe. Both the hockey stick as well as the linear probe can be used. And then apply jelly over the foot plate. What I'm doing is apply jelly and then place Tegaderm over it. And if I have to need additional media fluid for the good image, we just use a saline soaked gauze. So no need to apply jelly over the eyelid. Then place the transducer over the closed eyelid, taking care that avoid pressure over the globe. And then adjust depth and gain to get an image 3 millimeters behind the retina. Once you get a good image, just freeze it and use the pointer option to do the measurements, and they can be repeated. So this is how the eye looks on the ultrasound. If we place a probe in the transverse view, we get to see the pupil, and this is the iris, so the consensual eye reflux can be elicited. But posteriorly, if you make an angle of some 20 to 25 degree and get an anterior-posterior view, you can identify the optic nerve and can measure the optic nerve sheath diameter. Why 3 millimeters? Well, this has been validated by various MRI as well as CT scan studies, where the measurements were done at different levels, and it was found that 3 millimeters is the distance which corresponds very well. The sensitivity and specificity has been found to be, more accurate measures has been found. So this is a CT scan study in children, where it was found that they did the optic nerve disc assessment. In addition to that, they also did the transverse diameter of the eye, and the ratio was calculated, and it was found that this is a better predictor of the intracranial pressure values compared to the ONST alone. So here the area under the curve was plotted for this assessment. It was found that in 86% of the patients, it was well compared. In children, the index of ONST to the transverse diameter of the eye, the value has been said to be 0.21 in one of the studies, which was published in 2019. And this is another study recently published in 2020, where it was found that if a boil's mouth gag is placed for the tonsillectomies, it can cause rise in the intracranial pressure, and which can be measured by the ONST. So one has to be cautious in the intracranial pathologies. This is a study from the frontiers in neurology, where the ONST was compared with the MRI studies. And the author suggested that in MRI, the pituitary cellular ratio and the ONST both can be measured to get the more accurate values. Then in the emergency scenario, this is a study, it was found whether the emergency physicians will be able to do this measurement, and it was found that 100% of the pediatric emergency physicians could accurately measure the ONST, and they could also detect the optic disc elevation using an ultrasound. But compared to this, when the fundus examination was done, that was accurate only in 40% of the patients. Recently, a protocol has been published, and this is the closed protocol where the authors have used color Doppler. And as we saw in the anatomy, the central retinal artery and vein is there. So this can be identified when we put the Doppler mode on our machine, and you can identify the central retinal artery and vein. On the side of this is ophthalmic artery. So if we put the Doppler waves, they can be seen as with their characteristic dichrotic notch, and medial to this will be the optic nerve sheath. So more accurate measurements can be done using this technique. Authors also propose that we should do dual measurements, that is the transverse at an angle of some 25 degrees and the like sagittal measurements. So this will overcome inter-rater variability and the possible artifacts which are there due to setting changes in the ultrasound machine. And this is the autonoma, that is the automatically and algorithmic approach can be used to measure the optic nerve diameter. So various like meta-analyses and systemic reviews have been published. In this study, in 2019, like 40 studies were analyzed, but this was a retrospective data of 5,000 participants. And the comparator was invasive intracranial monitor. And the author said, well, this ONSD can be used to find out whether we should refer a particular patient to the higher center or not. And this is very recent in 2021 in an ultrasound journal. 90% of the studies were prospective and 80% were comparative. And the value which was finalized was raised ICP of more than 20 millimeters of mercury is equivalent to the ONSD value of 5.82. And in this study, authors have used, they have stratified this ONSD with etiology based upon the diagnostic methods used, like CT, MRI, lumbar puncture, then in different hospital settings also, like in the ICU, in the emergency department, in the clinics, and in the operating room environment also. And the forest plots were plotted, and then the measurements were done. And as you say here, this is a good, heterogeneity is very less and it can be used. In children, attempt has been made to find out the optic nerve growth curve, and it was found that optic nerve grows up to the age of 10 years. So the values are different. For 4 to 10 years of age, the cutoff has been taken as 4.10. For 11 to 18 years, it is 4.40. But less than 1 year, we must consider that fontanelle will be open, so there will be variation in the ONSD values. And this is a recent study published in Curious from my institute, where the ONSD was correlated with intraventricular intracranial measurements in predicting dysfunctional intracranial compliance. And they compared different ICPs like 20, 30, 35, and tried to find out the ONSD threshold, and it was 5.5, 6.3, 6.5, and 6.7, depending upon the rise in the ICP. In fetus also, ONSD has been measured to rule out life-threatening intracranial abnormalities. This is the 3 case reports which were compared with the normal children, normal fetus, and it was found that the distance which should be used for the measurement is 2 millimeters in the fetus. So besides other monitorings, ultrasound is need of the hour in our operating room. This is an ongoing study which I'm doing, where in the hydrocephalus patients, we are trying to establish the values. We are doing a pre-operative ONSD measurements, and then after placing the shunt, serial measurements are being done to find out the functioning of the shunt. So this is a study in British Journal of Anesthesia, where it was found that caudal block, if the drug is injected, the high volume is injected at a faster rate. There are changes in ICP which can be shown by the ONSD. Similarly, during epiduroscopy, if the speed of injection is fast and too much volume is given, it can be hazardous. In preeclampsia, in pregnant patients, it has been used. In the interventional suite, like thoracoabdominal aortic aneurysm repair, it is known to cause transient spinal edema, and this can be elicited by ONSD. So accordingly, the management can be done. Well, the robotic surgery is one area where a lot of work has been done on the optic nerve sheath diameter because, as you know, in this environment, it is difficult to do the readings. So most of the readings have been done before and after the procedure. So steep Trendelenburg position was blamed that it causes a lot of rise in intracranial pressure. A meta-analysis was done, and it was found that this rise occurs at all the times, early as well as late. And then certain drugs were tried to find out whether they can reduce this rise in intracranial pressure. So mannitol was found to be effective. And then this is a study where age was related, and it was found that the patients who are less than 60 years, the autoregulation is better, and they can be more compliant to the steep Trendelenburg position. So the changes are less. This may be used as a criteria for taking these patients for the robotic assisted surgeries. Then, and in another study, the authors have found if we initially they do the reverse Trendelenburg position and then create the pneumoperitoneum, the changes are less compared to if the pneumoperitoneum is created in the supine position. Then various agents like DES versus Tiva has been used, sevoflurane versus propofol has been used, and it has been found that the total intravenous anesthesia is better and it causes less rise in intracranial pressure and thus ONSD. This is a study done from my institute where we used orogastric acetazolamide in laparoscopic donor nephrectomies, and it was found that at 10 minutes and 60 minutes after creating the pneumoperitoneum, the changes in the ONSD could be well managed. There was no rise compared to the placebo group. Dexmedetomidine has been used. And then this is a study where CO2 insufflation pressures, it was found when high insufflation pressures are used, they can cause rise in ONSD. So pressure, CO2 insufflation pressure should be less than 10 millimeters of mercury. Then liver transplant surgery, because these patients are have coagulopathies and there is high ICP, so it is not advisable to put the invasive device. It has been like ONSD can be used. Similarly, this is another study where it was found that in ventilated patients also to predict the prognosis as well as to see the effect of ventilation, this measurement can be done. This is another study which we had done where optic nerve sheath fenestration was done endoscopically. So we did the ONSD measurements before doing the procedure and after the procedure, and this was found to be a good predictor. But this was just a preliminary study of 10 patients. In resuscitation and in hypoxic brain injury to diagnose brain death, the attempts have been used to maze this technique. You will agree with me, this is not a situation where patients are to be shifted for some investigation like CT or MRI, though the final diagnosis can be done with these investigations. So this will give us an indication, okay, in this particular patient should be investigated. So this is a publication from the transplant proceedings where it has been found that cadaveric organ donations can be improved if we can diagnose brain death early using this non-invasive technique. Similarly, during transportation, it has been suggested that if patients' head rest is raised by 30 degrees, the effect of brakes on the ICP will be less. So this is an interesting article from NASA where they have found that there is a condition in the astronauts because they spend a lot of time in the microgravity environment. So there's visual improvement and intracranial pressure changes occur. So this is a typical syndrome. So it is the studies are ongoing. It is said that ONSD may be used as a biomarker to for the pre-flight identification of astronauts who are at risk for developing this syndrome. So to summarize, ultrasound-guided ONSD, it is a safe, non-invasive, radiation-free technique. It is easy to perform. It is repeatable, and it can predict changes in the intracranial pressure. So, and the ratios are better, and we need to do the multiple measurements. both in the transverse as well as in the sagittal plane, and accuracy can be further improved using the closed protocol. However, no machine, whatever sophistication is there, it can match a vigilant, caring human mind. Thank you.
Thank you. Thank you, madam. Now, before we move on to the next session, I would just like to say to keep all the questions towards the end of the session. We will not be answering in between the talks. Now, I would like to call Dr. Chandrasekhar to talk on quality of care in an eye care center. Madam, if you can just stop sharing.
Yeah, I did.
Thank you.
I request all eminent speakers to stick to time. Thank you. Thank you, Dr. Indu.
Thank you.
Our next speaker is Dr. Chandrasekhar, and he will be talking about quality of care in an eye care center.
Hello, can you hear me?
We can hear you, but we can't see any slides. Yeah, yeah, it is there now. Yes.
Can I go ahead?
Yeah, please, sir. Please go ahead.
Good morning. I am bringing the greeting from Retina Institute of Karnataka, Bangalore, along with Dr. Iris. And my topic will be on quality of care at an eye care center. And lecture focus will be the need for a tool to measure our quality of care. Recent advances in the medical field includes enhanced recovery after surgery, fast tracking, artificial intelligence, virtual reality, smartphone information technology, digital world, including electronic medical recording, online teleconsultation and clinic in the post-COVID status, minimally invasive techniques like MIS, phaco, and for daycare surgery, we use balanced anesthesia and MAC. And the latest is about the quality care and the request for an assessment tool. WHO Quality of Health Care insisted that after advocating safe surgery saves lives since 2012, recently it has drafted a guidelines on improving the quality of health services under national quality policies and strategies. And first is requires a framework, indicator, and tool for quality care measurement. And most importantly, we have to partnership with the patient in the team. What is partnering with the patient is by partnering patient through media. We can have improve our telecommunication modes. Patient tell us very powerful and educational experiences. Such a partnership will improve our understanding of the patient perspective, anxiety, and what are the measures that we can take. And also it improves our performance. So preoperative online clinics is the new and important element, especially under COVID situation, which is mutually beneficial for both doctors and the patients. So this is the diagram, what WHO recommends. So we are at crossroads to know what is quality, what is standard, and what are our safety goals. Quality is begin with ensuring the patient's safety and satisfaction. And it must be free from complications, anxiety, and incidences, and any disappointment. At the end, we want to have a satisfied patient. So quality is so what we do what you say, prove it, and improving it. So it is involvement of healthcare givers and the receiver is like a bus with 20 steering wheels, with having surgeon, PRO, and other staffs. The quality of assurance. Quality is a degree of excellence for a specific purpose, a measure of how good or how bad the service is, an indicator of professional achievement, and a fundamental to our market. Leadership should be committed to provide a high standard quality care. So quality product, what is that we are trying to achieve in error-free service and make that journey to the hospital a rewarding experience by the patient. To produce the quality product, to educate staff about the importance of the quality care, leadership, and integrity and follow-up of the patients after discharge. So what are the technical measures that we can have and the skills that we have is technically what patient receives, qualitatively is functional service of the patient. When you compare the quality and standard, the comparison with the set standard clinical guidelines to improve our quality. These guidelines are systematically drawn as statements and assist our care. So fortunately, we have got the NABH now. It requires the quality against set standards and from the Australian Medical Board and dictates our guidelines, builds our confidence in our patient and brings credibility to the institute. And most recently, NABH has introduced our standard for the eye care organization, giving more information and more standards for our clinical approach. So it has got a rating scale and it about the dropouts and registered and unregistered patients, complaints, and staff attrition. And we have introduced the patient feedback after as soon as the discharge is there, so that they will assess the service that they received out our institute. So preoperative preconditioning is one of the approaches to reduce the anxiety on the part of the patient. So anxiety and stress is the profile that if you attain that or attenuate this one, it will improve the final outcome. And especially we know that the daycare new patients have experienced significantly higher levels of preoperative stress anxiety than the inpatients and who have undergone surgery already. It recommends preoperative assessment of the stress anxiety profile, providing appropriate counseling and preconditioning. So patients have got will have concerns about the surgery outcome and the financial implication and whatnot. So newer approaches about the partnership with the patients are trust building. How we can do by trust building is through the educating the patient, providing all the information about the surgery and the requirements. And the UK healthcare has come out with a simulation-based patient education by giving a virtual tool of our institute and various sections of this one, and with a provision for audiovisual pictorial information and question and answering. And there are many journals have come out with editorials about the smartphone-based information technology. It will assess the preoperative anxiety using color analog, and also online preparatory information can be provided by using smartphones. And especially in dentistry, they have used a smartphone by cartoon depicting simulated simple dental procedure. Well, they'll be familiar with the technology that they use and the procedure that they have undergone. The preconditioning is another aspect, especially those who are coming for eye surgery. The preconditioning with the preoperative eye patch is one of the thinking that they have done. They have got a paper, visual preconditioning and emergence delirium. We are also following this study, and our results will be published next Preconditioning in hearing impaired children, what we do is we go to the ward and tell them, show them the circuit that they are going to and how to breathe. Is the child in the preoperative area. Perioperative care is very, very important. Patient concern is when we are ill, we want to know that we have a doctor who will treat us empathically with respect and courtesy to which we are entitled. So Maharishi Charaka, in the earliest recommendation is that a good physician nurtures affection for his patient exactly like mother, father, brothers, and children. A physician with such a quality gives a life to patient and cures their disease. A.K. Grover in Presidential Address also said the same thing, expressed the same similar thing. Put yourself in patient's shoes and behave exactly as you would like a doctor to us. Unique and privileged association with the patient builds a confidence and trust by friendly communication, full attention, providing full information. Our hospital reception desk is the most important connection between the patient and the hospital, and it should provide all the information that is required. Communication with the patient is the thing that we have to train our reception staff and the PR. And there's a fear of prolonged waiting after eye drops. So to prevent that one, we have got different colored slips for a new patient and a review patient. Review patient need not go through waiting period. And we have got a red dot for those who are wheelchair patients and emergency patients. They are, and also immunosuppressant patients are treated differently. Counseling is the most important bearing on the outcome, and patient counseling is where surgeon will appraise the patient and give the full information about the condition. At the same time, your patient counselor also discuss in native language at a leisure hour and clarify all the doubts. We also provide them with the information material. We have got a booklet for communication about retinal detachment. And also at the end, we give them a card giving them all the instructions. PAC by the anesthesiologist is very, very important to know how far we can optimize the patient before surgery. And most important thing is appraisal about the claustrophobia, and that is done by showing them the video. And appropriate consent is taken and patients are assured. And other anxiety is about the wrong patient and wrong eye that has been taken care by the surgery checklist and color coding of the PAC charts and also wristbands that with name and other details. And we also put one marker also and also wristband. This child has undergone, this just shows that it has undergone infected condition and it has got all the marks. How to ensure quality of anesthesia is following the ASI guidelines, PAC optimization and counseling, and preoperative checklist. Patients should be comfortable, confident on the table, and we give a pillow under the knees that will make them comfortably lie down on the table for more than 90 minutes. Surgeon, they don't want any distraction from the patient side. Anesthesiologist will do the monitor anesthesia care. He is forward to tackle any untoward instance of situation. Clean techniques, no injuries or errors. Detailed postoperative documentation, discharge summary. Now it has become a digital world. We can get all the patient information and also record it on the monitor. And drugs trials are there, are going on with so many different drugs. So what we are concentrating on beta blocking agents with availability of a drug with attain and still combination, and we are using it preoperatively, and our results will be of this zone. Regarding the hospital infection and control process, though we use water care, this one, we don't come out with water at the end of scrubbing. We always come out with betadine, and then it will be wiped, and then again chlorhexidine is used. And we got a color coding and care for the regular surgery and also surgery with the infection. And we have got all the micro instruments are inspected after cleaning, and also we have got ultrasonic cleaner, especially for the sharp instruments. Discharge formalities are very, very important, and we have got a discharge criteria and educate the attender what is drop of installation. Also, sometimes we tell them how to take the photographs, and WhatsApp message can be given post-operative if they cannot come for post-operative follow-up. Home ready discharge summary and copying the discharge summary to the referring doctor is very, very important so that the patient can reach them quickly earlier than coming to the institution. Post-operative follow-up instructions are very, very clear, and we follow them by WhatsApp or by phone. Next follow-up appointment, emergency contact number, and safe travel are the other things that we take into consideration. The roadmap for this one is there is no magic bullet. Implementation of quality care and scoring is not easy, involves extra effort, demands thoughtful approach that creates a sufficient pressure to bring about awareness and willpower to improve partnership with the patient for a satisfactory outcome, adopt a newer technology to introduce scoring of quality care. The summary is that there is an enormous potential for giving importance to reduce the stress by preconditioning the patient by pre-operative clinics and intraoperative clinics. Keep track of the patient of any untoward incidents and post-operative management and follow-up. Thank you.
Thank you so much, sir. Now I would like Dr. Suman Shri from Netradama Super Specialty Hospital to talk about cockpit drill before ophthalmic anesthesia.
Our next speaker, Dr. Suman Shri. She will be
Good morning.
with cockpit drill. Okay. Okay, Dr. Suman Shri.
Am I audible and visible, sir? Is my PPT visible?
Yes, you are audible as well as visible. Please go ahead.
Thank you very much. Namaste and welcome aboard the flight AIOA S001. This is your captain, Dr. Suman, from Netradama, Bangalore, flight deck, initializing cockpit drill before ophthalmic anesthesia. Bon voyage. Comparisons have always been drawn between anesthesia and aviation since time immemorial. Cockpit means a control center, and for us, it is our anesthesia workstation. Anesthesiologists check their machines using a cockpit drill. We ensure the pneumatic, the electronic, the electrical components are safe to use. It includes critical resuscitation equipment, drugs, pre-procedural patient protocols like your pre-anesthetic evaluation, your anesthetic plan, your written informed consent. These guidelines were developed in 1986, modified in 1983. Now, the recent guidelines are the pre-anesthesia checkout procedures of the ASA Committee on Equipment and Facilities, 2008. So what are the objectives of this talk? It is to outline the essential items that need to be available, functioning properly prior to delivering every anesthetic. We identify the frequency of checks for each item, and we suggest which item should be checked by whom. So the requirements for safe delivery of anesthesia care are a reliable delivery of oxygen at any appropriate concentration up to 100%, reliable means of positive pressure ventilation, a backup ventilation equipment, available and functioning, controlled release of positive pressure from the breathing circuit, anesthesia vapor delivery, an adequate suction, and a means to conform to standards for patient monitoring. Now let us look at the summary of the 15 items. They have items to be completed, who is responsible, and whether it's the start of the day or before every anesthetic. I'll go through each item in detail. Number 1, we verify the auxiliary oxygen cylinder and the self-inflating manual ventilation device, usually an ambu bag, whether it is available and whether it is functioning well. Number 2, verify the patient's suction is adequate to clear the airway. It could be centralized or an independent unit. Number 3, turn on the anesthesia delivery system and confirm that the AC power is available. We do what is known as the power failure test and ensure there's adequate battery backup of the machine. Number 4, we verify the availability of the monitors and check all the alarms of all the various monitors available. Number 5, you verify that the pressure is adequate on the spare oxygen cylinder mounted on the anesthesia machine. And we have to ensure that at least minimum 100 PSIG or half full cylinder is always available. And we have to check for this dial. We verify that the pipe pressures, especially the oxygen, is more than 50 PSIG. We can perform the tuck test on the pipelines to ensure there's a minimum of 50 PSIG and there is no hissing sound which is audible. Number 7, you verify that the vaporizers are adequately filled and that the filler ports are all closed. You should check for the smooth movement of the vaporizer dial over the full range. Now we verify that there are no leaks in the gas supply lines between the flow meter and the common gas outlet. Basically, you're checking the low pressure system for leaks in the machine.
No sound.
Dr. Suman, there is no sound.
There is no audio to video. Dr. Suman, there is no audio to video. Okay, anyway.
You couldn't hear me, sir?
No, we could hear you, but the video didn't have any audio.
Oh, it has an audio, just a minute.
Okay, that's okay, fine.
Share sound. When you share it, share sound.
That's okay.
Test for the negative pressure leak test.
Can you hear me now, sir?
Okay.
Okay.
Universal leak test or the negative pressure leak test. Attach the suction bulb to the common gas outlet. Ensure that the switch is in the open circuit mode. The machine is in the off position. The vaporizer is closed. Then squeeze the bulb until it is fully collapsed. It should remain in the collapsed position for at least 10 seconds. Then it confirms no leak in the low pressure system of the anesthesia machine.
Next, we go on to the flow meters. We should turn the machine on. With no flow, the bobbin should reach 0. And the bobbin should, once it is on, it should rotate very freely. And we can create a hypoxic mixture just to see if the anti-hypoxia guards are working. Then if you have a scavenging system, you ensure the negative and the positive pressure relief tests are fine. Then we also have to calibrate the oxygen monitor and check for the low oxygen alarm. This is usually done when the sensor is being replaced or there's a change in elevation. It need not be done every day. Usually once a month is adequate. We also verify the carbon dioxide absorbent is not exhausted. Look for the change in color of the soda lime and change it if there is desiccation. Then we go on to the item 12, the breathing system pressure and leak testing. It should be performed with the circuit configuration that you're going to be using during your present anesthesia delivery.
The APL valve test. ensure that the machine is in standby mode. The selector switch is in closed circuit. Then we set all the gas flows to minimum. We close the APL valve completely. We occlude the white piece. Then we inflate the reservoir bag up to 30 centimeters of water. And we ensure that the pressure remains in the reservoir bag for at least 10 seconds. And once it is checked, we open the APL valve. This confirms the integrity of the APL valve. The manual ventilator circuit leak test. Ensure that the machine is in the standby mode. The flows are minimum. The switch is in the ventilator mode. Then we occlude the white piece and fill up the bellows with the oxygen flush. There is no leak as long as it does not fall below 100 ml per minute, and we also ensure that the pressure remains less than 15 centimeters of water. The automatic ventilator circuit leak test. Switch on the anesthesia machine, connect the test lung to the white piece, then set the ventilator settings which are patient specific. Switch on the ventilator switch, set the flows to minimum, fill up the bellows of the ventilator with the oxygen flush, and then verify that the bellows fill appropriately and the ventilator displays the correct data according to the ventilatory setting. Ethics test for integrity of paint circuit. Switch on the anesthesia machine, occlude the patient end of the paint circuit, close the APL valve, flush with the oxygen flush, release the patient end and also flush. Due to the Venturi effect, the back collapses. This confirms the integrity of the inner tube of the coaxial paint circuit.
So these are the various tests for integrity of the breathing system. Now number 13, verify that the gas flows properly both through the breathing system during inspiration and the expiration, for which we have the modified pressure decline method. We need to put an extra reservoir bag on the inspiratory port. The other bag is on the bag mount. The fresh gas flows are minimum. APL valve is closed. We need to pressurize the circuit with the oxygen flush. If the bag on the bag mount is inflated, that means the expiratory valve is competent. Now, we open the APL valve, and if the reservoir bag on the inspiratory port does not deflate, the inspiratory valve is competent. Finally, in the 14th item, we document the completion of the complete checkout procedure in what we call as an anesthesia machine checklist. We have some tests done at the beginning of the day and some tests done before every anesthesia delivery. So we have to be careful, and this is part of the patient medical record. This is what we do in Netradama before every GA case. In case you anticipate a difficult airway, especially since pediatric general anesthesia are very common in an ophthalmic setup, please keep your difficult airway trolley ready and completely functional. Then before any regional ophthalmic anesthesia, we have an ophthalmic block safety checklist, which includes documentation of these eye to be operated, your biometry, the axial length of the eyeball before giving the regional anesthesia, and the preferred position, and then also the weight of the patient, calculation of the maximum safe dose of the local anesthetic cocktail you're planning to use, or if it's a single anesthetic agent, and then any complications, regional or systemic complications are documented in this checklist. So you're completely ready for the block. And most important, whether it is general anesthesia or regional anesthesia, your crash cart has to be ever ready. Eternal vigilance is the most important aspect of an anesthetic care.
And most importantly, in ophthalmic anesthesia, not only adrenaline, injection Lasix, because the commonest complication I have seen is acute pulmonary edema on table, acute LVF. So please ensure that injection Lasix is always available, apart from all the, and also you should know at which level, which drug, which equipment is available. So we need to have a well practiced code blue drill always ready in the OT. And you have your defibrillator and all the other emergency drugs. There is a mnemonic which is commonly used by many anesthetists. It's called as MS MAIDS. M for machine, that is your ambu bag or ventilator. S for suction. Then the MAIDS would be M for all your monitors, especially your oxygen saturation with the tone which is audible, because most often we are listening to the sound and we are very happy. A for the airways, your endotracheal tube, your stillets, your laryngeal mask airways, your blades, your laryngoscopes. I for the IV fluids, flowing and functional. D for drugs, anesthesia and your resuscitation drugs. And finally S, a special equipment like your blocks, your regional anesthesia equipment, difficult airway trolley, your IV infusion pump for intravenous sedation with Dexmed, etc. So remember MS MAIDS at the end of the day. Very easy to remember too. So coming to the conclusion, the cockpit drill is vital and critical for patient safety and reducing risk, not only for the patient, definitely for the anesthesiologists. Thorough understanding and training update about your own anesthesia machine is very essential for safe practice. Checks should be adapted to the local needs for much better compliance. The pre-anesthesia machine checks do not replace your regular preventive maintenance. And most importantly, if all else fails, use your ambu bag to ventilate. It is your parachute for safety. Thank you very much. And I would like to take this opportunity to thank Dr. Jay and Dr. Pushpa for reposing their trust in me and for choosing the AIOA Airlines. Thank you.
Thank you so much, madam, or I should call you captain actually now. Moving on to our next presenter, Dr. Jay Chandran from Shankara Nethralaya. He'll be talking about incident reporting, root cause analysis, and action.
Can I start?
Yes, sir.
The slides are seen, no? Okay. Slides are visible?
Yes. Yes, sir. Yes, sir.
Okay. Good morning, everyone. Following Dr. Shuman Sri's lecture on how to prevent an adverse event or incident happening, now we will see what happens if an incident has occurred. That is incident reporting, root cause analysis, and action. Now, this is how I thought I will approach this topic. First, we will see why an incident has to be reported. Then we will see what are the different types of incidents that can occur. Then how to do a root cause analysis, tools used for RCA, and corrective actions taken. Last but not the least, I will be sharing how we practice safety culture at our institution. As Dr. Shuman Sri rightly pointed out, the concept of patient safety has been derived from aviation industry. Now, in aviation industry, despite the number of worldwide flight hours doubling over the past 20 years, the number of accidents has fallen from approximately 450 to 250 per year. Whereas in healthcare sector, in USA alone, there are estimated 2 lakhs preventable medical deaths every year. It amounts to the equivalent of almost 3 fatal airline crashes per day. If that is the case, then airline industry, everyone has to close and no one will be allowed to fly until this problem is solved. Now, why this happens? This is because of the various reasons. One of the important reason is incident reporting. In aviation industry, incident reporting is strictly enforced with rules. Incidents are thoroughly investigated and immunity is often a part of the reporting culture. Whereas in healthcare sector, incident reporting, it lacks strict rules, proper investigations is not conducted, and it lacks immunity also. And this is one of the main reasons why more adverse events are reported in the healthcare sector when compared to the aviation industry. And that is why incident reporting is very, very important. Now we will see what is an incident. It is nothing but an event or any circumstances that could have or did lead to unintended and or unnecessary harm, loss or damage to a person. Now 4 types of incidents are possible to occur. 1, no harm. Next is near miss events, adverse events and sentinel events. Now we will see one by one. No harm. Unexpected event reached the patient, but no harm has occurred at that time and no potential for harm realistically exists in the future too. For example, when a wrong eye drops has been instilled, but there is no effect has been observed. What is near miss events then? It is an unexpected event did not reach the patient because of timely intervention. For example, just before starting that IV infusion, a fungus detected in the IV bottle. Accidentally plaster falling from the ceiling, but luckily no one was injured. So these are all comes under the near miss events. The reporting time frame can be the same day or maybe the next day morning. What is the importance of reporting no harm and near miss in an organization? It provides an opportunity to examine failure points existing in a system. It is a proactive method to improve a system before any significant event occurs. Addressing these defects provides an opportunity to strengthen defenses and prevent future harm to occur. Hence, in an organization, it is very important to report no harm or near miss, and this must be encouraged or it can be rewarded too. What is the definition for adverse event? It is an unexpected incident related to system or process failure which caused damage that was not serious or lasting. Now, Institute for Healthcare Improvement, IHI, defines adverse event as unintended physical injury resulting from or contributed to by medical care that requires additional monitoring, treatment, or hospitalization. For example, a medication error resulting in minor allergic reaction to a patient, plaster falling onto the patient leading to minor injuries, slip or a fall resulting in minor injuries. These are the things that comes under the adverse event, and it has to be reported within the same day, within 6 to 8 hours. Sentinel event. It is nothing but an unexpected incident related to system or process failure which caused death or major enduring loss of function that lasts for at least 2 weeks. For example, a medication error resulting in death or severe complication, plaster falling on the head resulting in death, wrong site, wrong patient, wrong surgery, instrument or any sponge left in the surgical site by mistake. This sentinel events has to be reported immediately within less than 2 hours. Now, once the incident is reported, it is important to do a root cause analysis for the incidents. What is a root cause? Root cause can be defined as a latent vulnerability in a system that allows an incident to occur. Root cause analysis means it is a retrospective, reactive analysis that is initiated in response to any adverse event. But remember, RCA should be performed for any serious patient safety events only. The 5 basic steps in RCA involves, first and foremost, you should define the problem, gather data, identify possible causes, then identify the root cause. Finally, you should implement the solutions for it. The commonest and simple tool that is used is the 5 whys. You define the problem and keep asking the question why 5 times. They say that you will come to the root cause for the problem. But unfortunately, this is not a proper technique because it is not suitable for all the problems and it forces the experts to a single root cause only. Results can be biased and it can be variable also. There are various other powerful RCA tools like flowchart, cause and effect diagram, Pareto chart, and run chart. Flowchart is nothing but a pictorial method for showing all the steps or parts of a process that make up the system. As we can see in this flow chart, if there is any delay in action, we will come to know that is the root cause for the problem. Similarly, if there is any delay in the decision, we will come to know that is the root cause for the incident. Next, cause and effect diagram. It is a visual tool to communicate the factors contributing to a particular problem. Now, these causes are grouped into categories like material, method, mission, manpower, measurement. And these are in turn connected to the issue in a fishbone style of diagram. Hence, this cause and effect diagram is often called as fishbone or Ishikawa diagram, following after the founder, Professor Ishikawa, who discovered this diagram. Coming to the Pareto chart, this is nothing but a bar chart in which the multiple factors that contributes to the overall effect are arranged in a descending order according to the magnitude of their effect. This ordering is important because it helps the experts to concentrate its effort on the factors. As you can see in this diagram, the number of incidences reported is more from the bar coding followed by wrong reporting, and thus we come to know this is the most commonest cause for the incidents. Lastly, run chart. It is nothing but graphs of data over time. It helps us to know if a change is an improvement over time or just a random fluctuation wrongly interpreted as a significant improvement. Here we can see in this diagram the number of falls reported is more in the month of February and March, whereas in the month of September and October, the number of falls is drastically reduced. So it helps to identify if there is trend. Now, what are the drawbacks in RCA? First, the term RCA implies that there is only one root cause. But as you all know, healthcare is complex and many contributing factors must be considered in understanding why an event occurred. Secondly, the term RCA suggests that analysis is the ultimate goal, but the ultimate purpose should be corrective action. Hence, in the year 2015, the National Patient Safety Foundation termed the RCA as a updated version called as root cause analysis 2. Now, coming to the corrective actions, it can be a stronger, intermediate, weaker. Stronger actions may not totally eliminate the vulnerability, but remember it provides very strong controls. For example, simplification and standardization of any procedure can result in a stronger corrective measures taken. Similarly, engineering control, that is called as forcing function, it eliminates the use of universal adapters and peripheral devices for medical equipments. These are all things that comes under the forcing function. So these two can result in stronger corrective actions. Next, coming to the intermediate corrective actions, actions are somewhat dependent on staff remembering to do the right thing. For example, eliminate or reduce distractions in an operation theater, education using simulation-based training, introduction of the checklist, removing look-alike and sound-alike drugs. These falls into the intermediate corrective action measures. Coming to the weaker corrective actions, actions that depends on the caregivers to remember training or what is written in the policy. So, introducing double checks, warning alarms, new change in policy, training, these are all comes under the weaker corrective actions. Thus, you can see in the corrective measures, standardization and simplification of any procedure is a very, very important to prevent any untoward incident happening, whereas change in policy, training, inspection is a weaker corrective action measures. Now, the final report that should be submitted for the administrators or for the stakeholders should include the description of the RCA2 team members who are involved, description of the investigative methodology used, a clear description of what happened with the final flow diagram, the root causes and contributing factors identified must be mentioned, and finally, action recommendations should be given to them. Last but not the least, I would like to share our experience, how we practice safety culture at our institution. This is the incident reporting form that we have introduced. As you can see, it varies from medical to non-medical. That is, it ranges from clinical incident to fire, work, theft, everything. We have a hospital safety committee, which consists of chair, and that is myself, followed by co-chair, medical and non-medical safety officer, and we have about 50 committee members. Now, once the incident is reported, once in a month, we meet and try to analyze if there is any system corrections or system needs to be improved in the organization. We effectively communicate to all the employees that incident reporting is a just culture. That is, it is blame free, but at the same time, accountability also should be there. Also, for employees who are reporting near miss and no harm, we certify them every month with the best patient safety campaigners. To conclude, safety should be part and parcel of everything, whatever we do, whatever decisions we make. Safety implications must be taken into account. Currently, visible islands of excellence, that is vast knowledge, in a sea of invisible failures, barriers with risk lurking just below the waterline exists. It requires a lot of time and patience to widen those islands of excellence and to connect these islands with more dry lands. Remember, safety begins with teamwork. And I am happy to share that in India, I am one of the few healthcare professionals to have received this certificate, that is Certified Professional in Patient Safety by Institute for Healthcare Improvement, Boston. Thank you all.
Thank you so much, sir. Next, I would like to call Dr. Parag to talk about various medico-legal issues encountered in an eye hospital.
Hello, Jai.
Sir, I will share you, sir. I will.
Yeah, please. So, shall I start? Make it full screen, please. Shall I start now? Am I audible?
Yes.
Okay, so this very wisely, we have only 15 minutes to talk, because what we want to tell is very important, but what people want to know is more important. So there is more time for discussion and less time for speakers. I'm sure I'll finish before the allotted 15 minutes. Please change the slide. So now this type of headlines, they are definitely worrisome. Family alleges negligence as boy dies after eye surgery. Next one, please. This is not, is it full screen now? So teenage boy admitted anesthesia for surgery dies. So these are definitely worrisome things. Next one, please. So in ophthalmic anesthesia, we must understand that expected mortality because of anesthesia is 0. Because we can't afford to have even one death for eye surgery. Because a blind living person is better than a dead person. So it's better not to operate rather than risk the life of a patient. Now this is the logo of my institute, LV Prasad Eye Institute. It says, so that all may see. But I say, so that all may, please, it is not over. Previous one. Previous slide, Jai. Previous. Yeah. So it should be so that all may live to see. Because if he does not live, what will he see? So surgery is not that important. Life is more important. Next one, please. Next. Now, Issues may be related to general anesthesia, issues may be related to local anesthesia. But I will precisely give a case report and then we can go to discuss. Next one, please. So, this is a real case which was decided by the National Consumer Dispute Redressal Commission. So, it is Medical Directorate versus Dr. Meenakshidhar, Amrita Institute of Medical Sciences, Ernakulam. Next one, please. Next one. So what happens is a 9-year-old child is posted for squint surgery. He develops cardiac arrest in the operation theater while being operated, almost at the end of the surgery. He is resuscitated with atropine and adrenaline. Pacing is also done, but the patient dies. Next. Next. Now, post-mortem report says the cause of death is hypoxia following induction of anesthesia. So this is the conclusion of the forensic science person in post-mortem. Next one, please. And they claimed 20 lakhs rupees as compensation at the district consumer forum, but the forum awarded 6 lakhs rupees. So then the hospital people filed an appeal in the State Consumer Commission. And the State Consumer Commission on its own decision, they dismissed the appeal so that lower court order of 6 lakh stands. So the hospital again went to the higher level, that is National Consumer Dispute Redressal Commission. So now what National Commission has to say, we must focus on that, because what we think is not important in the court, it is what the judge thinks is important. Then the outcome does not depend upon what you have done. It more depends upon how the case is presented to the judge. That is very important. And our lawyer, how he presents it before the judge, that is also important in addition to the facts. So next one, please. So the court's observation, point by point. It is claimed that glycopyrrolate was given, but it is recorded as glyco, which can mean anything. Next one, please. Next observation of the commission is, no proper consent is taken. The consent is ritualistic. That means probably the pre-printed form is like a ritual signed by everybody. This also has been done like that. So that consent itself is not held proper by the National Commission. Next one. So next observation is, it is claimed that retrobulbar block was also given to block the oculocardiac reflex, but there is no mention of this in the case record. Next one, please. There is no record of PAC. With all these observations, the lower court judgment is upheld, means they have to pay the compensation. So now this is an example how the cases are decided. And now from this case, you can take this message that a proper informed consent is important, not a pre-printed form. It has to be individualized consent, dependent upon the patient to patient. Then don't use abbreviation. Use the standard abbreviations are okay, but don't use your own observation like glyco. So he said glyco may be glycol, glyco may be glycopyrrolate, glycol may be so many things. So in our records, we have to use standard of abbreviation, otherwise use the full form. Then record everything that is done. So if a block is given, record a block is given. If you don't record, but you do it as a, you can't say that we do it as a routine and we have not recorded. That will not be accepted. And then pre-operative and post-operative care also should be recorded. PAC and other post-operative, whatever we have done. Next one. Next, please. So this is what I want to say. Now, with this, if you will have some more questions, then probably we'll get some more knowledge and more highlights. Thank you.
So can I ask a question?
Yeah, sure.
Yeah. So do you mean to say that printed informed consent does not valid, or it has to be individualized? Mean we have to write for each patient, or how is that?
I mean, see, there is one case decided by Supreme Court, that is Samira Kohli versus Dr. Prabha. So in this, the court has dealt in detail with what should be the consent. Now the thing is, many times I have seen, you also must have, those who visit multiple hospitals must have seen, that there is a form of consent which is just got signed by the, somebody is signed, you don't even know because they don't mention who has signed it. Whereas whenever you sign any legal document, the person's name should be in the capital, because by sign you cannot make out who has signed. Then if there is a minor, then the relationship to the patient should also be mentioned. It is father, mother, wife, whatever. Plus there should be some individualization. Patient particulars have to be individual anyway. Patient name, age, whatever it is. What he is suffering from, his diagnosis will be individualized. What surgery is planned, operation will be individualized. What are the risk factors will be individualized, because whether he is suffering from hypertension or diabetes or some other problem. So all these things, it can be partly printed, but something which is pertaining to a patient has to be there. It just cannot be a form signed by everybody. That's the thing. So it should give an impression that yes, patient was consulted on these points and he has been informed about these things.
In Delhi, can anybody in Delhi, sir? People are taking video consent. Okay.
Yeah, video.
So video consent
video
has
consent.
become very common for the patient with high risk surgeries. So that can
Video
be
consent.
presented in the court as evidence.
Yeah. Video consent is perfectly okay. It is accepted by the court and it cannot be denied by the person who has given the consent.
Yes.
So that is the best one if you can do it. Yes.
But with the number of cases in ophthalmic, the risks are so heavy, it is not possible to do a video consent for every cataract or even every GA. So that is a practical point, if it is not a high risk case, it is
What
difficult
happens
to.
is now there is a system of counselors, because counselors are trained to give the information properly. And before the person goes for surgery, he has to go for counseling. And in that counselor level, it can be recorded because doctors don't have probably more time. And thereafter, if the patient has any doubts after counseling, then he can go to the consultant and clear his doubts. So that way you can save time and get a proper consent.
Even this business that printed form is not allowed, that also
it's not printed. See, printed form is printed, but some information has to, some information particular to the patient should be there.
Should be written, yes.
It cannot be a blanket consent, because I have seen consents which read like, I give my consent for any operation, investigation, these blood transfusion. This cannot be a consent like that.
Yes, yes.
Okay. Right.
Another thing is, surgeon takes the consent, mainly he involves surgical issues in that, rather than taking any consent for anesthetic.
No, we can
Consent
always
for
have it.
anesthesia should be
In
separate.
our institute, we have a separate anesthesia consent, separate surgical consent, and a separate high risk consent if it's a high risk case.
Yeah, we do follow the same. We have a separate consent for surgery, anesthesia, as well as for high risk.
We also follow the same here.
That's good.
Any questions? Any more questions, please? Or Dr. Jayachandran, regarding this incident reporting.
Yes, sir.
It is very important, incident reporting. But I think, as you said, it is a culture. We need to alter the culture in our hospitals, medical setup. Like abroad, incident reporting can be done by anybody. Like staff nurse, a technician can do an incident reporting occurring in the hand of a consultant, professor, or something like that. So, since the time it can happen in our setup, we can't expect much out of incident reporting. Most of the incidents will never be reported. So the first step in incident reporting is the protection to the person, or his interest should not be, means he should not be reprimanded for reporting the incidents. That should happen. But it is very important. Without incident reporting, you can't come to know what wrong has gone, and you can't take any preventive, corrective, curative measures. So that's absolutely very important. So, but this is more important than this. I think so.
Yeah. So to add on to that, that is why just culture means it's a blame-free and accountability, but it depends upon the behavior. Reckless behavior should not be there. Intentionally, it should not be done. The incident should not have happened because of reckless behavior or any intentional. If it is unintentional or accidental, then definitely it has to be noted down. And if it is near miss or no harm, as I was mentioning, it can be rewarded and encouraged also. That can improve our system.
Any absolutely avoidable should be avoided. Any avoidable incidents should be avoided. That's all.
As you're saying, many of the incidents will be system. I mean, somebody end result, somebody performs, makes a mistake, but actually there are many factors in the system which predispose for mistakes. So those have to be tackled and not just dismiss the individual or reprimand him, or as you're saying, system factors are the ones. Why did he make the mistake?
Yeah, that is why all the procedures in a system should be standardized and simplified. That is the most important thing.
Yes, yes.
Hello, I'm Dr. Kanan. Hello. As Dr. J has told, this is a self-realization of the system. That is, if I do a mistake, I immediately inform the incident. So it is not a blame that I am blaming somebody else as an incident report. That is what Dr. J is trying to create in our hospital.
One thing is that unless there is a culture in the institute itself, hospital, that they treat it impartially, irrespective of who has no blame should be. Generally, what happens is that blame immediately put to the person who involved in the incident. That's why they don't, and they are not encouraged.
No, yes. I think there is a long way to go from our side, but we should keep on trying to reach that place.
Correct.
So, any more questions? Speaker, sir. So, should you call up, sir?
Yes, sir.
Dr. J. Yeah. So we end this session. I thank all the speakers for their wonderful talk, and I thank all the participants. Thank you very much.
So, Sumana, shall I start the general body meeting?
Echoing is there.
Can I start? Are you able to see my slides?
Yeah.
Yeah.
Okay. Good morning, everyone. As a secretary, I would like to invite you for the first annual general body meeting.
Eco both hai.
Dr. Pushpa.
Dr. Pushpa, echo is there. Can you just ask that Suman, the sergeant, to look? Sergeant?
Side by side. On maybe on your end.
I'll just talk to them.
Sorry? I think now it is okay, I think so.
Yeah, better.
Yes, sir, better.
Yeah. So, good morning all. Welcome to the first annual general body meeting. As a secretary, I would like to welcome our president, Dr. Farah, Dr. Kannan, treasurer, Dr. Renu Sinha, journal editor, Dr. Jagdish and Venkat Raja, vice president, and Dr. Ravichandar A, joint secretary.
Again,
welcome our council members, Dr. Shuman. One second, sir. We will stop and see.
Dr. Kannan, please ask questions also.
Hello.
You also
can you rest of them unmute, mute? Yeah. Correct, sir. Can you mute? Okay. Can I start now? So good morning all. I welcome you all to the first annual general body meeting. As a secretary, I would like to welcome our president, Dr. Parag, our treasurer, Dr. Kannan, journal editor, Dr. Renu Sinha, vice presidents, Dr. Jagdish V and Dr. Venkat Raja Adigal, and Dr. Ravichandar, who is a joint secretary. Also, I welcome the council members, Dr. Shuman Sri, Dr. Pushpa Susan, Dr. Rashesh, Dr. Sharma, Dr. Vikas, and Dr. Shalini, and other life members and associate members to this first annual general body meeting. So, as a president, I would like to invite Dr. Parag to give his welcome address. Over to Dr. S.C.
Thank you, Jai. First of all, let me confess that it is all efforts of our secretary, Jai. I have not really done much about it. I only gave him idea that we have high time to start a association of ophthalmic anesthesiologists, and he has done all the work, not most of the work. All the work is done by him, and it's very nice that now we are starting our first conference and first AGM also, and we have sown the seeds now. How the tree grows and what fruits we get depends upon future generations, how they perform. But till now, the work has been really very commendable, because in such a short time, membership has been very reasonable and is still growing. The e-journal has started, 2 issues already come. First conference is so nicely being conducted, and I am grateful to all the members who have joined, even overseas members, and we have tried to keep the ophthalmologist and even optometrists, for that matter, anybody who is concerned with eye care is welcome to join our association, because eye care is a teamwork. So it's not only for anesthetists, it is for, and that's why today's speakers also include some ophthalmologists also. And I'm sure this multidisciplinary approach will give better results than only anesthesia association. So I hand it back to Jai for further conducting the meeting. Thank you.
Thank you, sir. Thank you, sir. Ultimately, it is your motivation and advice which helped me to bring out this association, and you have brought it to this level. Now, moving on to this next agenda point, our treasurer, Dr. Kannan R, will be submitting the last financial year report 2020 to 21. Kannan?
Yeah, thank you. Am I audible?
Yes.
I am honored to present the first audited financial report of AIOA for the year 2020 to 2021. It was the great effort of all the members of AIOA, and in particular Dr. Jay Chandran, that AIOA was formed. I remember the day when both of us, Jay and myself, walked into the State Bank of India and opened an account in the name of AIOA and deposited the first 2 accounts towards the life membership. Going over to the report, with the membership fee of rupees 5,250, we have a total credit of 3,72,750 from the membership fees. Our expenses included the association registration charges, web and domain charges, printing and stationaries, and we have an outstanding of rupees 11,000, which will be carried on to the next financial year. The balance, we have 3,32,434 in the bank and 926 rupees on cash. We thank the auditors, Mr. Pasati and Co., who have audited and presented the financial statement and have concluded the proper books of account have been maintained by the society. I'm thankful to you, sir. Once again, I thank all the members for their continual support in the growth of AIOA. As regarding the next electing the auditors for the next financial year, I propose Messrs. Parthasarthi and Co. as auditors for AIOA for the next financial year. Thank you.
Yeah. We'll move on with this appointment of chartered accountant with Mr. Parthasarthi and Co. Thank you, Dr. Kannan.
No, thank you.
Next. Yeah. I think Kannan, you can mute here. Yeah. Thank you.
Sure.
Thank you. Moving on to the new agenda points about the membership details and the new agenda points, before which I would like to congratulate our organizing secretary for the first national AIOA conference that has been conducted virtually in a much professional manner, grand manner. So also I would like to thank Dr. Giridhar A for hosting this first national AIOA conference. Thank you, Dr. Pushpa and the organizing team for doing such a wonderful job in spite of your hectic schedule. Thank you, Dr. Pushpa. Now, thanks to all speakers who have participated in the first national AIOA conference virtually. Thank you all. A big thanks to all. Now, moving on to the membership details. Now, following enrollment from October 2020 to till date, we have now a total of 77 members registered in it. 67 of them are life members and 10 of them were associate members. No deletion or removal of any member was recorded in the last year. And this is the cutoff figures. 77 members, out of which 67 are life members, 5 are overseas and 5 are surgeons. We have national membership ranging from almost all states of India, ranging from private practice to major tertiary referral eye care institutions. We have overship members from Malaysia, Adelaide, Birmingham, Turkey, and Switzerland. Now, coming to the new agenda point, I just wanted to know your opinion about the membership fee renewal. Initially, we had 5,000 INR and rupees 250 INR as an admission fee. The grand total was 5,250 INR. Shall we stick on to this the same membership fee, or we want to revise it? Any of your, can you give your inputs?
We can continue with the same, Jay.
Yeah.
Okay.
That we should continue with this for this year, and from next year we will see.
Okay.
Yeah, even I go with majority. I think we should continue with the same amount, Jay.
Okay, Jay. I think we can continue with the same for this financial year also.
so that we can enroll more members, because if you increase the membership fees, then probably it may be counterproductive sometimes. So let us reach about, I think, at least 200 members before we revise it.
Sure, sure, sir. We will try to. So we will try to have them retain the same membership fee, that is 5,250 for the next financial year also. Now moving on to the second agenda point, to encourage more registration for AIOA. This time, what we have kept is free papers and poster presentation at all our national AIOA conference. The presenting author or the co-author must be a life or associate AIOA members. I think we will stick on to this for the next conference also. Is that okay?
Yeah. Yes, we'll stick on to this for all the conferences.
Okay, sir. Okay. Now coming on to our journal, Indian Journal of Ophthalmic Anesthesia. I would like to congratulate Dr. Renu, our chief editor, and associate other editorial board members for successfully bringing out 2 online issues. Thank you. And next issue is supposed to be released in the January 2022. And also we have applied for the international standard serial number. Hopefully we will be able to receive in a short time. And to which we have also formed an editorial board members consisting of Dr. Renu being the chief editor and Dr. Ankur Sharma, associate professor, AIMS, Jodhpur, Dr. Indu Sen, professor anesthesia from PGIMR Chandigarh, and myself, and Dr. Sirisha Sendil, consultant head glaucoma service from LVPI. And in overseas editor, we have Dr. Vaya Kok from Baskent University, Turkey. Now moving on to the next agenda point. Now to encourage more members to submit more articles for IJOA, I propose that chief editor and the editorial board members to identify best IJO articles for each year. We will give an award. That is, the authors for the articles can be recognized at our national conference with medals, certificates, and cash prize that can be funded by AIOA. Is this okay? We can pass this proposal.
Yeah, it's a good idea.
Yes.
There is one suggestion.
Yes, sir. Tell me, sir.
Please, about this award, please write in our journal issues so that people know that there is something like that, and that award people will be encouraged to submit more articles.
I didn't get you, sir. What is that? Please.
In our journal, publicize about this award, so that people will, somewhere in the journal we must mention that
there is
the award,
sure.
so that people know about.
In the website also we will, and we will circulate the minutes to all the members.
Yes, we should publicize it as much as possible. So
we will circulate the minutes. Yeah,
right.
Definitely, sir. We will do. Okay. Now coming to the venue and dates for the second national AIOA conference, I propose we will have it at Aravind Eye Hospital, Madurai. Is that okay? We will move on. It was one of the offer. I thought we will accept it. Is that okay?
Yes.
Yeah.
Agreed.
Wonderful, Dr. Jay.
Yeah. So we will have in the month of September 2022. Most probably we will try to have it. It will be a 2-day conference. 1.5 days we will have a didactic lectures and half a day workshop. And in this conference, we will also try to have a special oration lecture delivered by eminence in the field of ophthalmic anesthesia by either national or international faculty. And we will be conducting the second annual general body meeting of AIOA, and election for office bearers will be conducted during this conference. And I propose Dr. Ravichandar A, who is also the joint secretary for AIOA, as to be the organizing secretary for the second national AIOA conference. Is that okay?
Okay.
Jay.
Yes, sir.
Thank you.
I just want to say something about the oration. Because
yes, sir. Tell me, sir.
Before we start, we should plan it properly, and we must decide what will be the criteria for selection. How are we selection? What are we going to give that person? Some medallion, certificate, travel allowance, whatever it is, we should formulate. How much finance it will need? How much finance it will need? Then once we do all this homework, then let us get back to our governing council or elected our committee, and we'll discuss and then do it.
Okay. Sure, sir. Agreed.
Right.
Okay, sir. So, Dr. Ravichandar, would
Thank
you like to
you.
add upon?
Yeah, thank you, Jai, for giving the wonderful opportunity to one of the ancient city of India and the cultural city of Tamil Nadu. And as everybody knows, Madurai is known for Meenakshi Temple, and also now it is famous for Aravind Eye Care system. So I wish you all come, and we welcome you all and get the blessings of the Meenakshi. And once again, I welcome you all and make the function very successfully. Thank you.
Yes, of course, we will be there to support you.
Thank you, Jai.
Dr.
Thank you,
Ravichandar.
Jai. Thank you.
Thank you. Thank you. It's our pleasure and an honor to be conducted over there. Now,
Yeah, it should be a physical.
Moving on to the winners for the, yeah, definitely. Now moving on to the winners for the free paper session. So total of 5 papers were presented. The judges were Dr. Giridhar A, Dr. Geeta Nath, and Dr. Multan Mal Sharma. So this was the third prize. That paper that was selected was positioning of kyphoscoliosis patients during ocular and periocular surgery, a case series presented by Dr. Siddiq Afsal Hassan from Dr. Giridhar Eye Institute. A big round of applause for him. Now coming to the second prize, it is won by Dr. Deepa Shetty, who has presented a paper on post-operative vomiting after pediatric strabismus surgery, a comparison of sevoflurane versus propofol anesthesia. Congratulate Dr. Deepa Shetty from Narayana Nethralaya, and Dr. Shalini Subramaniam is also one of the co-authors for it. I congratulate the winners. Now moving on to the first winner, it is rate of preoperative control of blood sugar in diabetics and its impact on post-operative infection, presented by Dr. Ronak Ravi Khanna from Shankar Nethralaya, Chennai, and I am proud to say that I am also one of the co-author for it. So thank you. I congratulate all the winners, and shortly we will be receiving the e-certificate through mail, and you can give me the postal address. We can also courier to you the prices also for the same. Thank you. So coming to the end, I would just like to wind off that our society will grow for future, and long live AIOA. Long live. Thank you.
Jai.
Thank you, Jai.
We will work together for this long life of AIOA.
Sure.
Thank you, Jai.
Meet after lunch.
So I think we will move on to that lunch now. Lunch break. Sumana?
Lunch.
What time are we starting back?
Minute lunch break,
1:30.
and then we'll go on to our section 3 at
1:30.
Okay.
Yeah.
1:30 is the
Thank you
time to
all.
register.
Thank you.
Yeah.
Thank you.
30 to start. I think.
So 1:30, the lunch
Yeah.
break. After lunch break, 1:30 in hall A, and 1:30 in hall B will be showing workshops.
Right.
Okay, sir. Thank you.
Dr. Sumana, are we starting in a couple of minutes or still people haven't come back from lunch?
Hello.
Yeah, should I share my screen?
I'll just, yeah.
Let me
So
know.
I think we can go ahead with the general anesthesia session 3. This will be chaired by Dr. Kannan R. He is a Deputy HOD of Anesthesiology at Shankara Nethralaya and Treasurer of AIOA. Simultaneously in Hall B, we are having the workstation. 3 videos will be played. First one is Needle Blocks on Simulator, Do's and Don'ts by Dr. Jayachandran of Shankara Nethralaya, followed by Subtenon's Block by Dr. Pushpa Susan Isaac of Giridhara Institute, and finally Basic Life Support Mock Drills by Dr. Venkat Raja of LVPI Hyderabad. So on to you, Madam, Dr. Geeta Nath, who will be talking on anesthetic options during laser photocoagulation for retinopathy of prematurity.
Thank you very much. Let me share my screen first.
Okay.
Yeah. Yeah. So this is my topic, anesthetic options during laser photocoagulation. So my first statement is anesthesia for retinopathy of prematurity is one of the most challenging in all of ophthalmic anesthesia. I think all of you might agree with that. So how big is the problem? So one is almost 10% of all births are premature worldwide, if you look at it. And of these, the risk factors for ROP or retinopathy of prematurity, one is low birth weight, gestational age, of course, Apgar score, pulmonary complications, then whether they received supplemental oxygen or they were ventilated, the anemia, blood transfusions, multiple gestation, intraventricular hemorrhage is one, and sepsis, NEC, all these things are risk factors for ROP. And one series of 600 preemies found that the incidence of ROP was more than 1/3, 33.9% of the patients. So what are the issues here? So one is, of course, prematurity, pain, types of surgery, effect of the agents, and post-op monitoring. I will deal with them one by one. So coming to prematurity, What we are most afraid of is postoperative apnea, because these children do tend to become apneic at the drop of a hat. So the recommendations for anesthesia in premature babies is it is ideal to do these things, these cases after a post-conceptional age of 60 weeks. That is from conception till the age. But for ROP, really, there's no choice, because there is a limited window of opportunity during which time it has to be done. Otherwise, they lose vision. So that's one problem. Also, if they tend to get apnea, for instance, if they get apnea at home, or if there is other morbidity like CNS morbidity or lung disease, anemia is a big correctable factor. Like many of the factors, risk factors cannot be corrected, but anemia can. Then opiates, of course, they depress ventilation and cause apnea. Other things which we are concerned about in these small babies, one is they get hypothermic so easily, hypoglycemic as well as hypocalcemic. So all these are the issues because of prematurity. Apart from all the issues of pediatric anesthesia as a whole, prematurity comes with all these issues. Then pain, what does pain do? We think, okay, they can't tell us they are having pain, but pain is not pain, and stress causes long-term psychological and neurological effects. So really we should not stress the baby. As far as possible, we should minimize stress. Then another thing is, what is the surgery what is the procedure which is going to be done? Is it only going to be photocoagulation, or is it actual retinal surgery? Like, are they going to do a vitrectomy, or is there detachment, some surgical procedure, or is it just going to be cryotherapy? So that is a deciding factor in our management. And coming to the anesthetic agents, opioids, muscle relaxants, all these things promote postoperative apnea and hypoventilation. So if we are going to give these drugs, we have to be much more alert, and maybe have a low threshold for postoperative ventilation. Then one issue which has come up over the past few years is the neurodevelopmental effects of general anesthetic agents. And these effects are seen inhalational agents, propofol, ketamine, all these things have had these animal studies. And during the period when the brain develops, then recently we have had the results of the gas study and the mask study, all these things, which have told us that actually if you give one anesthetic, a single anesthetic of not very long duration, it's okay. But repeated anesthetics or very prolonged anesthetics, we still don't have the data. And one other thing which has come up is that dexmedetomidine has a protective effect against these neurodevelopmental effects. But anyway, laser photocoagulation is not going to be a very prolonged procedure. So I think we can say that we can give inhalational anesthetics for this procedure. Coming to postoperative monitoring, that has to be very careful, and at least 12 hours of monitoring is recommended. So they shouldn't be discharged to home. So they have to be monitored postoperatively. Either it's often not possible in standalone centers. So you have to send them back to where they came from, the pediatric hospital which they came from, and they should be monitored afterwards. What are the anesthetic options? Either only topical or sedation plus topical, general anesthesia, either with a supraglottic device or intubation. These are the options that we have. There's nothing else. Early studies recommended that we should intubate all these patients. General anesthesia with retinopathy, with endotracheal intubation is recommended, because in this study, they quoted that there are a lot of systemic complications reported when being treated by retinopathy. This is a 1995 study. So in this study, 13 babies, 19 eyes were treated, and these babies were intubated and monitored by the neonatologist. This is 1997, and again, they had 3 groups, either topical alone or GA plus topical. And the interesting thing is they said that the cardiorespiratory complications were even more severe and protracted when topical anesthesia alone was used. So that is something to think about. These 2 studies, the first one was a survey of anesthetists, actually of ophthalmologists, regarding their practice and beliefs about how much stress is, the baby undergoes when you are when you're doing laser treatment. And they found that a lot of variation was there in what they do as well as what they think about stress. So many people felt that we should just paralyze and ventilate, or give morphine or oral sedation, rectal sedation, all these combinations. None of these people said that they use only topical alone. Sorry, I think that was a mistake in my typing. And the one on the right is an editorial about this same article by Chen. And it discusses all the various problems with individual drugs. It also discusses how much problem we have in observation, because the ophthalmologist is there covering the head and we don't have access to monitor the baby properly. So if we give deep sedation, that's a problem. We cannot monitor the ventilation and airway. But the procedure is such that you do need fairly deep levels of sedation and analgesia. So again, these 2007, they suggested that neonates should be electively intubated and ventilated before laser treatments. This is some more studies. So one paper talks about conscious sedation with a combination of fentanyl and midazolam without mechanical ventilation. So that's a bit, it didn't make sense to me, because why are you giving fentanyl for these premature babies? And as expected, 6 out of 15 babies were ventilated. So, I mean, that's not such a good idea. Another set of workers used subtenon's local anesthesia along with oral sedation, and they found it acceptable. Ketamine sedation, again, in the paper, they said that this is an acceptable option. But if you look at them, 11 babies, 3 of the 11 had intraoperative complications and 2 of the 11 needed additional ventilation. So really ketamine, though it sounds, sounds tempting, but it didn't work very well. In topical anesthesia, this is another paper 2016 paper, which said that topical anesthesia had more cardiorespiratory problems compared to general anesthesia. And the bottom one is Dr. Renu Sinha's study, where 56 infants were reported, 46 were intubated, and 10 had supraglottic device. And they concluded that giving paracetamol and topical anesthetics reduced the total intraoperative opioid requirement. Obviously, when they intubated, they gave the full gamut of opiates, muscle relaxant, and everything. Majority, 46 out of the 56, were intubated, but the exact surgery is not mentioned. And I suspect that it was probably actual vitreoretinal surgery. So that would need intubation, but just laser photocoagulation we have to think about. So our experience We had a series of 63 preemies or ex-preemies who had laser photocoagulation from 2017 till now, and their median age was 30 days. Many of them were 15 days, 16 days. Obviously they have to come out of the they have to finish their initial NICU treatment before they can come and have this surgery. Also, screening is done in the neonatal period in all the NICUs. The procedures, all these procedures were done in Pushpagiri, PVRI as it's called. And this is a standalone busy eye hospital. And the babies are referred from NICU neonatal centers, both in from private as well as government hospitals. And this is our protocol. Preoperatively, obviously, we look for the post-conceptional age, weight, birth history, and their history in the NICU. Were they intubated? Did they have nasal CPAP? Do they get apnea? Do they have stridor as well, especially if they have been intubated? So that's one. Then the fasting, apart from the general preoperative assessments, these are the points that we pay special attention to. Then the fasting instructions are standard. Breast milk 4 hours, formula feed 6 hours, clear fluids 2 hours. Now, these small babies are not normally given water or clear fluids. Usually they have only milk. So what I do is ask them to take 5% dextrose in a syringe, and they can just give little by little as the baby tolerates it, and that keeps the baby quite quiet during the fasting period. And then the anesthesia plan, the IV is usually in place from the NICU they are coming from. But if it's not, we put the IV. The IV is just for emergency drugs. It's not for any anesthetic drugs. So we put the IV and then gas the child down with the oxygen, air, and sevoflurane and maintain with the same mixture. Once the depth is adequate, we put supraglottic eye gel or LMA and continue with the same. Watch the respiration, assist if necessary. Now the IV fluid that I use is DNS because DNS has 0.9% sodium chloride. So it is not a hypotonic solution because we don't want a hypotonic solution which can cause hyponatremia in the baby. Also, it has dextrose because these children are prone to hypoglycemia. We need to give dextrose as well. So we give this at 10 ml per kg. See, this is an eye hospital. It doesn't have volumetric pumps or syringe pumps and all that. So I give it with the flow regulator. Whatever the weight is, I calculate and give the 10 ml per kg as per the weight of the patient. Once then we have to warm the patient. So again, we don't have warmers. So we put lots of wrapping around the baby and put some plastic sheet around it. Here again, there is a little bit of tussle between because they say their equipment has to be under the low temperature. So air condition, they don't like us to switch off the air conditioning. So we have to wrap the baby very nicely and we monitor the temperature as well. Once the procedure is done and the baby is breathing nicely, we remove it deep. And so what have we given? We have given only sevoflurane. It is inhaled and it is exhaled. So there is nothing, in my mind, there is nothing left in the baby. So they usually wake up quite quickly. Once they are fully awake, we start feeding them. And after 2-3 hours, we transfer them to the NICU, where they came from. So only one baby out of all of these needed intubation, after which they were shifted back to the NICU. Otherwise, all the other babies were fine after removal of the supraglottic airway. Obviously, you have to sit with them and monitor them very closely to make sure they are breathing properly. So this is one of our babies, and you can see the we use HME filters for all the babies, but you can see how big it looks in comparison with the baby's face. And as you see, we monitor the skin temperature. It is a difficult thing to maintain the temperature, but we try our best. And this is a baby after the procedure, somewhat smiling. And eyes are closed because it had all the procedure done inside the eyes. So to conclude, ROP is definitely a challenge for the anesthetist. And so many modalities being used, meaning there is really no ideal technique. And the choice depends on your setup, whether it's a standalone eye hospital or is it a big multi-specialty center. Also, what is the procedure required? Is it going to be only photocoagulation or is it actual vitreoretinal surgery? Close monitoring is definitely necessary either by anesthetist or neonatologist or whoever. If you use only topical anesthesia, it is more challenging for the ophthalmologist. The procedure does take longer and sometimes it is difficult to complete it. So many of the studies, as I've shown, they recommend post-op ventilation. But for photocoagulation alone, it is possible to avoid this with a carefully selected anesthetic. So thank you very much.
Thank you so much, madam. Now I would like to call Dr. Renu Sinha to talk from AIMS, New Delhi, to talk about management of syndromic child posted for eye surgery.
Thank you, Sumarna. It's good to hear our study in the another talk.
Yeah.
So I will start sharing my screen. Can I do?
Yes, I've stopped.
Yeah. Are you able to see my screen?
Yes.
And I am audible, I think.
Yes, ma'am.
Yes,
So
ma'am.
good afternoon, everyone. I bring greetings from Dr. Rajendra Prasad Institute for Ophthalmic Sciences, AIMS, New Delhi. Yesterday was AIMS Institute Day. It is not going forward. Yeah. So today's topic is anesthesia management for syndromic patients for eye surgery. This time I am including the adults also. So I changed from child to patient. Syndrome is a combination of signs and symptoms that are indicative of a particular disease or disorder. So they don't have only one disease, they have multiple diseases. There are multiple types of syndrome, you can name it, and it is difficult to chart out each and every syndrome. So being in a tertiary eye center, we get syndromic patients right from the 2-day-old child to the children of 10 to 12 years and even the adult patients. Because of the good care, now the patients are surviving till the adult age group, and we are getting much more patients of 20-year, 30-year and even 50-year-old. So anesthesia concerns includes the age of the patient related to ophthalmic diseases and related to syndromic specific concerns. They may need any type of ocular surgery. So you name it and they need it. Each and every ophthalmic surgery is not same. Their requirement is not same. But in toto, anesthesia goals for ophthalmic surgery includes echinacea, smooth induction and emergence, avoidance of OCR, control of IOP, adequate analgesia, and prophylaxis and treatment of postoperative nausea vomiting. Some of the common syndromes are Down syndrome is the most common syndrome. They have cataract and strabismus. So they come for those surgeries. Usually have congenital heart disease, have mental retardation, subglottic stenosis, hypothyroidism, to name few. Golden heart syndrome patients, they come very early age because they have lid coloboma, which causes corneal melting. They have pathognomic preauricular tag, mandibular hypoplasia, difficult intubation, heart disease, renal involvement, and skeletal involvement. We published one 20-day-old neonate with golden heart syndrome for coloboma surgery. Crouzon syndrome patients have proptosis, so they come for torsorrhaphy, and because of the proptosis, they have corneal opacity. They have craniofacial abnormalities, craniosynostosis, maxillary hypoplasia, congenital heart disease, and they usually have obstructive sleep apnea, which is more if they are elderly or if they are older age group. So we also had one preterm infant with Crouzon syndrome, and we published the anesthetic management of this case. Sturge-Weber syndrome patients usually come for the glaucoma surgery. They have typical port wine stain. They have angiomas in the CNS, mouth, and upper airway. And they usually have history of convulsions and on multiple anticonvulsant drugs. They have congenital heart disease and difficult airway due to the angiomas. We also published one review literature and our experience of managing patients with Sturge-Weber syndrome. Marfan syndrome patients come for subluxation of lens and for retinal detachment. They are typically tall and slender built with long arms and legs. They usually have mitral valve prolapse and aortic root dilatation along with cardiomyopathy. They have high arch palate, scoliosis, and may be on cardiac medications. Congenital rubella syndrome patients usually come for the cataract and glaucoma surgery. They have congenital heart disease, any type of congenital heart disease, including cyanotic and acyanotic, have microcephaly, deafness, mental retardation, and developmental delay. Hurler syndrome patients are quite uncommon, but it used to come in our center for the corneal transplantation because of the corneal clouding. They have cardiac abnormality, repeated chest infections, umbilical and inguinal hernia, and they have really difficult airway. Gapo syndrome patient is very uncommon, and once we did this case, this was the 35th case reported in the world. She came for the glaucoma surgery and they have multiple problems. So anesthesia management is just like another case with more precautions. Once you get a syndromic patient and you are not very used to doing those syndromic patients, then literature search is very helpful. Just if you Google Down syndrome, then you will know that vascular catheterization is difficult in Down syndrome patients. They have high incidence of bradycardia with sevoflurane, and they can have post-operative desaturation. Once you go in a detailed analysis, then you will get to know that high incidence of airway obstruction, difficult intubation, and bronchospasm is also there. For uncommon syndrome, just like this Fraser syndrome, it looks very normal, but once you do the literature search, you will know that these patients are having high incidence of subglottic stenosis with difficult and impossible tracheal intubation and may need very small tube and may need emergency tracheostomy. So you will be prepared for those things. This patient who was 1 year old, we were intubated with 3-size endotracheal tube without any leak. So once the patient with syndrome comes, it usually should be referred to the physician or pediatrician depending upon the age, along with the genetic details, and accordingly the detailed systemic examination is done. This is done for those cases who can wait, but for the urgent surgery for this type of cases, as this case is not having any eyelid and head corneal melting, so these cases should be operated very early. So surgeons should be considered their viewpoint for vision saving or vision improving. You can see that this child was operated on the same day once she was admitted, and look at the child, at least he can see now. So for those patients who are coming for urgent surgery, then pediatrician or physician should see, and the minimal investigation can be done for the surgery, though danger of the patient should not be there. So detailed history, investigation, concern, plan, and anesthesia should be done. For history, detailed history should be taken for each and every system of the patient to know. You can see that some of the patients are having respiratory pattern very different from the normal, and they have laryngomalacia and tracheomalacia, but you can't wait for those to subside because it takes 2 to 3 years. This is the another patient of Crouzon syndrome. You can see that this patient is sleeping right now, and the respiration, you can think that this patient is having obstructive sleep apnea, and he can't breathe from the nasal route. So after the surgery, they will have this type of respiration only. This is the another child. It will take some time to come. I want to just wait a minute. So you can see that this is the pre-op respiratory pattern of this kid, and he has apnea also, but surgery is needed to save the vision. So we took this patient on the same day. Airway examination is also very important because they have difficult airway. Although golden hour syndrome patients are not having that much difficult airway, but some of them are having difficult airway. This patient had a history of unable to intubate, and we also had problem for this patient. Down syndrome patient, as they grow old, their airway is more difficult, and similarly for the Hurler syndrome patients, as they grow old, their airway is more difficult. So after seeing the child with the history, then the concern is chalked out whether the patient is having difficult airway, what systemic involvement is there. It's a microscopic surgery. The patient may have a mental retardation or laryngomalacia or OSA. Then anesthesia plan is charted out. Regional anesthesia can be planned for patients who are cooperative, able to lie down supine, and their eye anatomy permit for the regional block or under topical anesthesia. General anesthesia is needed only patients for those who are smaller patients who have mental retardation or have contraindication for regional anesthesia. This patient was, she denied that she doesn't want regional anesthesia. So general anesthesia was needed for this patient for Cruzon syndrome for squint surgery. This 10-year-old child had severe kyphoscoliosis and general anesthesia was detrimental for this patient. He was cooperative and for vitreoretinal surgery for retinal detachment. He agreed for peribulbar block, so dexmedetomidine infusion was started and surgery was done under peribulbar block safely. So for anesthesia plan, for each and every step, one should ask for pros and cons for doing and not doing the thing. So after planning, a good assistant, efficient staff, best equipments are needed for a successful outcome, and post-operative monitoring place should be decided before taking the patient for surgery. Sedation can be given to few patients, but patients who are having very difficult airway and obstructive sleep apnea, sedation should be avoided. We usually prefer IV cannulation beforehand for patients who are difficult, and we put EMLA for those patients. But for difficult IV, usually we have vein view, and I am very good in putting the IV line through the vein view. So it can be used for difficult cannulation. Awake intubation is not a choice for children, but awake intubation can be done for those patients who are 14 and 15-year-old and are cooperative. This patient was 15-year-old Hurler syndrome patients, and we did nasal intubation, awake nasal intubation after topicalization. For induction for general anesthesia, we prefer inhalational induction because titration is possible with 100% oxygen and sevoflurane, and risk of apnea is less. But patients who are not cooperative and have very difficult airway and obstruction, in those patients, IV induction can be done along with the inhalational induction. The more problematic patients are who are mentally subnormal, have comorbidities and syndrome. Few of them are difficult to handle because they are violent. So we usually make parents to accompany the patient or their relative who is the caregiver. They usually do not tolerate hypoglycemia and they are very violent once they are hungry. So we do them as an initial case. Sometimes IV premedication is also needed to take them to the operation theater. During the face mask ventilation, care should be given to avoid the eye compression. We have to use oral airway in those patients who have maxillary hypoplasia, and sometimes nasopharyngeal airway is needed for the ventilation. Many patients comes after the dental procedure and they have equipments for dental maxillary enhancement or mandibular enhancement. Ventilation is very difficult in these patients. For managing the difficult airway, it is the experience of the anesthetist to give relaxant or to use supraglottic device or endotracheal tube. Succinylcholine should be avoided in those patients who are having very sensitive to malignant hypothermia. Choice of airway device, supraglottic device has definite advantage over the other endotracheal tube because of the less airway stimulation and smooth extubation, but there is concern also if there is a difficult airway, then the chances of displacement is there. In those cases, it can be used as a conduit for intubation. So we are very okay with the using of supraglottic device for difficult airway also, but it is an individual choice and surgeon should also be happy doing surgery with the supraglottic device. Sometimes the supraglottic device is used as a conduit for intubation. This patient had difficult intubation in CL grade 3 or 4 for the last surgery. And during the surgery, the surgeon said that they want mucosal membrane graft. So through the supraglottic device, we did the intubation with the fiber optic. This is the AirQ ILA, through which the intubation in children can be done very easily because it has a wider air tube. And you can see that the intubation through the supraglottic device is very easy, and the chances of apnea is also very less, and the chances of desaturation is also very less. But the size of fiber optic should be available for those type of endotracheal tube. So small, this was the 2.8 size of fiber optic. And you can see that it takes only not more than 30 seconds to place the endotracheal tube through the supraglottic device. And after that, railroading can be done. Endotracheal tube is definitely a choice for post-operative ventilation, and it will provide the normocampnia and can be used for definitive airway. I think there is just, this video is not working, I think. Yeah. So this is a Cruzon syndrome patients who had gross granulosynostosis, preterm child, and the ventilation was otherwise also not very good. So the respiration was not very easy. So oral airway was inserted, but because it is a preterm child and chances of desaturation is very much more. And at that time we were not having any video laryngoscope. So we gave 100% oxygen with sevoflurane. And after that, nasopharyngeal airway is made through the smaller endotracheal tube. And with that, oxygen and sevoflurane was given. And after that, oral fiber optic was done for the securing of the airway. Nasal endotracheal tube was not forwarded into the trachea because the nasal passage was very small. In Cruzon syndrome patient, nasal passage is very small. So the chances of leakage of the air is there. So oral endotracheal intubation was preferred in this case. There is some delay, so bear with me. I don't know. Can you hear me? Yeah, then just, yeah. This is just to show you that even the patient with difficult airway and multiple problems, this patient was having congenital heart disease also. So many a times if you are thinking of using oxygen and sevoflurane for the induction of anesthesia, but because of the airway obstruction, you need to have some airway device for the ventilation if there is mandibular or maxillary hypoplasia. And after that, even without giving the relaxant, with the use of video laryngoscope or the normal laryngoscope, the intubation can be done. So in this case is only for to show that we can intubate and we can secure the airway with the supraglottic device also. Though the supraglottic device insertion is little bit difficult, but by training, you can use it successfully without any trauma. So it can be done with video laryngoscope. It can be done through the supraglottic airway device. After the airway secured, the analgesia is also very important. It should be multimodal analgesia. In the patients who are having difficult airway or obstructive sleep apnea, then regional anesthesia is very good to provide the post-op analgesia along with the topical anesthesia and NSAIDs. If you are using opioids, it should be the smaller, shorter acting, just like fentanyl, because we don't have tremifentanil. Monitoring, apart from the clinical routine monitoring, if the patient is having heart disease, then we have continuous non-invasive arterial pressure monitoring, that is CNAP. It is available for the patients who are weighing 30 kg around and till the adult. And then for the monitoring of the depth of anesthesia, entropy or BIS can be used. This is a Hurler syndrome patient in which we used the entropy for the monitoring with the general anesthesia to have the adequate depth. Maintenance can be done with the TIVA or inhalational agent. We usually prefer inhalational agent because the awakening is good with inhalational agent and it is early. Apart from the normal concern, there are concerns about having the airway a little bit away from you. And if it is a smaller kid, then we usually prefer to have IV access on the foot so that minimal interference will be there while giving the drugs. And chances of disconnection is there, so one should take care of that. Extubation can be done in awake or deep depending upon the difficulty of the airway and presence of OSA. Sometimes even after the extubation, you may need to use oral airway for the post-op respiration till the patient is fully awake. For the LMA removal also, you will find that these patients are so nice to breathe with the LMA. Okay, I will leave. Sometimes you have to stimulate these kids to be awake because they are happy breathing through the LMA because it is giving an unobstructed airway. This is also the patient which we saw the intubation. At the extubation also, we put the nasopharyngeal airway because it was difficult for us to ventilate initially. So it was difficult for the end also to ventilate through the mouth. So at the time of extubation, beforehand, we put the nasopharyngeal airway by the endotracheal tube, and we extubated the child in the awake position. Once she was awake, and after that, she was happily sucking her fingers. It was her habit, and she was preterm at that point of time. And after 6 months, her father sent me the picture of the kid that she is doing fine. Her name was Pari. There was some delay in moving the slides. Please bear with me. So just one more. This is the adult patient. So we put amla cream and put the IV beforehand, because the Down syndrome patients, if you will induce it with sevoflurane, and if it is an adult with 80 kg, chances of having the bradycardia is much. And we were having her sister at that time. So we do the co-induction. Along with the sevoflurane, we give propofol. In this patient, fentanyl was avoided because it was a cataract surgery. So one should remember that ventilating these patients with one hand is very difficult. So you should have a good assistant with you who can ventilate while you are using your both hand for the mask. And the putting of the supraglottic device is also a little bit difficult, but with practice, you can do it without any trauma. Always have a supraglottic device with a suction port because they have full stomach. And we used the topical anesthesia because it was a cataract surgery. Lignocaine gel was put in the eye. Oxygen and sevoflurane was used along with the nitrous oxide. And at the end of the surgery, many times you need half an hour to 45 minutes for them to be awake. And their tongue is too large, so we need a little smaller, one size smaller supraglottic device, and you can see a big tongue. After the surgery, depending upon the systemic illness, they should be shifted to HDU or ICU. Initially, we were not having the high dependency unit. So at that time, we were keeping them in the recovery room with all the gadgets and emergency cart available. So to conclude, we do get common syndromes and rare syndromes. It needs multidisciplinary management because of the systemic involvement and difficult airway. Awake procedures can be done in selected patients. Careful planning is needed for anesthesia management and perioperative and postoperative analgesia, along with the postoperative monitoring to have a optimal outcome. Thank you.
Thank you, madam. Now I'd like to call Dr. Shirisha Sendil from LVPI Hyderabad to talk about the effect of anesthetic agents on intraocular pressure measurement.
Yeah, hello everyone, and thanks for the invitation. So I'm just sharing my screen. I hope I am audible.
Yes, madam.
Yeah.
Please go ahead.
Thank you so much. So this is kind of an intrusion in the anesthesia meeting, but I guess it's very important, and congratulations on this wonderful initiative. So in the next few minutes, I thought I will discuss about the effect of anesthetic agents on intraocular pressure measurements. So before going into those details, what is the importance of intraocular pressure measurement and tonometry, and what are the factors that could affect the intraocular pressure measurements? Especially in children, it is very, very important because we will not be able to do a proper evaluation just like what we do in adults. Also, the child's eye stretches rapidly, and there is also accommodation of the fluid inside the eye. So any increase in the intraocular volume increases the size of the eyeball, and hence not necessarily the intraocular pressure is high always. So also there is no universally accepted intraocular pressure range that is normal in children. And also what we need to remember is, although we keep talking about change in the myopic shift in refraction and so many other parameters, intraocular pressure is the only parameter that anyway is managed. So not just for diagnosis, but also for assessing the effect of treatment and the response, as well as whether we need to additionally control the intraocular pressures or not for further management. Especially in children, it is very challenging because many, especially with regards to glaucoma, first of all, they have photophobia, they have blepharospasm, they don't even look at the, your eye. So they have a lot of discomfort, and they will not allow you to examine the eye, leave alone the intraocular pressure. The minute we go close to them, they're going to cry, and the squeezing definitely increases the intraocular pressure as well. So most often what we need to do is we need to either, sedate them or take them up under a short anesthesia to be able to record the intraocular pressure. So while awake or sleeping, one of the tonometers that has actually revolutionized the way we are doing IOP estimation in the office hours, and the number of EUAs have significantly come down, is the eye care tonometer or the reborn tonometer, which is a contact tonometer, but a very short contact, and because of which we don't need to anesthetize the eye. So the minute we put Paracaine, the child is going to cry and they are not going to open the eye. So that is there. But having said that, these tonometer definitely has a slight overestimation of intraocular pressure. So many times we may end up giving anesthesia to be able to record the intraocular pressure. So while under anesthesia, and like I said, intraocular pressure assessment is so important, there are several factors that one need to consider before we take that intraocular pressure measurement to be able to take management decisions in a child. So starting from the anesthetic agents, the airway access, the type of intubation, speculum that we use, whether we use it or not, any manipulation that we do to the eye, as well as the tonometer that we use. All these do affect the intraocular pressure assessment. And let us look at each of them. So when a laryngoscope is placed, there are a lot of changes that happen in the hemodynamic parameters. There is adrenergic stimulation that causes increase in the outflow resistance, and hence that increases the intraocular pressure. We all know that once the intubation is done, the intraocular pressure is likely to increase by approximately by a mean of about 5 millimeters of mercury. This increase in intraocular pressure possibly persists for a few minutes after intubation, and that is the reason why we say when we, after the induction of anesthesia and intubation, we maybe want to wait for a few minutes before we record the intraocular pressure, while the elevation and IOP because of intubation itself may come down. We also need to remember that apart from the intubation itself, there are several other factors that the anesthetic agents itself can affect the intraocular pressure estimation. Some anesthetic agents increase the intraocular pressure like ketamine and succinylcholine. Some of them significantly decrease, that is the halothane, but the commonly used anesthetic agents today are the inhalational anesthetics. The more commonly used one is sevoflurane, which is known to decrease the intraocular pressure to some extent. So the reason why in fact, we were interested in this study is that While we know the laryngoscope or the intubation can increase the intraocular pressure, it is a common understanding or the thought that while that increase happens, sevoflurane also decreases the intraocular pressure. Possibly these two will stabilize. So one increases, the other one decreases, and hence there is no effect of anesthesia on intraocular pressure estimation. So this is a thought process that was there, and that is the reason why we actually embarked on a study. The other factor that can affect the intraocular pressure is whether we are pulling the lids or we are using a speculum to separate the lids to record the intraocular pressure. So this should be avoided, and very gentle separation of the lids is required to be able to record the intraocular pressure appropriately. Which tonometer used? I won't go into the details, but the commonly used tonometers that we have are the handheld Goldman applanation tonometer, that is the Perkins, and the other one is the iCare or the Rebound tonometer. The reason why I measured this is whatever is the tonometer that we use, we actually have to use the same tonometer every time that you measure. And because there are certain differences in the IOP measurement with these two tonometers, in fact, in our study, we used both the tonometers to see what is the effect of the anesthesia on intraocular pressure using both the techniques. Rebound tonometer, like I said, because we are using that in the office hours most of the time, we also wanted to see how it affects the IOP reading, how the anesthesia affects the IOP reading with this particular tonometer. So like I said, tonometry is used to record the intraocular pressure in children, especially the rebound tonometer in the office hours, as well as sometimes we also do that in the under anesthesia. And what we found was in the office hours, when there is a slight overestimation of IOP by about 2 millimeters. But what we know is when the IOP recorded without anesthesia in the clinic is less than 19 millimeters of mercury, most often we don't want to give a GA to confirm this. But when the IOP recorded by iCare tonometer is high, we always want to recheck this to see whether this is really an elevation or was that because of the child squeezing and the eye and things like that. So this was the study that we had embarked on, and Dr. Uma Shankar and Dr. Koshi were quite instrumental in helping us with this study. So what we looked at is what are the changes in the IOP associated with inhalational anesthetics. In fact, it started off with sevoflurane, but then when we realized it was not just the sevoflurane that was used, but there are several other anesthetic agents that are used, which is dependent on the anesthetist's preference as far as safety of the anesthesia for that particular patient is concerned. And hence we decided that we will compare these two. What is it if only sevoflurane was used, and what is it if the mixed anesthetic agents were used? And this was published in the recent Indian Journal of Ophthalmology. So while fixed anesthetic drugs, so whatever studies that are existing until now have actually looked at fixed anesthetic drug regime. That means either a sevoflurane versus propofol or isoflurane versus sevoflurane and things like that. But they haven't really looked at the mixed anesthetic agents, which is in a day-to-day practice a common one. So this was the aim, that we measured the changes in IOP with the inhalational and mixed anesthetic agents that were used under general anesthesia. A study was conducted at LV Prasad Eye Institute in 2017, and sample size was 48 eyes of 48 patients. So all the intraocular pressure were measured actually in the non-surgery eye. Obviously, the eye to be operated, you don't want to record the intraocular pressure once the surgery is done, and hence they were recorded in the non-operating eye. So I just would like you to notice this, that T1, which I'm going to refer to in the next few slides, means the IOP measurements done 5 minutes before induction of anesthesia. T2 is the IOP measurements done 5 minutes after intubation. And T3 is the IOP measurements done at the conclusion of the surgery. Like I said, we had 2 different tonometers that we used. In the group, mixed anesthetic agents were used in 26 patients and sevoflurane in 22 patients. What we looked at is what are the changes in the IOP at T1, T2, and T3. And the linear mixed effects model was used to compare the intraocular pressures at various time points. So these were the demographic parameters and the ocular parameters of the patients that underwent surgery. The age, if you see, is about 27 years. And that is the reason is that, so this study also required IOP estimation before anesthesia. That means the child or the patient should be cooperative to be able to allow IOP assessment, and hence very young children could not be included in this study. So we have to extrapolate the results to the children as well. But then we had little older children who allowed IOP estimation. So the pre-anesthesia IOP in this study was 26.9 with a large standard deviation, because some were glaucomatous patients and some were non-glaucomatous patients. What we found was there was a significant decrease in the mean intraocular pressure measurements at T2 and T3 time points. So like I said, there was a significant decrease, and this significant decrease was noted by both tonometers, and there was a slight difference in the IOP assessment by iCare Pro as well as Perkins tonometer, but that was not the aim of the study, and nor was the difference between the two tonometers very significant. But what is noteworthy is that at T2, that means after at T2 and T3, that means after induction of anesthesia, there was a significant drop in intraocular pressure by about an average of 5 millimeters of mercury. And at the conclusion of the surgery, it was close to about 6 millimeters of mercury. And how did the two groups differ in, that is the sevoflurane and the mixed anesthetic group? There was not much of a difference. That means there was no statistically significant difference. In the mixed anesthetic group, the drugs that were used were propofol or thiopentine sodium, fentanyl, and sevoflurane. They were various agents were used for induction as well as maintenance. So if you see at the two time points, the difference with the two different anesthetic regimes, there were not significant difference. So what we would like to say is that whatever is the type of anesthetic that is used, there is decrease in intraocular pressure irrespective of whether it is sevoflurane or any other mixed drug. So what was interesting also was we had two groups, that means the pediatric and the adult patients. We also found that in the pediatric patients, the decrease in intraocular pressure was not that significant compared to what we saw in the adults. And we were actually curious to know why. And we realized that several of the children that were taken up for anesthesia or who were included in the study were actually glaucomatous, and the adult patients were non-glaucomatous. That means adult patients were the ones who were undergoing either a squint surgery or something like that. So what we inferred from this is that in glaucomatous eyes, the decrease in intraocular pressure was slightly less compared to that in a non-glaucomatous eye, maybe because of the way the outflow resistance is there in these eyes. So that could possibly explain that. However, this difference was about 2 millimeters of mercury, not very significant though. The same thing which was done with iCare Pro tonometer. So what I would like to say is that IOP values recorded by two different types of tonometers definitely showed a decrease by a mean of about 4 to 6 millimeters of mercury at the time points of T2 and T3. And also it is important to know that at T3, that means at the conclusion of the surgery, the intraocular pressure was far less compared to T2, although in some groups it was not statistically significant. So what we could recommend is IOP should be assessed as soon as possible after the induction of anesthesia. That means within the first 5 minutes, to get the intraocular pressure measurements that are closest to the true intraocular pressure measurements. So I would like to conclude by saying that there is a significant decrease in IOP after a GA with whatever type of anesthesia that we use today in the day-to-day practice. And hence management decisions, especially as regards to pediatric glaucoma, has to be taken based on this underestimation which needs to be considered. So like I said, we don't go by just the IOP. We have so many other parameters that we look at. However, IOP is the most important parameter, and hence the importance of this study. Thank you so much for your attention.
Munna, I think you are mute. Oh, sorry. Can you hear me now?
Yes, ma'am.
Okay. I would like Dr. Bhavana Gupta from AIIMS Rishikesh to talk about managing the difficult airway in ophthalmic surgery.
Thank you, ma'am. Good afternoon, all. I thank the organizer for giving me an opportunity. I'll just share my screen. I hope the slides are visible.
Yes, ma'am.
Thank you so much. So my talk is on managing the difficult airway in an ophthalmic surgery when the patient is under local anesthesia. The outline of the presentation is the definition of a difficult airway, the spectrum of difficult airway, how do we assess it, what are the challenges in ophthalmic surgery when we are dealing with a difficult airway under local anesthesia, and how do we manage such scenarios. So the definition of a difficult airway is a clinical situation or a condition in which a healthcare provider or conventional anesthesiologist who is skilled at airway management encounters difficulty with one or more standard methods of airway management. Either it can be difficult bag and mask ventilation, difficult laryngoscopy, indirect or direct laryngoscopy, difficult intubation, difficult supraglottic device insertion, or difficult surgical airway. The spectrum of difficult airway revolves around the anatomical factors, the physiological factors, and the patient factors. In the anatomical factors, either it can be congenital syndromes or the acquired causes like morbid obesity, acromegaly, rheumatoid arthritis, Angst spondylitis, trauma, or tumors. In the physiological factors, usually we may encounter patients who have low oxygen reserves or critically ill patients. And sometimes we also encounter some uncooperative patients and also mentally retarded individuals. So the role of airway assessment is to identify the predicted problem in management of oxygenation during such airway procedures. So either it can be difficult bag and mask ventilation, which can be predicted by means of difficult mask seal, or obesity, like in cases of morbid obesity, there is redundant tissue which can impede the airflow, and elderly individuals in which we can find loss of elasticity, or in cases of stiff lungs in which there is increased pressure which is required during ventilation. In the prediction of difficult laryngoscopy or intubation, there is a mnemonic in the form of lemon in which we look externally at the prediction of difficult intubation like body habitus, head and neck anatomy like short neck, small mouth opening or loose tooth or prominent incisors, or significant malocclusion or beard. Then evaluating 3-3-2 rules, that is 3 fingers in between the interincisor gap, 3 fingers in between mentum and hyoid bone, and 2 fingers between the distance of hyoid and thyroid. Also, Mallampati classification class 3 and 4, it predicts the high degree of difficulty. Then O stands for obesity or obstruction, and N stands for neck mobility. Then difficult supraglottic device placement can be predicted by reduced mouth opening or upper airway obstruction, distorted anatomy, or stiff lungs. And in cases of difficult front of neck access can be judged by means of recent surgery or mass in the neck, recent trauma, tumors, radiation effects. So after we have predicted the difficult airway and also whether it would be difficult mask ventilation, difficult laryngoscopy, or difficult supraglottic or difficult phono, and also ascertaining the history and examination, we formulate a plan in the management of such cases under local anesthesia. So if we compare, managing such difficult airway cases under general anesthesia is a complex procedure in which we assess the difficult predictors and also plan whether we would like to go for awake intubation or under general anesthesia, whether we would like to go for non-invasive or invasive techniques, whether we would like to preserve the spontaneous ventilation or ablate the spontaneous ventilation. Depending upon the plan, we execute that plan and monitor and ensure the patient's safe outcome. If we compare such a thing under local anesthesia, what is important is that patient information and education regarding the perioperative process and setting realistic expectations is usually adequate in allaying anxiety in most of the instances. We can get away with such cases and mostly without any sedatives and only non-pharmacological measures, like we can just get away with those things, or mostly patient would require some mild sedation. So basically, what could be the challenges under local anesthesia and how do we make decision making? So if we talk about eye surgery, usually the most of the patients which we would encounter are mostly of cataract surgery. And despite advances in the surgical techniques, there's a large proportion of patients who are apprehensive and anxious regarding the surgery. So also there's a feeling of suffocation under the facial drapes. And in some of the patients, like in cases of morbid obesity, they may find discomfort in the supine position and also when the head is immobile. So the challenges of managing a difficult airway under local anesthesia lies in the fact that you might have to manage airway while the surgery is going on, and you might have to plan for failure or catastrophe if that thing happens, and you need to have customized approach depending upon the predictors of difficult mask ventilation or intubation. So in the pre-procedure preparation, it is very important that we talk to the patients and relatives, tell about the benefits of the procedural sedation, the risk involved and the limitation in your setup. Then we evaluate the difficult airway predictors, the OSA risk factors, if there are any in obese individuals. Risk of pulmonary aspiration can be a certain level of consciousness in case of critically ill patients, and room-based saturation. Regarding nil per oral status, according to the patient risk factors, we may allow for 2 hours for clear liquids and 6 to 8 hours routinely, which we follow under anesthesia, but no prolonged fasting should be allowed in cases of cataract surgery patients like in elderly, because prolonged fasting hours can affect the physical and psychological well-being, and also it can lead to delayed development of hypovolemia and low blood glucose, and also anxiety. It has been seen, it is worsened with prolonged fasting hours. So we have to weigh according to risk of the patients. Then also we have to set a target level of sedation if it is required in such a scenario. It is important that an experienced individual should be present at the time of difficult airway management under local anesthesia, because it will provide you adequate monitoring. He's the person who will maintain the level of sedation, because it is very important that there is a continuum of sedation and we have to settle on what amount of sedation we require in such cases. Also, they may find early airway obstruction in a case if at all it happens during deep sedation, and seek additional help whenever it is required. So if I talk about local anesthesia, there may be several approaches which can be used for cataract surgery, including topical anesthesia, eye drops, or intracorneal retrobulbar blocks, or extracorneal peribulbar blocks, and blunt cannula using subtenon's approach. The main purpose is to provide safe, painless, efficient, and effective technique, and also anesthetize and akinete the segments. So it has been seen that if you are using topical anesthesia, it has been found to have more intraoperative and postoperative discomfort when compared to other blocks like subtenons. So that can be taken care, because there is a additional installation of anesthetic agent can be done in the anterior chamber, that is intracameral anesthesia, which improves the patient comfort. But on the other side, like the retrobulbar and peribulbar block, they result in equivalent level of pain control, which are superior to those of topical anesthesia. So if I talk about sedation or analgesia, it minimizes the patient anxiety during surgery, also discomfort. And the ideal anesthetic agent would be one that will reduce the anxiety and stress response, also increase the pain threshold of the patient, and eliminate any undesired or accidental movement during surgery. So regarding to those goals, we do have many agents, but it should always be remembered that it is a supplement to the block. It is not a replacement. Also, it will depend upon the surgeon's preference as well, because some surgeons, they're happy to talk to the patient during surgery, but others, they would just like the total silence in the OT or complete ocular immobility. So depending upon that scenario, we have to judge whether the patient would require the analgesic agent or the sedative agent. So if I talk about optimal sedation, you have to ascertain what is the goal, that is anxiolysis, analgesia, or sedation. We should avoid polypharmacy, because if you're giving, it should be given before before we are anticipating any painful stimulus. Like before block, we can give some amount of fentanyl that will take care of the pain part. And also sufficient time should be rendered between the dosage. Like if we have given 0.5 milligram midazolam right now, we must wait for at least peak action of the midazolam to happen, and only then we should repeat the dose. Also, neck can be little extended so that we can prevent tongue fall during surgery, and it can be stabilized with the help of headrest. Oxygen supplementation may be required in cases of moderate to deep sedation. If we talk about the continuum of sedation, like in the minimal sedation, the patient responds normally to verbal command, whereas in the moderate sedation, he may respond purposefully to those commands. In most of the cases, in minimal and moderate sedation, the airway is maintained and the severe support is not needed. But if we compare the deep sedation and general anesthesia, you would require airway support, and we would not like our patients to go into deep sedation during ophthalmic surgeries, and especially true in a difficult airway situation. So there are various agents which are being used in the ophthalmic surgery. It will depend upon the need of requirement. Like in cases of midazolam, we can go away in cases of axial, like in providing axiolysis. But we must remember it is not an analgesic agent, and it can cause prolonged sedation. And also the dose needs to be reduced in cases of elderly individuals. Then fentanyl can be used as an analgesic agent, especially when we are giving topical blocks. Although propofol is not routinely like used in cases of elderly individuals or in cataract surgeries, but it does has an advantage of rapid onset and easy titratability. So regarding monitoring, it is very important that we maintain regular communication with the patient, in addition to the monitoring the level of consciousness, sedation assessment, ventilation and oxygenation, as well as hemodynamics. There was an article in JAMA in which they have suggested a new flexible support for the ophthalmic drapes. Like in the spontaneous cases, it has been seen that there are incidences of hypercarbia if we are using ophthalmic drapes. So to prevent those hypercarbia to happen, or to prevent hypoxia, these equipment, it is easy to handle and prevents the contact of the patient's face with the ophthalmic drape. Then there are various observer assessment alertness sedation scales, like we can use those scales in the OT. Also, there is Ramsey sedation score, like the score 1 will be the patient is anxious, the score 2 that is cooperative and oriented. In score 3, it responds to your commands, and in 4, you would require more stimulus for the thing. In routine, like in a difficult airway situation, we would like to have a patient cooperative, oriented and tranquil, that is a score of 2. So also it is important that during recovery, some patients may land up in complications secondary to delayed drug absorption or slow drug elimination. They may land up in residual sedation or cardiorespiratory depression. So we need to monitor such cases and continuously observe for the consciousness, sedation levels, and monitoring till the discharge. So the simplified discharge criteria for such cases can be like the patient is fully awake and he's able to maintain oxygen saturation on room air, then we can safely discharge those cases. Now, in what situation, we may have the intraoperative requirement of conversion into general anesthesia is important, because like in cases, there may be convulsions, so you need to keep anti-epileptics and emergency airway cart with us. Then in certain cases, there may be excessive sedation if we have given excessive amount of drug. And also they may land up in respiratory depression, or there may be complications secondary to the drug administration, like in local anesthetic systemic toxicity or anaphylaxis, or secondary to patients' own comorbidities like respiratory COPD. And in certain cases, there may be severe agitation. So in these cases, we might require conversion of a difficult airway, which was under local anesthesia, into general anesthesia. Then in that scenario, we have to have management of difficult airway. That is, we need to supplement oxygen throughout. We need to have a basic preparation in form and a certain health and pre-oxygenation. So this is basically a list of portable drug difficult airway management card, but it is depending upon the specific need of the patient, preference of the anesthesiologist, and skill of the practitioner, and depending upon the healthcare facility. We should keep the difficult airway card in cases that things happen. Then difficult airway guidelines are there, definitely, like in case we the plan A, B, C, D, we can follow that. And what are the don'ts in difficult airway? That we should never aim for deep plane of sedation. We should never go for a technique which we are not familiar with. We should not go for multiple attempts, and render the patient apneic unless you are pretty sure that you will be able to do mask ventilation. So my take-home message is we should have appropriate experience, risk assessment, and clinical judgment, which can reliably predict difficulty of managing a patient's airway. We should have clear definition of type of difficulty which may be encountered, like with respect to difficult ventilation, intubation, or supraglottic device insertion, and we should have a pre-formulated strategy and management. Most of the patients would just require verbal reassurance, and in case if we require sedation, in such cases, we should go for mild to moderate sedation only, and have a safe outcome. So thank you so much.
Thank you, madam. Now I would like Dr. Manpreet Kaur from AIIMS, New Delhi to talk about anesthesia for daycare ophthalmic surgical procedures.
Can I have the sharing rights?
Yes, ma'am. Yes, ma'am. Your screen is perfectly visible.
Good afternoon. I'll be talking about anesthesia for daycare procedures, ophthalmic surgical procedures. I bring warm greetings from AIIMS, New Delhi. Dr. Rajendra Prasad Center for Ophthalmic Sciences, which is a part of AIIMS, was founded 50 years back and has been recognized as the apex organization by the Government of India. Over the next 15 minutes, I'll talk about daycare surgery. A daycare surgery is the planned admission and discharge of a patient for a specific surgical procedure within the 12-hour working day. A daycare surgery for one institute might not be daycare surgery for the other hospital. For example, strabismus surgery is not a daycare surgery at our institute, but at many of the centers outside, it's a daycare surgery. So this is a vast range of procedures which are being carried out as daycare. Cataracts, squint surgery, VR surgery, they are done as daycare and including AIOA. That is examination under anesthesia. So anesthesia may be required in some children for eye examination. Simply either they are too young or they are uncooperative to allow examination when they are awake. These procedures last only for 5 to 10 minutes, and they can even be done in procedural sedation, but general anesthesia is definitely better, especially when we need sufficient depth of anesthesia. These children also undergo repeated examinations for which angiolysis is of great benefit because of the serial examinations. This is a general setup for the area which is needed, that is, a preoperative room is needed, wherein, as you can see in this slide, there are large number of patients waiting in the waiting area, in the preoperative area, where they are screened, and then they are taken into the child-friendly waiting area. This holding bay should be child-friendly. Like, as you can see, there are multiple children-friendly posters. You can install a television in it, and an examination room, wherein there should be an anesthesia machine with scavenging system and all the airway equipment. This is the exhaustive list of EUAs which is done at our center, which range from external eye evaluation to the vitreoretinal examinations. The ophthalmic patients usually belong to extremes of ages. I will be mostly covering pediatrics. Most children, they are scheduled for eye surgery are either ASA class 1 or 2 and can be managed as day cases. Anesthesia is usually straightforward. However, in some children, the eye problem may be part of the chromosomal or metabolic disorder with anesthetic implications. A few children may have developmental delay, mental retardation, and behavioral problem. Then in them, the challenge is to deal with them in a sympathetic manner. We should never undermine the detailed evaluation in the haste of time. Whenever we receive any patient under the EUA, we should always look for the ample history, that is allergy, medical history, past history, last meal, and anesthetic charts which are available with the child should be looked for. A history of recent URI is important. And these days, COVID testing is also done pre-operatively. A useful tip is that we should always look in them for tonsils. An enlarged tonsil is important because we are going to insert an LMA, and preparedness for maneuvering or using a softer LMA like EMBU LMA might be of great help in such patients. The fasting guidelines are according to the ASA practice guidelines. To reduce the prolonged fasting, we can give clear time instructions. Like, for example, if the child is posted at 10 a.m. in the morning, then we can give a clear instruction that clear fluid has to be taken up till, say, 8 a.m. We can split the list into two and call them at the split timings. This will save a lot of time, as well as this will help in managing the list easily. The myriad of investigations might not be needed in all EUAs, but might be needed according to the type of surgery. For example, if we talk about EUA, hemoglobin might not be needed if we are getting a suture removal. But we may need detailed evaluation even prior to minor procedures like EUA. For example, if a Down's patient is coming, we will need an ECG and a thyroid profile. A child who has been fasted for long and is inactive, it's a good idea to do FBS. And other important tips are that all investigations, they might not be needed in all EUA, but don't consider EUA as a simple case and compromise on evaluation. If a child has a likelihood of getting admitted into high dependency unit, you should not do it as a daycare case. Pre-medication and induction are a matter of personal preference. And a busy pre-operative room, like as you can see, with more than 30-40 examinations in a day, the feasibility of sedation has to be considered. So, as we know that for pharmacological pre-medication, oral midazolam takes around 20 minutes after administration to reach its peak action, and clonidine around 30 minutes. So waiting that long and timing it out might be very difficult. So pharmacological intervention for EUAs per se might be difficult because of the time constraints. Space is also needed for pre-medicating them, and an anesthetist is also needed for observation. However, we can use pharmacological intervention for surgeries like squint, etc. However, but for EUAs, we can utilize the non-pharmacological interventions like parental presence, video distraction, and toys. As you can see in this video, the child is being video distracted, is sitting in parents' lap, and by video distraction, we are not only allaying the anxiety, but also establishing a rapport with the child. This is another video. So this child is being wheeled in with the present, along with the parent. So parental presence is important. This allays his anxiety. We can utilize the parent and we can induce the child in parent's lap. The first child which you saw in the video, see the important aspects are that the wheeling in of the child and the parental presence where there is maximum anxiety. Those points of time can be taken care of by simply video distraction and the parental presence, which is commonly practiced at our institute. There are specific requirements for ophthalmic surgeries. First and foremost is akinesia. That is very important. Most of the surgical procedures involving the eye and orbit result in only mild to moderate pain and discomfort, and are well managed with topical anesthetic agents or simple agents like paracetamol and non-steroid analgesics. However, surgeries like squint surgery, retinal surgeries, they are generally associated with more severe postoperative pain, and stronger analgesics may be necessary. So we can think of using tramadol in them. Any drugs or maneuvers that increases IOP can cause extrusion of vitreous. So it is very important to take care of IOP. So things like application of mask should be gentle because it can also increase IOP. Other physiological considerations like oculocardiac reflex is also important. For VR surgeries, avoidance of nitrous is important because that can expand the air bubble, and we should be aware of the drug interactions. For most of the procedures, dilation of the pupil is done. We would see many patients being wheeled in with very less heart rate. Forgetting the fact that phenylephrine can be used, many of the ophthalmologists might overuse the phenylephrine, causing refractory bradycardia and hypertension. So we should be aware of these aspects. Another important aspect is the emergence. The emergence should be without coughing and straining and vomiting. Then comes the monitoring. For monitoring, we use heart rate, saturation, BP, and the monitoring of the ventilatory parameters. There are multiple anesthetic options which are available. I'll be talking about general anesthesia, and these options are determined according to the patient profile and the surgical factors. For pediatric patients, general anesthesia with using volatile agents or TIVA, using LMA is the most commonly done. Since we have a shared airway, it is very important to know that eye is also near the shared airway. Spontaneous ventilation via face mask will frequently suffice for simple eye examination, although it is often more convenient to utilize a LMA to allow the ophthalmologist unrestricted access to the eye. And besides, LMA reduces cough at the end of surgery compared to the endotracheal tube. And whenever the need be, we can use the controlled ventilation with muscle relaxant whenever needed. The options which are available to us are from simple face mask to multiple laryngeal mask airways, which includes classical LMA, flexible LMA, second generations like ProSeal LMA. Newer agents like AirQ LMA and LMA blockbusters have also come up, through which endotracheal intubation through them is also feasible in case the LMA gets displaced. A secure airway is essential because of the inaccessibility of the airway when the face is covered with the sterile grapes. So the options are either inhalational induction or intravenous induction. This job has been made easy because most of the syndromes have been covered by Dr. Renu. So I'll be just talking about a simple induction. In case we have a non-cooperative child, inhalational induction is the preferred technique, wherein we use sevoflurane 8% for inducing the child. As you can see in the picture, we are inducing the child using the inhalational induction. This child is a cooperative child. We could have even taken an IV cannula also beforehand. So when the child is induced, it's a good idea to induce with nitrous and oxygen because the induction becomes faster. Once child is induced, we can reduce the sevoflurane, and we can, after reduction of the sevoflurane, we can take an IV. What we use is, for if we have an AIOA going on, we switch off the sevoflurane and use the lower flows which are circulating in the circuit and the FRC for the rest of the 5 to 10 minutes. However, in case it's a longer duration surgery, then either we are using a muscle relaxant for akinesia, or we maintain the child on sevoflurane or isoflurane via LMA or endotracheal tube, whichever is inserted. But for cooperative children, propofol based induction is also a good option. So these are the picture of two children. Herein we have used flexible LMA. Usually we prefer to use flexible LMA in those surgeries where there's likelihood of pressing on the LMA, because this flexible LMA will not get compressed. For example, in squint surgery or VR surgery, we prefer to use a flexible LMA. And this is, the second picture is a EMBU LMA. And this child had a grade 3 tonsils, and we prefer doing, on the initial attempt only, we used soft LMA like the EMBU LMA. Now there are multiple controversies which are there, whether the IV should be taken for so short cases. There are pros and cons of taking an IV. Definitely taking an IV is safer because of better response in case there is a laryngospasm or anaphylaxis, and we can administer analgesics. But without IV, the efficacy will increase, the parental satisfaction would increase, and in a setting of rapid turnover, this might be of benefit. There's a large case series which has been published in year 2017 from Minerva Anaesthesiologists, wherein there was no, in case of retinoblastoma, there was not much complications in case no IV was taken. But it's a personal discretion, and in my opinion, it's safer to take IV, and it should be preferably taken. There are specific consideration for individual EUAs. For example, syringing and tubing, wherein there is a blocked nasolacrimal duct. a small blunt needle is used and irrigation is done with saline. So this saline appears in the mouth. It's a good idea to do suction prior to removal of the LMA, and it's a minimally painful procedure. For tonometry, the accurate intraocular pressures are measured for first 10 minutes of induction using CO or halo. And whenever we're using CO, we should limit to 5%, otherwise IOP would reduce a lot. And using face mask in patients with the tonometry measurements should be very gentle. For retinoblastoma, they have take a history of chemotherapy because they might have difficult IV. And for TT and cryotherapy, which are painful procedure, you might like to use fentanyls for these examination under GA. Now, these patients come for repeated examinations. Now, 2 decades ago, there was a possibility that anesthetists could harm the developing brain, and FDA raised a warning about it. However, with multiple trials, gas, PANDA, and MASK trial, there is no evidence of clinical anesthetic neurotoxicity. I have specifically covered EUAs in detail. Now I'll be talking about a few surgeries which are done in, as daycare in other places. Like cataract has been dealt in detail previously, so I'll not talk about it. A few aspects about strabismus surgery. It's very painful, so you can use peripalpal block. Paracetamol, NSAIDs like diclofenac and ketorolac can be used for pain. For postoperative nausea and vomiting, which is high incidence, you can use dexamethasone and ondansetron combination and avoid use of nitrous and high-dose opioids. And TIVA is another option. There is high incidence of oculocardiac reflex. I'll not go into detail, it has been dealt. And controlled ventilation might be suitable in them. TIVA is one option which is not commonly practiced in most of the places. However, we do practice at our institute. So I'll show you a video about it. So in this child, first BIS monitor has been preoperatively applied. They are given 1 mics per kg fentanyl, and TIVA propofol using Kataria model is used with a target effect site concentration of 5 to 6 microgram per minute. As you can see, once 5 is achieved, the adequate depth is there. We put in an LMA, flexible LMA. As you can see on the monitor, once the surgery is over and the propofol target concentration is titrated down and stopped 10 minutes prior, field. So this is at the end of the surgery, surgeon also administered subtenons block, and through that the pain relief is also taken care of, and at the end LMA is also removed, and the patient then can be transferred to PECU.
Madam, I'm just wanting to know how many more slides do we have? Okay.
In VR surgery, we should avoid nitrous. Pain is important aspect, and OCR and NV are also important to be taken care of. To conclude, detailed preoperative evaluation is needed even before EUA. Non-pharmacological methods are most suitable for sedation, and inhalational induction with LMA is the most suitable for EUA. Repeated GA exposures have no effect on neurodevelopment, and TIVA is a feasible option for strabismus surgery. Thank you.
Thank you, madam. Now on to Dr. Anil Kumar Bura from Center of Sight, Hyderabad, to talk about retinoblastoma, anesthetic implications and challenges.
Hi, am I audible? Are my screens?
Yes,
my
sir.
slides visible?
Please go ahead.
Yeah, hi, this is Dr. Anil Kumar, consultant anesthetist at Center for Sight, AIOA Hospital, Hyderabad. I thank the Association of Indian Ophthalmic Association Anesthesiologists to give me opportunity to talk about the retinoblastoma, its anesthetic implications and challenges. So coming about the sorry, it got stuck. Yeah. The most retinoblastoma is the most common intraocular malignancy arising in the childhood, which is seen in the posterior part of the retina with multiple foci. The tumor, which is present in the eye, it can extend forward into the vitreous cavity or also extend to the posterior to the brain through the optic nerve. It is because of the loss or inactivation of an allele gene of retinoblastoma 13q, which is also associated feature with primitive neuroectodermal tumors. The survival rate of retinoblastoma in children is more than 95% in the developed countries, but not in the developing countries because we lack in identification of the tumor itself. The main characteristic feature of the retinoblastoma will be leukocoria. Leukocoria is a white pupillary reflex which is commonly seen from the birth to 6 months or 1 year or 2 years of age, depending on the case of the retinoblastoma, whether it is bilateral or unilateral. And the second most common clinical feature will be strabismus or squint. That is the reason in the squint, if we see a squint or strabismus in a child in the period between 6 months to 2 years of age, fundus examination is mandatory and it never has to be left around. And other classical feature will be like painful red eye with secondary glaucoma or painful red eye with uveitis. Poor vision is another feature, inflammation or pseudo-inflammation around the eye. And there's also a particular syndrome called 13q deletion syndrome, which is because of the deletion of the tumor suppressor gene, which is in 13q14 band. The characteristic features of the 13q deletion syndrome will be hypertelorism, micrognathia, the absence of the nasal bones, large ears, and these people are highly associated with retinoblastoma also. Coming to the differential diagnosis of retinoblastoma, this white eye reflexes may also it will be a classical differential diagnostic feature with the persistent hyperplastic primary vitreous, Coats disease, cataract, retinopathy of prematurity, uveitis, and endophthalmitis. There are a set of investigations to be done for the to define the retinoblastoma and diagnosis. But the first one will be the distant direct ophthalmoscope, which is called a red reflex testing, which is done in the office setup. But we know that most of the children here are like in the age group of 0 to 6 years. So these kids are definitely not cooperative in the office setup for any kind of examination and to help for the further prognosis of the disease. So for them, we have to take them under general anesthesia to check whether how the stage of the anesthesia. Though other most commonly done diagnostic tool will be ultrasonogram, which is called B scan, where we can see the cauliflower-like mass arising from the retina, which is a characteristic VY pattern, and then orbit. In the CT scan of the orbit, we can see the calcification of the orbit inside the eye. And the classification of the retinoblastoma is also done based on the tumor size, and also that will be grouped as A, B, C, D, E, and another staging will be like staging 0 to 4, depending on the histopathological examination after the enucleation is done, regarding the extent of the tumor seen. So coming to the first part, when we have to take up for a EUA or for any disease per se, the anesthetist role will be doing a detailed pre-anesthetic checkup. I guess like we have covered already all the eminent features of a pre-anesthetic evaluation and optimization of the child in the previous speakers, but I'll just want to share few topics. Like in the pre-anesthetic checkup, the detailed birth history and family history and socioeconomic history has to be taken, because we know that these EUA kids will last for a minimum of 10 to 15 EUA cycles are required for a complete cure of retinoblastoma tumor. So for that, we need to take the detailed birth history, like it's a consanguineous marriage or premature delivery, or after the delivery, whether the baby is in the incubator, whether the baby was vaccinated, and when they have found out the white reflex, and the family history of retinoblastoma. And in detail, physical examination has to be checked up for the cardiovascular system, respiratory system, and neuro system, and in general full examination. Coming to the airway examination, ask for the child for the snoring, just check up for the chin, how they are attached to they are associated with any congenital anomalies. And then ask for the previous history of allergies, anesthetic complication associated elsewhere, or any blood transfusion or any chemotherapy complication done elsewhere, seizures or breath holding spells. Coming to the investigation, there are different set of battery line of investigations depending upon the oncologist and ophthalmologist required. And per se, for EUA, there is minimum of a complete blood picture, and complete blood picture is what required, because we need to check on the anemic status of the child also. And To complete an optimization of the child for the examination, there should be a teamwork with the pediatrician, hematologist, and oncologist and ophthalmologist with anesthesiologist. NPO status was also completely elaborated in the previous slide, previous speaker only. So the clear liquids should be 2 hours, and I appreciate that these clear liquid 2 hours to be continued till we take up for the surgery or examination under anesthesia. And after that, least but after that, regarding coming to the optimization of the child, retinoblastoma children, we all know that they are so immunocompromised and they are with the risk of highly infections, respiratory tract infections. So for them, they have to be vigilant. They have to be vigilant, and they have to be under a pediatrician at their hometown or elsewhere with the coverage of antibiotics, paracetamol, nebulization, and decongestants completely throughout their cycle. These kids may be anemic, so blood transfusions are required, and with the further neutropenia, granulocyte colony-stimulating factor injections have to be given. For thrombocytopenia correction, platelets have to be given. And then coming to the examination under anesthesia, even this part was dealt very well by the previous speaker. Here, for this retinoblastoma, we know that these kids are like they are not cooperative for other sedative pre-medication, so they have to be taken in under the inhalational induction only. And securing IV access is the most important part. In our hospital, after complete induction of the child with oxygen, nitrous oxide, and sevoflurane, the patient will be connected to the monitor and check for the central placement of the eyeball, because this is the most important and factor for the examination under eyes. And then placement of the supraglottic airway and fixation of the tube. Securing of the IOE line through the vein finder is the most important part. And then in detailed examination of the child, this examination under EVA room will take minimum of 15 to 30 minutes, wherein set of investigations will be done, like red cam will be done, IOP measurement will be done, and other general examinations will be done. And apart from the tumor, in per se, central tumor and the periphery tumor and the anterior segment of the tumor will be examined. It will take a minimum of 15 to 30 minutes. Apart from that, the decision management also will be taken up there itself. The management of the retinoblastoma will be done like initial first phase will be chemo reduction or chemotherapy, and then allied with the chemotherapy will be focal therapies, which includes cryotherapy, transpupillary thermotherapy, intravitreal chemotherapy, intracameral chemotherapy, periocular chemotherapy, and intrathecal chemotherapy. All these things will be done in the EVA room itself, then and there. The radiation therapy, including EBRT and plaque brachytherapy, will be done in the main OR. Enucleation, exentration also will be managed accordingly. So coming to the chemotherapy, there is a strict 3-drug CEV protocol all over the world. It is managed for the retinoblastoma, and which includes vincristine, etoposide, and carboplatin. These chemotherapy cycles will be for 6 to 9 cycles and minimum gap of 1 month or 28 days. Enucleation, coming to the enucleation, whenever we see that the chemotherapy is not successful, then the child will be progressed for the enucleation, advice for the enucleation. Enucleation is a process of removal of eyeball with retinoblastoma. Here, the common anesthesia management will be in the general and same with the inhalational induction and muscle relaxation with the endotracheal placement. This enucleation process also will take a minimum of 1.5 to 2 hours, depending on the surgery and depending on the surgeon. And the multimodal analgesia management should be enhanced. Hypotensive anesthesia for minimal blood loss to be given. Watch for the OCR, oculocardiac reflex, in between in the surgery. And the smooth and unhurried extubation is required. And other thing, which is the most common challenge what we face as an anesthesiologist per se with retinoblastoma, is orbital retinoblastoma or extraocular retinoblastoma, which is which comes around 20 to 50% of the developing countries. This tumor extensively metastasized to the lungs, CNS, and bones. And this extraocular tumor in this child, it has eaten up the entire eye and the orbit, and it is protruding out. We have seen maggots also in these particular cases. So this treatment plan will be enucleation or exentration with adjunctive chemotherapy along with radiation therapy. in these kids, the mask ventilation will be very difficult to attain. So for this process, the anesthesia management will be entirely different. And we know that exentration is a process of removal of the entire eye. It's a demutilating surgery where the entire eye contents along with the tumor will be scooped out. For this, what we know that already the child is immunocompromised because of the chemotherapy and the systemic metastasis. So this kit has to be optimized before taking up for surgery with blood transfusion, antibiotics, and seizure prophylaxis. Reserve the blood, procure the blood before surgery is most important thing. Mask ventilation will be very difficult, as I said, because of the proptosis. Plan with rapid sequence intubation with 100% oxygen, with nasal ports of oxygen, and then hypertensive anesthesia has to be planned with multimodal analgesia. Placement of throat pack is essential, as this tumor, which is there in the orbital cavity, can extend to the sinuses also. So we have to explore and remove the entire cavity of the sinus. For that, throat pack is to be kept in the throat cavity. Throat pack has to be kept, and this throat pack has to be removed even after the surgery. And extubation should be in the deeper planes only. Another mode of treatment, what is required for the retinoblastoma is placement of the radioactive implant on the sclera corresponding to the base of the tumor, which is commonly used ruthenium-106. Ruthenium-106 is the plaque brachytherapy made here. Now we get the ruthenium-106 plaque from the BARC, Bombay. And indications for the tumors will be like less than 16 mm in the basal diameter and less than 6 mm thickness of the tumor. The duration of the plaque will be like around 36 to 72 hours, and the tumor and the gray will be like 4,000 to 5,000 centigrade units will be used for the dose. Plaque is sutured to the sclera, and even after placement of the plaque brachytherapy, the child will be there in the hospital for 36 to 72 hours, and even the removal of the plaque brachytherapy will also be under general anesthesia. Then coming to the another mode of treatment for the retinoblastoma, which is intra-arterial chemotherapy, or called as selective chemoreduction therapy, which is the same procedure as done in the cath lab elsewhere, but it is done under the supervision of interventional neuroradiologist, oncologist, and anesthesiologist in the cath lab. Here, the induction will be inhalational or with sevoflurane or IV propofol. Intubation will be with the muzzle relaxant. Endotracheal tube has to be placed, and ventilation, pressure control ventilation is ideal for this one. Here in this, there is a pre-medication. Along with the normal pre-medication, we have to give ipsilateral nasal decongestants of oxymetazoline 0.5% in the ipsilateral nose to bypass the cross circulation of the drug what we are giving through the catheter. So after induced, radiologist will cannulate the femoral arteries, catheterize, and then the catheter is passed to the ophthalmic artery. This is the diagrammatic representation how it looks. Intra-arterial chemotherapy. From the femoral artery, common carotid artery, internal carotid artery, and then the drug will goes to the internal ostium, and then it goes to the ophthalmic artery branch, where here for a minimum of 30 to 45 minutes, each drug will be given as an infusion. The drugs will be melphalan or topotecan. This is a picture of a cath lab where intra-arterial chemotherapy has been given in our allied center. The most common complications arising with the intra-arterial chemotherapy is like, the first common complication will be ophthalmic artery spasm. For this, we have to stop the surgery and wait for the spasm to be relieved, or else we have to try for other modalities of the anastomosis, where we can bring down the catheter and pass the catheter from the external carotid artery. The next complication will be like OCR attributed. I will be dealing it a bit later. Another thing will be like allergic manifestations, seizures, stroke, and femoral artery thrombosis. Coming to this characteristic complication, which is most commonly seen with the intra-arterial chemotherapy, is with the OCR, what we see is a sudden drop in saturation, sudden drop in heart rate, and then it leads to hypotension, hypoxia, and the next with common features. But here, what we see here is whenever the catheter is introduced into the internal ostium, it start, we see a sudden decrease of EtCO2 for a minimum of 10 to 15 millimeters of mercury because of the decreased lung compliance. This is the characteristic feature which is seen in the intra-arterial chemotherapy, and which is not related to the drug or anything. This is most commonly because of the catheter. Whenever we see that there is a decrease in the EtCO2, there will be sudden decrease in SpO2, which drastically falls below 90% to 80%. Then stop manipulation of the surgery, stop manipulation of the catheter, put on 100% oxygen, and pressure control ventilation has to be given. But this cycle, definitely it lasts for 15 to 30 minutes, but slowly SpO2 increases, and never we have seen any eventuality like death on the IAC table. But these things are to be discussed elaborately. We don't know what is causing this one, but we commonly feel that because of the literature and literature, that is, it is one of the commonest complication of oculocardiac reflex only, and it's not attributed to any allergic reaction. Another thing, what we can do with the retinoblastoma management will be intrathecal chemotherapy. Even intrathecal chemotherapy, because we, the anesthetists, are only better person who can do the lumbar punctures and other invasive procedures with respective to the airway management and other treatments. So children with these tumors, which are extensively, the tumor has spread to the brain, so they have to be optimized with normal LFT and CBP. That's what we have checked. We have to check for a normal lumbar puncture. Under strict aseptic precautions, after induction and under strict aseptic precaution, lumbar puncture is done with 26 case cannula in L4, L5 space. And after clear aspiration of CSF around 2 ml, that is for cytochemical analysis, and then injection methotrexate, single drug or 2 drug with the steroids can be given as a treatment, slow infusion. Bone marrow aspiration is also performed under anesthesia only. What are the common challenges what we see with the anesthesia part giving for the retinoblastoma management? That is the most common complication, the most common thing what we see is the optimization of the child, preparation for the surgery. This is the most common challenge what we face, because the child comes with the frequent URI, frequent loss to follow-up, and these things. So we have to optimize the child before taking up the child, because the risk weight benefit ratio will be like more towards taking up the surgery or examination anesthesia. That's that, because the chemotherapy has to be successful. And then the most other challenges will be oculocardiac reflexes, which have been already dealt, laryngospasm, frequent URI, and difficult airway because of the presence of the tumor with the proptosis. Another thing is COVID-19. The laryngospasm is another common complication what we see during examination or anesthesia or the surgery in the kids, because of exaggeration of the, it is an exaggeration protective reflex that prevents aspiration of foreign objects into the lower airway, leading to the partial or complete occlusion of the glottis. This the management will be like IV magnesium, lidocaine, propofol, or succinylcholine, or the physical manuals like complete positive pressure ventilation with 100% oxygen, Larson's maneuver, or gentle chest compression. We know that Larson's maneuver, which is commonly we do whenever we feel a difficult airway, whenever we see a stridor inside in the patient, the pressure over the laryngospasm notch, that is the notch in between the mastoid process posterior and the anteriorly mandibular condyle, along with the jaw thrust. So this is the procedure. This is the position where we give the jaw thrust, called as Larson maneuver. Usually completely it changes from the complete laryngospasm to the partial laryngospasm. So this is an algorithm where we can check for the laryngospasm treatment. So initially, so whenever we see a inspiratory stridor during induction or at the time of extubation, raise an alarm. Apply CPAP with 100% oxygen, apply jaw thrust, and then check for his air entry. If the air entry is fine, then it is a partial laryngospasm. Wait for it, or wait for some time with complete oxygen, 100% oxygen. It will be relieved in few minutes, or else stabilize the patient with the propofol and induce, and then intubate, and then wait for some time for the laryngospasm to relieve. If it is a complete laryngospasm and no improvement, IV access has to be regained, and attempts to ventilate with 100% oxygen, reassess the air entry again. If no improvement, call for help, initiate CPR. And other common associated factors, what we see with the EUA children or retinoblastoma children is coming with the URI symptoms. Here, the risk-benefit ratio has to be assessed correctly to whether to post the case or cancel the case. So here we have made some few steps where we deal with in our center. If we find a severe mucopurulent nasal discharge, productive cough or fever, and if the child is lethargic and if he has a conductive sounds, then definitely we will cancel or reschedule for a period of 4 to 6 weeks. But if the child is fine and activity levels are okay, but he has a mild URI, like with only running nose and lungs are clear, then we go ahead with EUA and surgery. Coming to the another precautions in this pandemic zone, that is COVID-19, what in the EUA room or in the surgery room, respective of 25 to 50 EUAs, which we do a day particularly. So we do it very particularly, like meticulous way. That is with minimize the mask ventilation with snugly fitting mask and slow tidal volumes, and usage of HEPA filter both at one at the patient and another at the expiratory limb and the anesthesia machine, and limit the disposable supraglottic airways rather than the reusable supraglottic airways, and the seal should be adequate. Priming of the breathing circuit. This is the another thing what we have developed. The priming of the breathing circuit. This is how breathing circuit will be primed with 1 liter of 1 liter of oxygen, 2 liters of nitrous oxide, along with 8% of sevoflurane, completely occluding the other end of the breathing circuit for 1 or 2 minutes. Then the entire breathing circuit will be primed with the sevoflurane gas, and then bringing up the child and directly putting the mask on the face of the child. Immediately through this process, we have seen that in a matter of 15 to 30 seconds, the child will be induced with priming of breathing circuit. And other precautions to be taken for the COVID-19 will be the minimization of the people, OT personnel, limit the OT personnel people. Antiemetics is the other part where we are considering and we are giving for the patients, and patients should be reviewed, induced, recovered within the OR itself to restrict the contamination to one room. To summarize, we know that in the developing countries, the early identification of the tumor is the most important thing. So retinoblastoma is found to be most common malignant tumor, which the survival rate is very less if it is not well dealt. So early identification and treatment with salvage eye vision and life saving. Optimization of the child is very crucial. Proper counseling of the parents not to skip the follow-up and visits and vigilant with the complications. Informed consent, good clinical judgment, and experience are the very crucial factors in the decision-making process, whether the child to be taken him for anesthesia or not, and to help the child with the salvage the vision. A few references. Thank you.
Thank you so much, sir. Now on to our last topic for the evening. Dr. Sonali Raman from Shankranetralaya to talk about anesthesia for modified osteoodontokeratoprosthesis.
Dr. Anil?
Yeah.
Can you unshare?
Let's stop, ma'am.
Okay, fine.
Yeah.
Until the slides get ready, can I ask one question to Dr. Anil? Anil, it was a really nice presentation. Just I wanted to know, are you giving intra-arterial chemotherapy in the institute, in your institute?
No, sir, we are not giving the intra-arterial chemotherapy in our institute, sir. We are sending it to the different center where we are going.
So you say that the cardiologist should also be there while that procedure is going on. Am I correct?
No, sir. Actually, the team involved there are like interventional radiologists, oncologists, anesthesiologists, and the oculoplasty fellows. That's it.
Okay. So you go to that place or any other anesthetist come there? Just
No,
for my interest.
we go there, sir, for the cath lab.
Okay. Okay. Then. Thank you.
Yeah. Thank you.
Is my screen visible?
Yes, yeah, ma'am, your screen is visible, but
Yeah, fine. So
it's very small. Hello?
Pardon?
Yes, ma'am, it's very small.
One sec.
Can you just open the
Small.
Go to the another slide and then see.
No, this is actually the structure of slide is like that.
Okay.
So when Bible say in New Testament that an eye for an eye and a tooth for a tooth, in modified osteoodontokeratoprosthesis, we say tooth for an eye. So good afternoon, everyone. So here we are, the last talk of our first virtual meet. I want to thank Dr. Giridhar, Dr. Pushpa for organizing and inviting. Hello.
I'm sorry, ma'am, interruption, but ma'am, your screen is visible, but it's very small.
It's
Ma'am, can
small.
you please reshare?
Just one sec, I will check. Screen is very small coming. Just one sec.
Ma'am, can you please reshare?
Yeah, I will do that.
Yeah, this is fine.
Is this fine?
Yeah.
Yes.
Play the slideshow.
Now?
This is okay.
Yes, ma'am.
This is fine, ma'am.
Right. Modified osteodontokeratoprosthesis is the procedure of choice for restoring sight in patients with corneal blindness caused due to end-stage ocular surface diseases not amenable to penetrating keratoplasty, but having intact retina for visual improvement. So the name itself suggests we use tooth lamina as a keratoprosthesis. OKP was pioneered by Professor Strampelli in Italy, later modified by Professor Falcinelli, and his association with Shankar Netralia is almost 2 decades old. MOOKP at Shankar Netralia is incomplete without mentioning Dr. G. Sita Lakshmi. She was the one whose tireless efforts went into learning and adapting the procedure, and she became the first woman in the world to perform this procedure. And I proudly say that 70% of MOOKP at our center is done free of cost. We analyzed 74 MOOKP patients done between January 2007 and January 2015, and we looked into anesthesia-related challenges. The result of these I will be sharing today. It is indicated for all the reasons which causes end-stage ocular surface diseases like Stevens-Johnson, chemical burn, and so on. But it is absolutely contraindicated below 17 years, thiatrical eyes, and eyes with no perception of light. Our patients were in the early 30s and late 20s, and they had fewer systemic comorbidities because they were young. And more than half patients were Stevens-Johnson syndrome, and about one-third patients were chemical burn patient. MOOKP is usually done at 3 stages routinely. The stage 1A, which consists of removal of keratinized surface from cornea, removal of lens, iris, and anterior vitrectomy is performed, and with cornea transplant if indicated. Later on, this technique at our center was modified by bone augmentation. In that, they augment the chosen tooth bone by the bone graft which was taken from the lower jaw. This led to the modification in our technique of anesthesia. Initially, for stage 1A, we were intubating the patient orally. Because of this modification, we started intubating them nasally. Stage 1B, 1C is performed simultaneously. In that, the buccal mucosa is taken and implanted over the eye, and osteoodontolamina is formed from a tooth which is fitted with an optical cylinder that acts as a lens, and this complete osteodontal lamina is then placed in the contralateral cheek. The tooth with the largest available root is chosen, mostly upper canine, lower canine, upper incisor, in descending order of preference. Stage 2 is performed 3 months later. Here, the lamina is explanted from a subcutaneous storage space. The mucosal graft is partially reflected. The lamina is retrieved from its pocket. A hole is made in the center of cornea and suture to the lamina is inserted and suture to the cornea and sclera. And in a final step, buccal mucosa is placed again over cornea. Pre-operative assessment is a multidisciplinary approach in MOKP patient. In case of Stevens-Johnson syndrome, a careful history, drug history is very, very important. It is very important to identify the precipitating drug so we can avoid that. Careful assessment of mucosal erosion and skin lesion is very, very important because it can make the application of monitor difficult, peripheral IV cannulation difficult. Multi-system involvement in Stevens-Johnson syndrome require careful cardiac and respiratory assessment preoperatively. We might need to order extra battery of investigation to rule out the same. Pre-op medication like immunosuppressant and steroid should be continued in the perioperative period. Chemical burn causes lot of contracture and scarring, so which can make the difficult intubation. So airway assessment is very, very important. Patency of nostril is very important. And in case of peripheral burn, the peripheral vein assessment is very, very important. Informing the patient and attendant about the known or suspected difficult airway is must, and the high-risk consent should be taken for the same. If you are planning awake fiber optic intubation, then patient should be informed about the procedure in detail, and what we expect from him during the procedure should be explained in detail for good cooperation. Mallampatti grading can change between the stages, especially when we harvest the buccal mucosa, which can lead to contracture, scarring, and restriction of mouth opening. So careful re-evaluation of airway in between stages is very, very important. Most of these patients are anxious and depressed. They need very good counseling and should be well informed about multiple surgeries, long-term follow-up, complication involved, and the final cosmetic appearance. Anesthesia challenges we can face either due to patient-associated condition like Stevens-Johnson syndrome, burn, etc., or it can be related to surgical procedure itself. In patient-associated condition like Stevens-Johnson syndrome, if the lesions are fresh, extreme care should be taken while handling and transferring the patient. IV cannulation and fixation is becomes difficult, and we have to take care during fixing the cannula. Application of monitor may become difficult. Careful and gentle application of face mask, laryngoscopy, intubation, gentle suctioning with extra lubrication is important. Special care is required to prevent injury to oropharynx and larynx while airway management. Temperature needs to be maintained as these patients are very prone for the Raynaud's phenomena. Judicious and cautious use of drug in the perioperative period. Burn, contracture, and scarring can lead to difficult airway. Peripheral burns can cause difficult IV cannulation. So the patient with burn contracture is a challenge to an anesthesiologist. Anesthesiologist should have a pre-planned strategy for intubation of difficult airway. The basic preparation for difficult airway is availability of all equipment for management of a difficult airway. Have one more anesthesiologist next to you while starting the case. Pre-oxygenation by mask is must, and administration of supplemental oxygen throughout the process of difficult airway management is very important. The devices which we have to manage difficult airway is intubating LMA, intubation without muscle relaxant, intubation with muscle relaxant after trial scopy. In case of moderate to severe difficult airway, the safest approach is awake fiber optic intubation. The key for the successful awake fiber optic intubation is patient should be well informed about the procedure and meticulous preparation of patient. In our study, we had difficulty in intubating 8 patients. Among them, 6 had chemical burn, burn-induced contracture and scarring. 1 patient had awake fiber optic intubation in all stages due to restricted mouth opening, and 1B, 1C, which require nasal intubation. 4 patients we could not intubate because of loss of patency of nostril due to burn. Anesthesia challenges due to surgical procedure itself. As I have told that stage 1A at our center got modified. So 71 patients we intubated orally and 4 patients done by nasal intubation. Stage 1B, 1C, which require nasal intubation, but the most important challenge for this procedure was fixation of tube. We innovated a novel technique of tube fixation in which the north polar or the flexometallic tube was chosen. The tube followed the contour of the nasal bridge, as you can see in the picture. It was brought on the forehead. Here it was fixed with the tape, and with the help of L-shaped connector, the circuit was brought to the side of the patient. So other studies says that they changed the site of tube fixation intraoperatively. This was avoided by our novel approach of tube fixation. The mean duration of surgery was highest in stage 1B and 1C in our study. It was 5.2 hours. Stage 1B, as I already told, the 4 patients we could not intubate nasally because of the loss of patency of nostrils due to burn. Stage 2, Mallam patti grading can change from stage 1 to stage 2. So it was important to re-evaluate the airway as difficulty may increase in between the stages. And care should be taken to avoid any pressure by the mask over the prosthesis implantation site. Challenges which were common to all stages, as we know, the globe was open in all the stages. It was an open sky situation. So prevent any rise in intravitreal pressure, avoid bucking on endotracheal tube, keep the patient in deep plane. A smooth extubation was desirable. So either we extubated the patient deep or we used lignocaine 1 to 1.5 milligram per kg, 1 to 2 minutes prior to extubation. Prevention of hypothermia is important. In the post-op period, good antiemetic to prevent the nausea and vomiting, cautious and judicious use of analgesic in Stevens-Johnson syndrome patient. So patients of OKP, you can have problem due to patient-associated condition, multiple surgeries, airway management as we are sharing the airway, difficult airway, drug implication in Stevens-Johnson syndrome, prolonged surgery, open sky situation, and psychological consideration. So, however, a good pre-op evaluation and intra-op anesthesia plan before each stage could help in successful administration of anesthesia in these patients. Thank you.
Thank you so much, madam. Now I would like to hand over to our Secretary of AIOA, Dr. Jay, sir. Sir?
No, any discussion is left? Any points? Dr. Kannan, you would like to wind up this session? So I think we'll wind it off then.
Okay, sir.
Okay. So I would like to thank all the speakers who have participated in the first National AIOA conference. And I would like to thank Dr. Pushpa Susan, Dr. Giridhar A, and the entire organizing team for arranging such a wonderful, nice conference for us. I know it is a very hectic schedule, but in spite of all this, we were able to make it a grand success. I think we should all give a big round of applause to Dr. Pushpa. Thank you, Dr. Pushpa and the entire team. It was a wonderful show.
Thank you, Jay.
I hope we will all be meeting physically at the next AIOA conference at Madurai, September 2022. Over to Dr. Pushpa. You would like to add on anything?
Yes, Dr. Jay, thank you so much. And thank you everybody, everyone who joined in today. Actually, it was quite heartening to see 181 people had logged in and registered in the morning. It was actually much, much better than what a physical conference would have been, because I don't think we've ever gone beyond 50 people or maximum 60 people at any of our physical conferences in ophthalmic anesthesia. Right. Anyway, we are doing good. And
thank you.
Yes. And thank you. I would like to thank Dr. Giridhar, our MD, for being the driving force behind us and encouraging me and my team to do something. He keeps telling you should do something, people should know about you. Well, I'm not the kind who likes to make a noise about what I'm doing, but then in my small way, I do occasionally make some noise. So, well, I think I've made some noise this time. Thank you. And I would like to thank our hospital IT team who have done a lot of groundwork for me and who have been supporting me through the day to day. They are around, the boys are around and in working in their own silent way. Thank you so much. And a big thank you to Sarjan from Sun Pharmaceuticals and his IT team for giving the Zoom platform and maintaining decorum and helping us to host and conduct this webinar beautifully. And a big thank you to Dr. Sumana, my new colleague. Actually, she's new in this ophthalmic anesthesia field, and actually she's been with us only since 9 months. And I thought she would do an excellent job as an MC, and she hasn't failed me. So thank you very much, Sumana, for being with me. And a big thank you to all my colleagues in the hospital who have supported me throughout this venture. Thank you very much.
Thank you all. I think we'll wind up the meeting. Thank you, Doctor. And thank you, Mr. Sarjan. It was a wonderful show. Thank
To
you.
meet virtually also.
Just a group photo I will take. I will take a group photo. Please. Yeah. This is how a virtual group photo has been taken.
Bye.
I think Sumana has joined. Yes. Thank you, Dr. Sumana. Bye.
Thank you,
Bye.
sir. Thank you. Bye.
Take care.
Bye.
Thank you.
Bye, sir.
Bye.
Bye.
Thank you. Bye.
Thank you, sir. So, sir, I'm ending the meeting.
Roshni?
Yes, ma'am.
We are winding up, okay?
Yes.
Thank you.
Thank you, everyone. Did the best. Finished in time.
Thank you.